Morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have several bills this morning, today, to be heard in public hearing. But before we get to those, I'd like you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill to be considered today is House Bill 392 FN, and Representative Belcher is the prime sponsor. He's already in place. Welcome, Representative Belcher.
Good morning, Mr. Chairman and members of the committee. I'm happy to be with you here this morning. For the record, Representative Mike Belcher, Wakefield, Carroll County District 4. I've brought you this bill this morning seeking to dissolve several offices and divisions within the executive department. First, these programs ought to be considered both unlawful and unconstitutional, as they represent affirmative discrimination by government based on various mostly immutable characteristics. It was these programs during COVID that promulgated policies that withheld scarce medical resources based on skin color. It was these offices that advanced concepts such as the social determinants of health that are designed to incorporate political activism into healthcare based on the premise that the political environment can affect health. It is these offices that seek to shutter politically disfavored industry and energy resources based on the legal magic of disparate impact, and have thereby endangered the stability of our electrical grid and driven prices up. Broadly, these concepts represent a purposeful attempt to flip perceived hierarchies by elevating the marginal and punishing the privileged. In other words, it divides everyone as supposedly oppressor or oppressed. Departing from the American Constitution, they lean on the social analysis of Karl Marx and Jean-Jacques Rousseau to justify this evil. As such, departing from the American concept of justice as both impartial and individual, they rather impose penalties based on not individual actions, but on identity characteristics. The concepts of DEI, equity, and social justice is derived from the new school of Marxist analysis known as the Frankfurt School, famously existing at Columbia University. These concepts found their way into American law and jurisprudence largely via Harvard University. Critical legal studies under Derek Bell in the 1980s gave way to critical race theory under his student Kimberly Crenshaw a couple decades later, with her supposedly groundbreaking Marxist analysis in mapping the margins. In reality, it was little more than what was already being done by the Comintern almost a century earlier. Thankfully, these concepts have now been roundly rejected by the American people and the citizens of New Hampshire at the ballot box. We were put in this position to definitively end these discriminatory, punitive, and divisive programs. When I filed this bill, it was still a bit of a mystery as to what position we would be in at this moment. I'm happy to now report that the position I staked out in this bill is now reflected in federal policy of the executive. Now, contrary to any suggestions that we might lose federal funding if we were to move forward with eliminating these offices, on the contrary, we're far more liable to lose federal funding if we do not. The federal executive has issued a series of executive orders, some of which I have passed out as handouts, to remove root and branch all aspects of DEI, including environmental justice practices, from the federal government. The federal government, the federal executive, has declared these programs to be discriminatory and unlawful. Now, when the federal executive makes a declaration like that, they're not merely opining. What they're saying is that a failure to abide by their declarations may result in enforcement actions, including under the Civil Rights Act, which would open this state up to lawsuits. As far as the necessity of having enforcement of civil rights, which I don't dispute, that exists in our Department of Justice where it belongs, not in any other department where it is being used to smuggle social justice into policy and go around this legislature. We must act. It is good and righteous to act now. The people demand it and our oaths demand it. Thank you. I would be happy to take questions.
Thank you. Questions for Representative Belcher? Representative McLean?
Thank you, Mr. Chair, and thank you for taking my question. A lot of us here on this committee were Health and Human Services, so we may not be familiar with some of the departments. I know I'm not, for example, familiar with the Department of Environmental Services, functions for civil rights and environmental justice. That's kind of outside of the purview of this department. So could you, I was unaware that even existed. Could you describe what that is and what these functions are in terms of environmental justice? Thank you.
Yes, thank you for that question. It's a very good question. So, environmental justice is quite similar to any of the other sort of fad terms justice that you've heard thrown around in recent years, in that it doesn't mean American impartial individual justice. What it means is social justice applied to a certain field of policy. So what they've done is they've applied social justice to the field of environmental policy. And what has happened is through a series of less than stellar older judicial precedents, such as disparate impact, they've managed to say that any industry or energy resource or anything of the sort that can be argued to have a disproportionate effect on one group versus another group can result in civil enforcement actions and be shut down under the auspices of environmental justice. So simply put, what that means is if there's a power plant that is producing some kind of environmental pollution, even if it's well mitigated, only a small amount, if it can be found that, for instance, a power plant might be found in an area that is disproportionately of lower income, well, because that disproportionately affects people of lower income, it can be said to be discriminatory, and therefore they can use it as a cudgel to shut that industry down. And it's been used that way by the executive branch for the last several years.
Other questions? Oh, Representative Mazur.
Thank you, Mr. Chair. Thank you for being here today and taking my question. I see the last sentence in the description of it as dissolving the Governor's Council on Diversity and Inclusion. Am I correct in thinking that saying that he did dissolve that on his way out of the end of his term?
Yes, thank you for the question. It's my understanding that advisory council no longer exists. However, the bill does go on to say that reestablishment of such advisory council is prohibited under this bill if it were to pass. So it's still relevant in terms of going forward. Thank you.
Thank you.
Other questions? I'm seeing none. Thank you. Oh, Mark, you got to raise your hand, we'll wave it or something.
Sorry, Mr. Chair. And thank you for taking my question. So you talked a little bit about the legal jeopardy. We do see certain private businesses, Walmart, Facebook, and even universities moving away from some of these programs. In many cases, the universities, I think, actually favor and would like to go on with these, but they do see some potential legal jeopardy. But are you aware of any specific incidents where this legal jeopardy has manifested itself, or is it just the threat at this point?
Thank you for the question. I don't have the citations off the top of my head, but yes, there have been in recent years a number of judicial precedents set. I don't think any of them have gone to SCOTUS yet, but there have been at least lower and appeals court precedents set, finding that the policies of DEI, DEIJ have been found to be violative of the Civil Rights Act because they are not based on the idea of individual impartial justice. They're based on the idea of purposefully discriminating against somebody who's perceived to have more privilege than somebody else.
Follow-up?
So if you don't have those specific references in front of you, would it be possible for you to, after the fact, provide those to the committee?
Absolutely. I'll find some examples to send you.
Thank you.
Representative Woods?
Thank you, Mr. Chair, and thank you for taking my question. Help me out. I guess I need clarification on, in Section 1, the governor hereby directed to dissolve the council and is prohibited from reestablishing. Is it the purview of the legislature to tell the governor what he can and can't do regarding council?
Thank you. And that is a very good question. And at the end of the day, like most other things, the courts would have to step in if there was a dispute to look at that issue. However, generally speaking, it is the job of this legislature to direct the executive in what to do. And on the basic principle that this commission, I believe it was called, was established to create and promulgate policy based on equity, justice, and inclusion, and that those policies themselves go against the Constitution, the Civil Rights Act, and our oath of office, they ought not be reestablished. And I believe we do have the authority to dictate that, yes.
Other questions? Representative Lamontagne?
Thank you, Mr. Chair, and thank you for taking my question. Why do you believe some of these programs were set up to begin with?
Thank you for the question. So I went a little bit into the history of it. These programs were largely established based on the precedents set by critical legal theory, which is an idea that came from Derek Bell at Harvard University, not on his own. It was a follow-up of sort of the work that had been done at the Frankfurt School to normalize within American jurisprudence the concept that we ought not treat people always as individuals, but sometimes we should treat them as groups according to their identity. This made their way into American jurisprudence, and many lawyers have been trained along these lines in time since. So it was a long, slow process to move these concepts from their ideological foundations in Columbia University and other places in America through Harvard, through the legal system, through the education and training of lawyers and judges. It's been a very long process. Thank you.
Can I have a follow-up?
Follow-up?
But you don't have any actual evidence that people that helped bring these programs about were actually Marxist, and these programs weren't actually based on empirical evidence showing disparities of health and environmental outcomes?
Thank you. I think I can find the question there. It was, so I can, along with the judicial precedents that I'll find for you later, I can find for you the name of the book, because I don't remember the top of my head. It was something along the lines of An Introduction to Critical Legal Theory. It was a textbook that was utilized at Harvard and has been utilized by many others since, that identified, in fact, that Derek Bell, Kimberly Crenshaw, and the others who promulgated these ideas and moved them out from the academic sphere into the governmental sphere and into policy, identified themselves, self-identified as Marxists.
Other questions? Representative Nagel and then Representative McKay.
Thank you, Mr. Chairman. Thanks for taking my question. I've been working with people, vulnerable populations, patients for a really long time. I think more pragmatically than theoretically. And I just wanted to read this to you.
Do you have a question?
Yes, I do.
Okay.
The question's coming from what I read.
Okay.
So if you look at the DHHS's website, it talks about the Office of Health Equity that I believe would be eliminated if this bill passes. It says they ensure equitable access to effective quality programs and services across all populations with specialized focus on breaking down barriers to care for vulnerable New Hampshire residents. In my experience, that's a really important function, and I'm just curious, if that goes away, how do we replace that?
Thank you for the question. I believe the key word there was the very first word that was in that statement: equitable access. It is not equal access. It is not access that looks determinately at who has the greatest need. Equity, by definition, looks at people based on identity characteristics, not based upon need, which is the same reason that these offices promulgated the idea during COVID-19 that withheld scarce resources on the basis of skin color, not based on need.
All set?
I know, but I'll stop there.
Representative McKay.
Thank you, Mr. Chairman. The first part of this legislation is not needed, which you know. The second part says we can never do it again. I find that peculiar, that telling the legislature what we can't do. Most legislation tells us what we can do.
Actually, do you have a question, Representative McKay?
Do you believe that that is an appropriate use of legislation?
Thank you for that question. And just to be clear, I do not believe it does that at all. That's actually a misreading of that. This tells the executive branch what it can and cannot do in the future. It does not in any way bind this legislature, which we ought to know according to our own rules and precedent. We can't pass anything that binds future legislatures. So they could undo this if they wanted to down the road. That would be up to them in passing further legislation.
Thank you.
Other questions? Representative Markell.
Thank you for taking my question. Earlier, sir, you mentioned that this is unconstitutional. Did I hear that correctly? That, in other words, what's presently going on is unconstitutional. Did I hear that correctly?
Yes, I believe the policies themselves to be unconstitutional.
Okay, but this is, you would agree, would you not, that this is basically health regulation? Do I have that correct? Health and safety regulation?
I would say it goes a lot deeper than that. It goes to a basic concept of what justice is and what justice is under the Constitution versus what justice is under a paradigm of social justice.
Okay, but not necessarily social justice, but we're here in front, may I?
Follow up.
Thank
Go
you.
ahead.
Thank you. So my concern is that I think you suggested that this is unconstitutional. Is that based on a strict scrutiny analysis?
I wouldn't say it's based on a strict scrutiny analysis because I'm not trying to take into account government extreme need to regulate versus the unique and very narrow tailoring of law. This is a more fundamental principle. Actually, strict scrutiny isn't actually a constitutional principle. It's a legal principle based on judicial precedent. So no, it's not based on strict that analysis. It's based on the concept that you can find in the Constitution, for instance, that, the same idea that requires us to give somebody a trial by jury is the concept that they are liable only for their own actions. And the people of that they're a part of the community with are the ones who will ultimately judge them in that. Social justice takes a very different tact, and it suggests that people will be judged not necessarily by trial by jury, but trial by media, trial in the public sphere, where they are presumed guilty instead of being presumed innocent based on their identity characteristics, not their actions.
Okay. Follow up, may I? sir?
Follow up.
Thank you. Okay, but you would agree that this is basically health and safety regulations on its face?
I would agree that it touches on that, but it's a much broader and higher principle than that.
Okay, so I'm thinking that this would, because you mentioned earlier that it was unconstitutional, and I'm thinking that if this is health and safety regulation, it basically gets rational basis review, which means all it has to do is be legitimately related to a rational government objective. And that's basically the standard of review which allowed Dobbs to be able to be carried the way it was. And I'm suggesting that it probably is constitutional. You may have different arguments with it.
We can cover that in executive session,
Oh,
Representative.
okay. Thank you. No further questions.
Representative Tellez.
Thank you, Mr. Chairman, and thank you for taking my question. So you mentioned that the existence of the Office of Health Equity and the other two entities is discriminatory. So do you have any evidence of that discrimination here in New Hampshire?
Yes, I can point to the policies that were promulgated during COVID that specifically took a certain amount of vaccine when it was early available, new rollout was not available for everyone yet, and withheld a certain amount of that, not based on need, not based on the fact that we know elderly were most vulnerable. So perhaps it should have gone entirely to elderly, but it withheld, I believe it was 10% at the time, specifically on the basis of skin color. We also had that same thing happen with the antibodies that were available at certain hospitals for a brief period of time.
Follow-up?
Follow-up.
So the Office of the Ombudsman is who takes complaints from individuals of discrimination. So do you have any evidence of any individuals filing concerns about discrimination based on the existence of the Office of Health Equity, given that the example you cited of the vaccine distribution was actually held up twice in court?
I'm sorry, can you repeat what the question was there?
So the example you provided for discrimination was already thrown out by 2 lawsuits that were found to not have merit of being discrimination based on the vaccine policy that was rolled out. So I'm asking, do you have any evidence of discrimination and a need for this particular bill?
Thank you. I understand the question now. I would not look to judicial precedent to determine whether something is discriminatory or not. I would look to common sense to find that discriminatory. And I would say that we can adjust judicial precedent in this body by passing this law. Thank you.
One more follow-up.
Yeah. So are you aware of the concept of population health and the Institute for Healthcare Improvement basically being the world's leader for how health quality can be advanced? And they have said that there can be no quality if we do not address equity.
I'm not aware of that specific body, but I'm aware that these concepts that were promulgated based on Marxist social analysis have been broadly taken in the field. Yes.
Other questions? Representative Palazov.
Thank you, Mr. Chair, and thank you for taking my question. So you covered a lot how these programs are unconstitutional, but I wonder if you have any data on the effectiveness if we assume that the goal is to help those who are in need or certain demographics. So when we look at identity, like if we close energy plant in a poor neighborhood, does it actually help that poor neighborhood? Or if we target some ethnic or racial demographic and deliver them vaccines that are not stopping transmission, does it actually help them? So do these programs help?
Thank you for the question. So this is one of those situations where, despite the fact that there is clearly some need for regulation in the marketplace to make sure things don't go awry, in this circumstance, it would be much better if we just got out of the way, because we're actually requiring, through the policies promulgated from these offices, discrimination. We are requiring that people be treated unequally, not on the basis of need, but on other immutable characteristics such as skin color. Now, what you've referred to now within the, I'm sure you're probably all aware, within the concept of medicine and rationing of scarce resources, there will be circumstances where it is correct and good to withhold a scarce resource primarily for a person of one race or another, but it's not based on their race. It's based on their need that is correlated to their race. That's the difference. If there's a need, there's nothing preventing any of that from happening. But when you're doing it on the basis of race without taking need into account, because you're looking at it on the oppressor versus oppressed hierarchy and trying to flip that, that's what these programs do, and that's what we need to eliminate.
Representative Tellez, please remember that we're not here to debate, just get information.
Well, I'm just a little confused because can you share your definition of health equity? Because every definition I know is about providing what people need based on their individual circumstances, such as people with disabilities who may need a wheelchair, or people who are blind who may need Braille. The rest of us don't get it, but it's because we don't need it. So equity is about providing what people need. So please share your definition.
Thank you. What I would say about that is that it leaves out the fact that it interprets that need on the basis of group, not individual need. So it would look at a person of a certain skin color and say, because of historical circumstances or whatever else is going on, this group may have a greater need because they're underperforming in this area or whatever than this other group. And it will thereby treat everybody within that group under that paradigm instead of looking at them as individuals who have an individual need, which may or may not apply to that group paradigm.
Okay, we do need to move on. Any final questions? Seeing none. Thank you, Representative. Just for the everyone's information, the practice of this committee is to give the prime sponsor additional time for the purposes of explaining the background of the bill, why it was introduced, and so forth. But it is also the practice of this committee to ask that all those testifying keep their testimony to 3 minutes. That allows not only for others behind you a chance to testify, gives everybody an equal opportunity, and we do have quite a few people who do want to testify, but it also allows the committee members to have time for ample questions of you, and much of what you might not cover in your testimony, if you run out of time, could be covered in that manner. So please be respectful of the time constraints, and we will be timing testimony this morning. Next up to speak is Attorney John Williams and Associate Commissioner Ann Landry from the Department of Health and Human Services. Again, there's two of you, so it's 3 minutes, up to 3 minutes apiece. But you've asked for 3 to 5, so obviously the quicker you can make it, the better.
Okay. Thank you. Good morning, Chairman McDonald and members of the House Health and Human Services and Elderly Affairs Committee. My name is Ann Naughton Landry, and I am Associate Commissioner at the Department of Health and Human Services. And I'm here today with my colleague.
And for the record, my name is John Williams. I'm the Legislative Director for the Department of Health and Human Services, and we do appreciate the opportunity to come before this committee to provide information.
Yes, thank you. In addition to being the Associate Commissioner, I've overseen the Office of Health Equity for the last 5 years, and I appreciate the time this morning to share with you some very serious concerns regarding HB 392 as introduced, specifically sections 2, 4, and 5, and the negative health and financial implications to New Hampshire's residents, healthcare providers, local municipalities, and the states. And the state itself should the Office of Health Equity be dissolved. The vision of DHHS is optimal health and well-being for everyone. And the mission is to join communities and families in providing opportunities to achieve health and independence. Again, this is for all New Hampshire residents and citizens. The Office of Health Equity serves 3 primary functions in support of all of the department's program areas and divisions in eliminating barriers to access for direct and contracted health services to achieve this vision and mission. The 3 primary functions of OHE are ensuring compliance with communication access and disability federal and state laws, engaging with the department leadership and staff, as well as the community and providers to facilitate access to care for all residents, and overseeing the federally funded and mandated state refugee resettlement program. So I'll address each of those 3 buckets quickly in our time frame. And please jump in if you have anything. But OHE oversees the department's communication access services program for staff and any individual receiving services from the department. This ensures the state's deaf and hard of hearing, visually impaired, and those with limited English proficiency have full access to all of our services and related information. These are services that they're legally eligible for and deserve. The office ensures the department is compliant with the Civil Rights Act of 1965, Title VI American with Disabilities Act of 1990, Section 504 of the Rehabilitation Act of 1973, and RSA 521A-5, among others. The office also advises contract compliance for all of our provider partners on these federal and state laws, ensuring that their services are also accessible with all the communication access standards that they're required to abide by. The elimination of OHE would greatly jeopardize the department's ability to ensure access to all individuals requiring and receiving services. Not only would we have individuals with disabilities not getting the care they need, but also the department would be in violation of several federal and state laws, which would put the state at risk for countless lawsuits and financial penalties. Additionally, when residents are unable to access the care they need in a timely manner, it ultimately puts a strain on the hospitals and healthcare systems, leading to potential increases in emergency room wait times and in uncompensated care. This is for critical hospitals, this is for academic hospitals, this is for your large tertiary care centers and all community providers. The second point is that OHE serves as a key community ambassador and facilitator across the state in understanding all barriers to access for health and human services for all New Hampshire residents, and helps to strategize with community partners on how to best address these barriers. The leadership and staff of OHE receive outreach daily from constituents with complex health needs, both the clients and their providers from across the state who are struggling on how to navigate our healthcare system. The team helps with the immediate need of that individual or the provider advocating on behalf of that individual, but then also addresses the larger barrier to care by convening with the different community stakeholders and providers. The barriers to care addressed by OHE on a daily basis include transportation, communication access, again, for the deaf, hard of hearing, and visually impaired, housing, and connection to primary and substance use care for individuals who are re-entering our community after incarceration. Just one more minute. Often a requirement for release and important to reduce recidivism. The office minimizes costs of the healthcare system by helping key individuals, keeping them out of assisted living and in their homes by ensuring the right care at the right time in the right place at the right cost. Very critical to saving money in the state of New Hampshire.
You could start wrapping up, please.
Okay. The last part is, so eliminating this would disrupt the coordination of care across the state. And then the last piece is that we oversee the 100% federally funded refugee resettlement program, which moved into the Department of Health and Human Services from the Office of the Government in 2012. This is 100% federally funded. All these individuals are here legally, but the ability to integrate this program into the Office of Health Equity and DHHS allows us to have the fiduciary oversight of these federal funds, which allows for more effective and efficient use of these funds and allows us to help the refugees achieve economic independence and self-sufficiency earlier. If the office were to be dissolved, we will lose, this program would exist outside the state government. We will lose all control over these funds. And there would be a burden placed on the municipalities in which these refugees reside, which are primarily the major cities in New Hampshire. So just to wrap up, again, looking at communication access in compliance with federal and state laws, our ability to knock down all barriers of care for every single resident in the state of New Hampshire, and to continuing to help refugees achieve economic independence as soon as possible.
Thank you.
I'm happy to answer any questions.
Representative Polozov.
Thank you, Mr. Chair, and thank you for taking my question. Could you go back into history when your office was created, and like what parts of DHHS or other departments were helping with these functions before it was created?
The office was created in the late 90s, and over the last 26 years or so, different components of the office have been integrated into that office for better coordination and better functionality.
Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my question, and thank you for being here today. You mentioned the refugee resettlement services that you offer, and that if this were to go away in your department, what would happen? Are there not other organizations such as the International Institute of New Hampshire, Accentria, etc., that do somewhat of the same thing?
Thank you for your question. International Institution of New England and the Century are two resettlement agencies in the state of New Hampshire that are part of the federally approved refugee resettlement services. So we contract with them to deliver the services required by the federal government. If the Office of Refugee Resettlement was removed from DHHS or the state government, there would be a different organization outside state government that would administer those funds for the federal government. Whether it's one of those two resettlement agencies, I'm not sure, or if it would be a different entity that would be set up in the state of New Hampshire that would then contract with those two resettlement agencies.
Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I think the hot word in all this is that word equity. And I'm just curious. So in the state health assessment and implementation plan, we thought that word was so important that we spent 2 days discussing what it actually meant. And we came up with a working definition. And I'm curious if you have a working definition that defines what you mean when you use the term.
For the Office of Health Equity and for this, the Department of Health and Human Services, we really look at the word equity as addressing the health needs of every individual in the state of New Hampshire, ensuring that every New Hampshire resident has access to care, whatever that means for that individual.
Representative Kofalt.
Thank you, Mr. Chair, and thank you for taking my question. So following up on Representative Mazur's question, you indicated that if refugee resettlement program were eliminated within DHHS, then those services would likely be contracted with an outside agency. You also said that if that office were eliminated from DHHS, then we would have a problem in which cities and towns would be taking on the expenses and the burdens associated with refugee resettlement. So I'm trying to square those two statements because it seems to me that if the federal government were going to be contracting with an outside agency, then it would not put burdens on cities and towns to pick up the slack. Can you explain?
Yes. Thank you for the question, and I did rush through my last part in that section. So yes, if the Office of the Refugee Resettlement Program existed outside state government, there would still be federal funds for that program. However, its existence within DHHS allows for better integration with the programs in which these refugees are legally required to receive, whether it's some of the SNAP, TANF benefits that are specific to refugees, some of our Medicaid programs specific to refugees. And so positioned in DHHS, it allows for better integration. It also allows us to use our contract compliance and fiduciary skills and expertise that we have, and allows us to better integrate the services and program. And it allows us oversight over these programs to ensure that the funds are used efficiently and effectively to help the refugees achieve economic and health independence.
Other questions? Representative Lamontagne.
Thank you. Thank you, Mr. Chair. And thanks for taking my question. Do you know of any rules or policies at DHHS that would deny anyone care based on the color of their skin, as the prime sponsor has suggested?
Not to my knowledge, no.
Other questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So the three bullets that you've kind of lined out here, I don't think anybody would dispute that they have enormous value. At least I wouldn't dispute it. But again, following up on Representative Lamontagne's question, the focus is not saying the distribution of COVID vaccines is or is not important. Those things are all important. So I guess my question would be, with respect to the approach that you take, are there incidences where you are going to look at and say, this community needs service as a community more, and so we're going to focus delivery on a community-based approach as opposed to an individual-based approach? And I think that was because nobody's disputing that these three bullets are important. The question is related to the approach, I think. So if you could maybe talk to that.
Thank you for the question. So if I understand correctly, it's whether your question is around whether we're focused on one community or another, or the individuals within the community. Is that correct?
Yes, in other words, the concern of the prime sponsor was that in seeking to advance the good of the community, it is sometimes necessary to subordinate the good of the individual. And that was his concern. And so what I'm just trying to get at is your practice and how you conduct that and how you ensure that that does not happen.
Of course. So our office, the part of the Office of Health Equity that would help in that part is really listening to all communities, and that's all providers, all community members, and looking at the barriers within. Sometimes there are barriers that are specific to a certain region, right? We have a very rural state. We have a lot of homebound seniors. We have transportation is a huge issue. Sometimes access to primary care in the rural region, access to recovery. So they may look at a community like a rural geographically and say, what are the barriers to care in that region, and help knock down those barriers with the community members and the providers, but not weighing one community over another community or one individual over a different individual. Really convening and facilitating and understanding, is there a gap in primary care doctors? Is there a gap in substance use recovery? Is there a gap in case managers for in-home care for those aging in home? So really looking at some of those broader themes at a strategic level.
Other questions? Representative Tellez.
Thank you, Mr. Chair, and thank you for taking my question. Sort of hidden in the middle of the language of the bill, it says, DHHS is hereby directed to dissolve the Office of Health Equity and is prohibited from reestablishing this office or using any allocated monies for any project labeled as health equity. Can you tell us what it would mean for the Department of Health and Human Services to be prohibited from doing health equity across all of the Department of Health and Human Services and not just the Office of Health Equity?
At this time, we don't have projects or programs labeled health equity. We have federal funding and general funds for different programs that are specific to whatever, a grant comes in and it's addressing one need or another, and there's specific regulations and appropriate uses of those funds. But as a whole, we don't have programs or projects labeled health equity.
But if I could follow up with that, in addition to Associate Commissioner Landry's, certainly it serves a very important function to make sure that the other program areas are aligned in terms of any requirements under federal law for administration of their programs.
Thank you.
One follow-up, please.
So just if you could expand on that, the fiscal note focuses on the costs within the office that might be saved, but you did mention that not complying with federal civil rights law puts a lot of money at risk, because we are supposed to, all the Department and Health and Human Services programs should align with compliance. So can you repeat or tell us, like, potentially what's the magnitude of that scale?
So thank you for your question, Dr. Hayes. I'm not prepared to give a financial number of what we have not done that financial analysis of what the potential penalties are, because we don't know what that would even mean at this point. I mean, as far as the number of violations that we would incur if we did not offer communication access and we didn't comply with federal and state laws. But we have numerous residents across the state that are deaf and hard of hearing, that are visually impaired, where English is a second language. They have a right to access all of the information and all of the services. And if they can't get the information, they can't access the services. And therefore, we are liable for that lack of care, if you will, for that individual. So I can't quantify it today.
And if I could add to Associate Commissioner Landry's answer a response back. The question as it's posed is looking at the bill under the four corners of the document and an elimination of the program. You know, I think our goal here today was to provide an educational opportunity for you to make an informed decision about what actually the program does. And Associate Commissioner Landry did a very concise, fine job of doing it. The question then flipping it on the other end of it, well, what value is it to the program as it currently exists in terms of cost savings? So for example, we know in long-term care, it's better for people to age in place. So that costs annually around $24,000 a year versus if somebody has delayed services and requires higher acuity care, you're going to be entering into a nursing facility and the average cost of that is $74,000. So there is many cost savings that are currently occurring as a result of the current configuration of that particular entity within our department.
Thank you. One more question, Representative Mazer.
Yes, thank you. Thank you, Mr. Chair. Can you just tell me how many employees, if this were to pass, how many employees would be, so if these were dissolved, how many would be impacted? What's the number of employees we're looking at?
We currently have 11 positions within the Office of Health Equity. It's all
Follow up. What about the Department of Environmental Services?
That commission will be testifying next.
I will defer to
Okay.
Deputy Commissioner
So
Grapo.
11.
Okay, thank you.
Thank you very much.
Thank you so much.
And speaking of environmental services, we have Adam Crapo, the Assistant Commissioner of Environmental Services, up next. And Commissioner, again, if you could keep it as close to 3 minutes as possible.
Thank you.
Oh, there's two of you, okay, so you've asked for 5, there's 2 of you, so, okay.
We'll keep it brief.
Thank you, thank you.
Good morning. My name's Adam Crapo. Thank you for the committee for having us here today. I'm the Assistant Commissioner at the Department of Environmental Services, and I have here with me my colleague Thane Joyle. She's the head of our legal unit at the department. Like I said, I'll keep it brief. You know, this bill proposes to prohibit the department from using any allocated funds for projects labeled civil rights and environmental justice. The department doesn't take a position on this bill. However, we do want to make the committee aware of some of the concerns that we have. DES is required to ensure activities funded with federal monies are in compliance with the Civil Rights Act of 1964. Specifically, we are required to adhere to Title VI, which is intended to prohibit discrimination on the basis of race, color, and national origin in programs and activities receiving federal financial assistance. If a recipient of federal assistance is found to have discriminated and voluntary compliance is not achieved, the federal agency providing the assistance is required to initiate fund termination or refer the matter to the Federal Department of Justice. So in addition to that, we are required to comply with the Americans for Disabilities Act as well. That's the ADA. And so having the bill say we can't work on projects labeled civil rights and environmental justice would put significant federal funds in jeopardy. We did give a range in the fiscal note of $80 to $90 million of federal funds, and those are for various infrastructure projects that the federal government provides funding for, and many other programs and other things that we do with the department. Regarding the term environmental justice, it's a long-standing term. I think if you asked anyone on the committee or anyone at the department what that term specifically meant, I think you'd get many different answers. But at its core, you know, over the last few years, the federal government has had an emphasis on ensuring that the department adheres to some of the executive orders that they have. At one point, one of the executive orders required for any discretionary grants that 40% go to environmental justice communities. So and basically how we label that is any disadvantaged communities, low-income communities. That executive order has been repealed. So we are really, what that means for us now is just good customer service. And historically what we've done is if someone asks for a, translation services for documents or a translator at a public meeting, we offer those services as a courtesy. We think that's good customer service, but that's, at this point, that's the extent of what we do under the, I guess what I would say, the auspices of environmental justice. So that's really where we're at. We think that it is a good thing to offer those to anyone who needs them. A good example, I know there was a project in Nashua that was being proposed in a community with a lot of individuals who were not proficient in English, and so we did offer translation services down there at a request of one of the groups that represents that community, to ensure that they understood what the project was doing and what was being proposed there. And so that's a good example of how we offer these types of services. It's really meaningful engagement and making sure that folks can interact with the department. So with that, I'm happy to take any questions. I don't know if you want to add anything, but I'm happy to take questions from the committee.
Okay, thank you. Representative Mazer, did you want to follow up with your question from before?
Yes, thank you, Mr. Chair. How many employees in the Department of Environmental Services?
So we have, in the department, we have more than around 500 employees, but in any program where there is an individual who works on a project or a program that has federal funding attached to it, we are required to adhere to the Civil Rights Act. And so it's not any one person specifically that's working on the civil rights piece. It's a group of folks that throughout the department. It's not anyone's one duty. It's kind of baked into the duties at the department in those roles. On the environmental justice side, we don't have anyone working specifically on environmental justice. What we do have is someone who does provide and coordinates language access, and as I mentioned, those services like providing translation for documents or information relative to any of the services we provide if someone needs it with a disability or some other issue that they're facing. So
Follow up.
Yes, thank you. So I'm looking at the fiscal note where it says $100,000 with 500 employees. It seems like it would be a lot more than that. Is that correct in assuming that?
So for the fiscal, I'd have to take a look at the fiscal note. We provided an estimate for that one person's position for that individual who provides language access. That was specifically what was asked for that, as that's kind of labeled environmental justice, and that's what that would cost. On the civil rights side, it would be a much larger fiscal impact, as I mentioned, in the order of $90 million potentially. That's the range of what the EPA could look at and say, you're not making sure folks have a pathway for if they were discriminated against, one of our subrecipients, for example, if they discriminated against somebody, you need a pathway to be able to make that complaint, and we do offer that.
Representative McKay and then Representative McLean.
Thank you, Mr. Chairman. I'm not sure if my hearing was correct. Did you say that this legislation would jeopardize up to 80 to 90 million dollars?
Well, what I said was that is the amount of federal funding that is subject to Title VI of the Civil Rights Act. And we have to make sure that we provide a pathway for someone to, if they're discriminated against under any of our federal programs, to make a complaint under that. We need to make sure that all of our programs that receive federal funding, but also our subrecipients, are adhering to Title VI of the Civil Rights Act. And so that is the universe of funding that if EPA were to ever, or any other federal agency that we receive funds from, were to do an audit or some sort of other check on whether or not we're adhering to that part of the act, then those funds could be in jeopardy. That's just the universe. I'm not suggesting that is likely to happen. What I am suggesting is that is the universe that EPA could look at and say, okay, you're not adhering to the Civil Rights Act, and that's what could be at jeopardy depending on what they find. So,
Thank you.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So just to clarify, when DHHS testified, that they talked about the kind of three-legged stool that they have within the Office of Health Equity, and that if this bill were to become law, basically that stool gets broken and everything has to get scattered, and so they lose a little bit of that cohesion. However, with your department, if this bill were to become law, you would still be providing translation services. You would still be, if someone had a complaint, processing that complaint. So really, if this law was to pass, would there be any real change in the way that you operate?
on the environmental justice side, likely not. On the civil rights, because we are not branding it environmental justice at this point because that federal executive order has been rescinded. It is merely just good customer service that we're providing. On the civil rights side, if someone were to make a complaint, we would not be able to process that complaint because the text of the bill says we cannot work on anything labeled civil rights.
Follow up.
I think I got it. Thank you.
What's that? Okay. Other questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Representative Jess Edwards from Rockingham County District 31. And again, Representative, if you could keep it to 3 minutes.
Thank you, Mr. Chair. I'm Representative Jess Edwards, representing Rockingham District 31. I have served as the chair of Division 3 for the last 2 budgets, now going on 3. I'm also been a member of HHS oversight. And in these 5 years, I've had an opportunity to speak with the department because the word health, or the phrase health equity, has jumped out at me as well. And I think we've got a situation where whoever came up with the name of that department really regrets it because they couldn't forecast how the name would basically become synonymous with actual discrimination and not real equity. And so I've been asking repeatedly and been told each time, probably 5-6 times in public hearings, some in private, what do you do to run these programs? And what they're looking to do, it was said, break down barriers to access. They're trying to make sure that those among us that are less aware culturally because they're new, they're refugees, or they're less abled than we are, they have less proximity to medical resources than most do. Those demographic populations that are not predicated strictly on race, they can be cultural, they can be geographic. It's whatever forms that demographic. That what they're looking to do is to ensure that access to care is equal. That they are not trying to make sure, they're not trying to have any individual demographic get superior care. It's just a search to remove barriers to make sure that we all have an equal access to care.
And of all the programs they've mentioned, I've been pretty okay with them doing that. I'm a little concerned about the housing program. I wish I had a chance to do a deep dive into that one. Unless they've been lying to me in testimony for the last 5 years, I would say that this is a program that by and large, most of us can agree to. We're trying to make sure that our citizens, our fellow citizens, get access to the kind of care that our society expects. We're not trying to put the thumb on the scale to give somebody superior access. It's all about equality. And that's why they've done things like mobile vans to go out into the community to make things available. That's really what I wanted to say is I've spent more time with this group than most legislators have. And I've gone into it cynical because I'm cynical. And each time I've gone into it with my cynicism fully activated, I've been comfortable that the DHHS Office of Health Equity is probably doing good work. I'd like to cut it a little bit because we need the money, but that's a different issue.
Thank you. Any questions for Representative Edwards? Seeing none. Thank you.
Thank you.
Hopefully I pronounced this correctly. Also signed up to speak is Thane Joyle, I believe it is, from the Department of Environmental Services. Am I not pronouncing that? Get a second opinion here.
Thane Joy.
Joyle, Environmental Services?
Wasn't she the?
Oh, maybe she was with the commissioner.
She was
Okay.
with the commissioner.
Yeah, sorry about that. Okay, also signed up to speak, and this is another tricky one. I believe it's from the Department of Public Health Services. Ireda Muniz.
Muniz.
And again, you've asked for 5 minutes. If you could keep it closer to 3, I'd appreciate it. And please put your microphone on. The button at the base.
Thank you.
There you go.
You can tell it's my first time. Thank you. And thanks for having me here. My name is Iraida Munoz, and I am a concerned Nashua resident and the Health Equity Officer for the Nashua Division of Public Health and Community Services, one of those positions that is controversial right now with the name. I am a Hispanic Latina woman. I'm the wife of a non-English speaker and the mother of 2 Hispanic Latino boys. One of them is bilingual, and the other one is a native English speaker. Not by choice. He has a disability, a speech disability. I am here to testify in support of the Office of Health Equity. Their role is to ensure equitable access to high-quality DHHS programs and services for all populations in our state, with a focus on breaking down barriers, which is what we have been speaking, to care for New Hampshire's most vulnerable residents. I'm going to repeat, vulnerable residents. The Office of Health Equity has provided strategic guidance, training, and coaching to our department, fostering an ongoing process of organizational improvements and cultural effectiveness. Their work supports our programs in the Nashua region, ensuring compliance with the ADA and class standards and providing critical assistance to new Americans as they navigate life in our state. As someone who has personally taken English language classes and courses, I totally understand firsthand the challenges and opportunities that comes with learning a new language and a new culture. In both my personal and professional life, I have seen how access to language learning resources can open doors. The Office of Health Equity plays a crucial role in making these resources available by securing funding and offering strategic support. Through their coaching and guidance, I have gained valuable insights on improving public health communications, ensuring that vital information reaches our community through radio, TV, and newsletters. As a bilingual professional, I prioritize sharing public health resources in both Spanish and English so that all residents, regardless of their language, can access essential services. That is what health equity is all about. The Office of Health Equity also supports immigrant integration through the state refugee program, assisting refugees in becoming self-sufficient and adapting to life in the United States. Their collaboration with local, regional, and national stakeholders strengthens the New Hampshire communities. I'm almost there, I'm sorry. New Hampshire communities by building our community assets, sharing knowledge and developing resources that promote opportunity and well-being. Additionally, they provide critical training to our community partners on language accessibility and ensure that tools of the deaf and hard of hearing community are widely promoted and utilized.
If you could start wrapping up, please.
Yes, the leadership of the Office of Health Equity is essential to fostering a healthy, safe, and thriving community. When everyone has the opportunity to achieve good health, we all benefit. I think we all agree on that. Investing in the Office of Health Equity is an investment in our well-being as a community. I strongly urge you to oppose House Bill 392 and show your support for our Granite Staters in achieving optimal health and equity well-being. Thank you so much for your time.
Thank you. Any questions?
I just have one question. Can you spell your last name for me?
Sure. Munoz, M-U-N-O-Z.
Thank you.
Other questions?
Yes.
Seeing none. Okay, thank you.
Thank you.
Also signed up to speak is former Representative Joe Shapiro, former member of this committee. Welcome back, Representative Shapiro. Representative Shapiro knows the drill. He even put down 3 minutes as the amount of time he wanted, so.
Thank you, Chairman McDonald and committee members, and it's a pleasure and a privilege to be back here to testify in opposition to House Bill 392. How did I not know that everything I came prepared to talk about would already be talked about by the time I got here? Got to the microphone. So I will try to limit my comments to some of the practicalities and to try to put a human face on some of the issues that we've already talked about. One of the themes that was often central to our debates in this committee during my 6 years on this committee was the theme of building self-reliance. How many discussions did we have in this committee about providing specific benefits and services for low-income individuals or disabled individuals or individuals with mental health and substance use issues, or people who just had an untimely medical crisis in their life? How many times did we talk about whether the said benefits that we were talking about giving people, would they create more resilience, more well-being, more health, and more independence in the future? Or would those same benefits create more dependence and lock people into a cycle of poverty and dysfunction? That was frequently what the discussion came to. I'm going to talk specifically about the refugee program within the Office of Health Equity. The refugee program does the former. Fully funded by federal dollars, it works to foster integration and help refugees achieve self-sufficiency as quickly as possible, working through the 2 resettlement organizations and other private nonprofits. It promotes English language proficiency, cultural integration, and employment skills. While immigration can be a divisive issue, this is what the vast majority of Americans say they want. that newcomers follow the rules, that they learn to speak English, that they become good members in good standing in their communities, and that they work to support themselves and their families while filling very important empty jobs in our state. This is exactly what the refugee program promotes. This kind of resilience, this kind of self-sufficiency. And if I could have just another minute, I'd like to just put a human face on this program. So in my neighborhood, a couple of blocks away from me, a family was resettled by a Century of Care Alliance. They're a family of 2 adults, a married couple, and a 13-year-old son. So when people were evacuated from Afghanistan in 2022, they were brought first to Italy, then to this country, then to Concord, and finally to Keene to be resettled by the American military and by the American government. Both adults had been shot by the Taliban and have, wounds that are that have not completely healed. The father of the family worked in security for the American military. Since arriving in this country, they have, the father has worked at the Cheshire Medical Center. He works the night shift because he can make a pay differential so he can send home money to his family in Afghanistan. He takes every bit of overtime hours that he can take so he can send more money back to Afghanistan. For the first 2 years before he got his driver's license and before he was able to buy a car, he rode his bike at 10 o'clock at night to the hospital 2 miles away and back,
If you could start wrapping up.
and back at 6 in the morning. These are the kind of families that get, when they first come, get help through the refugee program at the Office of Health Equity. And I hope that you will take the actual people that this affects into consideration when you take your vote on this bill. I urge you to vote ITL on 392.
Thank you. Any questions? Representative Nagel.
Thank you, Mr. Chairman. It's nice to see you again. I'm sorry you're in the seat when I'm thinking of asking this question, but I know you well enough that I think you can answer it. One of the statements that I've heard over and over again has been that, historically we used private sector, nonprofit, ecumenical, whatever, to provide the services that DHHS is providing now. And some people are saying, well, maybe we should be going back to doing that again to save the taxpayer money. Do we have, do you think the structure in place that we can do that in outside of the government to provide those services in a cost-effective, coordinated manner?
Thank you. So that this has already been brought up before, and I did hear people say that the money would not necessarily go away, although the money seems to have gone away in any case. But it would not necessarily go away because of this bill, but funds would be administered by private nonprofits. What I would say to that is that I think the Department of Health and Human Services is better able to provide oversight and effective administration of those funds. And I believe that this is something that my government, my state government, should be involved in, because I think it's really important. And I think we have a stake in bringing refugees to this country and making sure that they become self-sufficient, making sure that they're able to fill jobs that we desperately need filled. And I think that state government is the best administrator of those funds.
Did I see a hand up over here earlier? Apparently not. Anyone else? Any other questions? Thank you.
Thank you.
Also signed up to speak is Brianna Hankel from New Futures.
Testimony?
You want to, do you have it to distribute or just?
Yeah, to
want-
distribute.
Yeah, just drop it off with Representative McGrath and she'll pass it around. She'll pass it down. Is it the spelling of your last name Hankel?
Yeah. Hello, my name's Brianna Hinkle. I'm the Legal Policy Fellow at New Futures. New Futures is a nonprofit, nonpartisan health organization that solves New Hampshire problems through policy change. New Futures opposes HB 392, and my testimony will focus on the Office of Health Equity and DHHS. A lot of what I planned on saying has already been said, so I will talk about a specific program that DHHS helps run and create accessibility. So one example is the 988 suicide hotline. It has capabilities for video calls for people who are deaf or hard of hearing. The Office of Health Equity is key to providing policy, strategic guidance, training, coaching, and technical assistance across the entire department. So the critical emergency services like the 988 suicide hotline remain accessible for all Granite Staters. New Futures requests the committee to oppose HB 392. And I can answer any questions if needed. A lot of what has been said is already in the written testimony as well.
Okay, great, thank you. Any questions? Seeing none, okay, thank you. Also signed up to speak is Richard Bernard from Building Community in New Hampshire.
Thank you, Mr. Chairman. My name is Richard Menard. I'm the Executive Director of Building Community in New Hampshire. I live in Bow. BCNH is one of those private nonprofit refugee resettlement organizations. Our mission is to help refugees and other new Americans navigate their way to safe, healthy, productive, prosperous, and connected lives. I'll focus just on a very narrow point because so much has already been said, that the Office of Health Equity performs many valuable functions. Among them, it houses the State Refugee Health Coordinator, part of whose job is to make sure that all new Americans have received the necessary vaccinations that the federal government requires, and that also that help keep all of us safe. Having the Refugee Health Coordinator in DHHS in close proximity to the refugee coordinator makes good sense. We've got the health side, we have the refugee resettlement side, which is primarily an employment program. Together, they work effectively together, and I think for that reason alone, it would be worth ITLing this bill, in addition to all of the other values that the current structure brings to the state of New Hampshire. I would just add, as one of the really 4 or 5 major nonprofits that work with refugee resettlement, having state government playing an essential coordinating role makes a great deal of sense. It had never occurred to me, frankly, that we might be unleashed from state government. I don't think that would be productive for us as an organization or for the people we're trying to serve. I'd be happy to answer any questions.
Thank you. Any Representative Polazov?
Thank you, Mr. Chair, and thank you for taking my question. If you could help me with demographic that you serve, like there are some opposition to refugees coming at all, but also there's some conversation around who is here legally, who is here illegally, and in my view, it could be like a spectrum: refugee, SLE who come on CBP1, SLE who jumped through the border. So if you could like speak about who do you serve?
Because we use these federal dollars, we are only focusing on people who are here with federal blessing, who have come as refugees, who've been approved by the State Department, or some other categories of new Americans, people who've come as humanitarian parolees, for example, from Haiti, or as of the people who were evacuated from Afghanistan, Ukrainians who are here through Uniting for Ukraine. My staff, we're a small organization. We have 7 full-time people. They include case managers who are originally from Afghanistan, from Democratic Republic of Congo, from Ukraine, and from Haiti. It's an amazing group. Together they speak 17 languages. This is what health access and equity is all about, is having communication skills on hand. And so we're working with approximately 400 people today. All of them are here, as they say, legally, though I don't find it particularly helpful to use that term. But they're working. They have Social Security numbers. They have employment authorization documents, and they're contributing greatly to the state of New Hampshire, financially, culturally, and because they are young. New Hampshire needs more young people.
Other questions? Seeing none. Okay, thank you.
Thank you.
Also signed up to speak is Lisa Bordwin from the New Hampshire Council of Churches.
Good morning. For the record, my name is Lisa Bodwin. I am the Executive Director of the New Hampshire Council of Churches. I am here to express on behalf of the Council of Churches our strong opposition to HB 392. The Council represents 7 denominations and over 300 churches and communities across the state. This bill raises critical concerns to people of faith who are called to uphold the dignity of all individuals, particularly those who are marginalized. And we advocate for policies that promote access, belonging, and the common good. Much of my written testimony has already been shared here today, so I would also like to point out that each of the structures under attack in HB 392 has the secondary, if not primary, effect of improving access to stable employment for the populations of Granite Staters, including people with disabilities, immigrants, and communities of color, by ensuring equitable health care, protecting communities from environmental harm, and fostering inclusive workplaces. These offices help individuals secure and maintain meaningful employment, allowing more Granite Staters to become productive, tax-paying members of society. This bill would dismantle that and leave unnecessary obstacles in place for these particular groups of workers, and also undermine the state's economic stability by reducing workforce participation and tax revenue. I will also add as a personal story that my son, Forrest, is a person with Down syndrome. And I can assure you that the group of people with Down syndrome within the group of people known as people with disabilities do in fact face barriers based on their appearance and presumptions that they have no competence to work or be engaged citizens. The offices under attack in HB 392 would leave unaddressed the social barriers that prevent people like my son, Forrest, from being seen as valuable employees to Granite State employers, from being seen as valuable friends, as valuable volunteers. I strongly urge you to vote ITL on SB 392. Thank you.
Thank you. Any questions? Seeing none. Thank you. Also signed up to speak is Heidi Tremarco from the Conservation Law Foundation here in Concord.
Good morning. My name is Heidi Tremarco. I'm an attorney with the Conservation Law Foundation. And with me here today is my colleague, Marina Voss, who is our EJ Community Advocate for the Nashua community. CLF is a nonprofit environmental organization advocating for clean air and water and healthy communities. And we oppose this bill and urge the committee to vote inexpedient to legislate. The committee's already heard today about the critical work that these offices do, and so I won't repeat that testimony, and we are submitting written testimony. But I think it's critical that we just emphasize that what this bill would do is remove services for our most vulnerable residents in New Hampshire. And it's not just in our cities, it's not just Nashua and Manchester, but it would have impacts across the state, including in the North Country and in rural communities where access to health services are often very hard to access. There's a lot of distance to travel, and some of this work provides access, so across the state. The committee heard from the Department of Environmental Services about what the EJ office does or does not do, but I wanted to clarify something that clarify a statement from the sponsor. The sponsor's description of what environmental justice laws are in the state of New Hampshire really wildly departs from what is actually happening in the state of New Hampshire. In contrast to what he was warning about, the state has no environmental justice law or cumulative impact laws. And when the Department of Environmental Services permits a facility, they have said, and then their regulations prohibit them from looking at cumulative impacts. So while there is a need to assess cumulative impacts in environmental justice, the department is not engaged in that at this point. And the description that if a facility is shown to have a impact on a certain community, it'll immediately get killed. That is not what's happening in our state. And there's no state or federal environmental justice law at play. What this bill would really do is take a wrecking ball to the Department of Environmental Services. And the committee heard from DES that they estimate that it would result in them giving back roughly $80 to $90 million of federal funding for the department a year. Is the Department of Environmental Services in such strong shape that we can give back $80 to $90 million? Certainly not. We know this not to be true. The department regularly testifies that they're doing the best they can on very limited resources and that there's a lot of work to be done. They're stretching their dollars. So I believe $80 to $90 million a year is roughly a quarter of DES's operating budget. This would have great effects in DES's work well beyond the Office of Environmental Justice or the EJ work that they are doing. It would impact our clean air and our clean water. It would impact our permitting and the oversight. It would have far-reaching effects throughout the way we regulate and protect our environment and our natural resources in New Hampshire. So we urge the committee to oppose this bill and vote inexpedient to legislate. Thank you.
Thank you. Questions? Seeing no questions. Thank you. Also signed up to speak is Sam Hawkins from NAMI of New Hampshire.
Thank you, Chairman, members of the committee, for the opportunity to testify today. For the record, my name is Sam Hawkins. I'm the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI New Hampshire, I'm here today to speak in opposition to House Bill 392. We have a strong history here in the Granite State of working to improve the lives of individuals and families affected by mental illness through the work of community organizations, state agencies, and the work that happens here in the legislature. Through this work, we've made great strides in improving access to care for all people living with a mental health condition. However, we have grave concerns that dissolving the Office of Health Equity could jeopardize access to care for Granite Staters or will jeopardize access to care for Granite Staters. You've heard specifics of the programs and services offered by the office, so I will not go into those, but I do want to emphasize again that Through the oversight and assistance they provide to the department and their contracted providers, which includes crucial mental health services, they promote and protect access to care really for every single Granite Stater. Simply put, for people living with a mental illness, recovery is possible, but only with access to the care they need. Every day, people go to work across the state to protect and promote that access to care, and that work has to continue. For that reason, NAMI New Hampshire urges the committee to vote ITL on House Bill 392, and I thank you for your time.
Thank you. Any questions?
Thank
Seeing
you.
none. Thank you. Also signed up to speak is Isadora Rodriguez Legendre, New Hampshire Council on Developmental Disabilities.
Good morning. Thank you, Chairman and members of the committee, for hearing my testimony. I do have written testimony, so I won't repeat a lot of what has already been said. My name is Isadora Rodriguez, and I'm the Executive Director at the New Hampshire Council on Developmental Disabilities. The council is in opposition of this bill because of the dissolving of the Office of Health Equity. And we believe that the office's work is vitally important to the disability community due to its focus on groups that have health disparities. So some of the points that I wanted to reiterate are that this office ensures federal compliance under federal statutes, including ADA, which protects people with disabilities, and allows for equal access of information and resources. The office has been around since 1999 under different names. And I just want to, voice my concern that we need to have careful consideration to not blanketly eliminate anything just because it has the word equity or justice in it, because there is a need that needs to be met, and because of health disparities that exist for people with disabilities, those needs can only be met through equitable access to resources and information. And then my last real point is that, coordination of care and accessibility of care is less expensive than siloed care, right? And to meet the needs of individuals, we need to recognize that offices like the Office of Health Equity is looking to ensure that every Granite Stater has access to resources and medical care. That's it.
Thank you. Any questions? Not seeing any. Okay, thank you. Also signed up to speak is Christine Doherty.
Mr. Chairman, members of the committee, I want to give you a little context quickly, and I'm not going to take questions in the time expediency. I am a doctor who practiced in New Hampshire for 18 years. I've now retired. I'm the mother of a special ed child, and I'm an immigrant. So I cover a lot of the topics that are affected by what we're discussing. But today I want to present you with just a big picture thought about medicine in general in this state. The model of DEI and the model of meritocracy are being presented as polarized approaches to healthcare. The debate in our country and in our state, it is about choosing one path only. One is superior to the other. I agree that both are necessary for our population to stay healthy and productive. Healthcare is a foundation of a thriving and competitive society. New Hampshire's population is tough, independent, and self-reliant by design. Despite that, every single one of us is impacted by the quality of the care we receive in our weakest and most vulnerable moments. This is when we often have no choices. Our lives and deaths will be in the balance. Diversity in medicine improves care and innovation. Medicine is changing very quickly. A doctor friend of mine says that trying to keep up with medicine is like trying to take a sip from a fire hose. I feel there is a danger that we will become calcified if our state approach to medicine, if we only pay attention to who merits a medical education and who merits receiving the highest quality of healthcare. Few agendas have as big an impact on the health, happiness, and prosperity of New Hampshire's population. I urge you to vote to remain free and to live free and die on our own terms. New Hampshire may never have equal access to medicine, but if this bill passes, we take one step closer to falling backwards. As academic and woke as DEI may seem, this should not be a partisan issue. It is a humanitarian issue that has never been solved by merit alone. New Hampshire lives will be visited by unnecessary suffering and even lost due to a lack of protection of our vulnerable citizens and by our state government. I believe New Hampshire lives free and dies not just on our own terms, but on the independent excellence of our elected representatives and what you foster in our government. Thank you.
Okay, thank you very much. Also signed up to speak is Wendy Roper. And you've asked for 4 minutes. Again, closer to 3 would be preferable.
Sure.
Good morning. My name is Wendy Roper. I'm a Guilford resident and I'm retired. I have truncated what I have to say quite a bit in the essence of time, but I do have copies that I can make available. We are operating in an environment of polarized views and highly charged language. Words matter. When we don't understand or agree on the meaning of specific words, those words can confuse and divide us. When we are responsible for governing and impacting the lives of 1.4 million people, we first must seek to understand the meaning, intent, and practical outcomes behind using certain words. Only then can we make fully informed governance decisions. I believe we are here today in part because of 2 recent presidential executive orders titled Ending Radical and Wasteful Government DEI Programs and Preference and Ending Illegal Discrimination and Restoring Merit-Based Opportunity. Both orders indicate support for long-standing federal civil rights laws, and there are many, which protect individuals from discrimination based on a host of protected categories. In New Hampshire, we have RSA 354A, which established the Human Rights Commission. President Trump has made it clear in his EOs that he is concerned about and has ordered illegal programs and activities that violate our civil rights laws to end. I support stopping illegal practices. I do not understand nor support the wholesale dissolution of 3 New Hampshire government entities proposed in this bill. Just in the last week, websites have been scrubbed, wording parsed, or documents taken down entirely in an effort to be compliant. When I discovered that the previous governor's executive order of 2017 establishing the advisory council had been removed from the state website, I asked Governor Ayotte via email if the values espoused in that EO and its commitment to equal justice for all are no longer applicable. and more importantly, that the concerted, thoughtful stewardship of the council in the area of discrimination supported by state and federal law is no longer needed. I have suggested that the council be reimagined to support anti-discrimination efforts statewide. Dissolving the Office of Health Equity and prohibiting its reestablishment is baffling to me. I trust that the committee or sponsor has had conversations with the relevant administration and program staff to gain a deep understanding of the programs and services administered and whether or not they support bedrock anti-discrimination law.
Please start wrapping up.
Have illegal activities been identified? I would make the same comment about the DES services. Have the relevant staff been spoken to, and have illegal activities been identified? Those folks have already talked about the impact on federal funds. Let me remind you that President Trump's EOs are focused on illegal activities. Consequential actions such as those proposed in this bill should not be taken based on words and an assumption of what they mean, but only on fact-based knowledge of illegal policies and activities based on existing law. I agree, having been a 30-plus year
Again, ma'am, please wrap up.
New Hampshire state employee myself, that there's always improvements to be made, money to be saved, programs to be streamlined. I think we can do better. I suggest this bill be withdrawn or voted down until such time it can be determined that any of the entities cited have broken any anti-discrimination laws. Thank you for this opportunity.
Thank you. Any questions? Seeing none. Thank you, ma'am. Also signed up to speak is Kristen Evans from Able, New Hampshire.
Thank you, Chair and members of the committee. For the record, my name is Kristen Evans, and I serve as the Director of Policy for Able New Hampshire, which is a disability justice organization dedicated to protecting the civil and human rights of people with disabilities across New Hampshire. I am here today to speak in strong opposition to HB 392 because this bill is not just policy, it is personal. It threatens the well-being, independence, and dignity of people who already face enormous barriers every single day. People with disabilities work hard to build lives, contribute to their communities, and navigate systems that were not designed with them in mind. Many already struggle to access healthcare, find stable housing, and secure employment. This bill would strip away the few remaining safeguards that help level the playing field. It would make daily life harder for people who are already fighting to be seen, heard, and valued. HB 392 is not just about eliminating offices or positions, it is about the message it sends. It says that equity and inclusion are optional. It tells people with disabilities that their struggles do not matter, that their access is not a priority, and that their rights are negotiable. This is unacceptable. New Hampshire can and must do better. A truly strong and just state is one that ensures every person, regardless of ability, has the same opportunity to thrive. I urge you to reject HB 329 and affirm New Hampshire's commitment to equity, dignity, and inclusion for all. Thank you.
Thank you. Any questions?
Thank you.
Seeing none, thank you. Also signed up to speak is Kathy Stratton from the New Hampshire Medical Society. And again, you've asked for 5 minutes. Please keep it closer to 3.
Absolutely. Thank you.
Honorable Chairman and the committee. My name, for the record, is Kathy Stratton. I'm the CEO of the New Hampshire Medical Society, and I'm here to speak on behalf of the society and New Hampshire's physicians in opposition to House Bill 392. New Hampshire Medical Society is a nonprofit association of physicians and other healthcare clinicians. The organization's mission is to advocate for the well-being of our patients, for the profession, and for the betterment of public health in New Hampshire. The society envisions a state in which personal and public health are high priorities, and all people who live and work here have access to quality health care. What does quality health care mean to the physicians? Health equity means is addressing the barriers that negatively impact patient care. For example, are patients able to access appointments? Do they have transportation? Do they need vision or hearing accommodations? Can they follow up with medications, physical and behavioral health therapies, and prescriptions? Several of our physicians have submitted online testimonies, and I want to take a second to highlight one in particular. And this is Dr. Travis Harker, who stated that the office provided training to his staff, to me, and to better understand the needs of a deaf and hard of hearing veterans and elderly and the people from different cultural and language backgrounds. The office has supported his patients and as they navigate state resources. The office has identified health disparities in our communities and collaborated with community leaders and medical and public health experts to develop strategies to improve health for all New Hampshire residents. I'm going to keep it short because a lot of what I've written has already been said, and I will submit this in writing. The Medical Society is here to advocate for the rights of patients. Equity programs that identify and serve New Hampshire's veterans, elderly, disabled, and underserved populations. Core public health programs that ensure quality health care for all, and a core value of the society and its members. Elimination of the Office of Health Equity would impact each physician and physician practice and patient differently. I can say, however, that New Hampshire physicians unilaterally believe that the Office of Health Equity serves an important and valuable role in the health of New Hampshire citizens and the patients that we all care for. For these reasons, the New Hampshire Medical Society strongly opposes Health Bill 392, and we urge the House Health and Human Services and Elderly Affairs Committee to recommend not pass. Thank you for your consideration of this testimony.
Thank you. Any questions? Seeing none. Thank you.
Thank you.
Did you say I had a written copy, or is that what was passed around?
I'll submit it online.
Okay, okay. Thank you. Also signed up to speak is Jennifer Earl. Please put the microphone on.
I'll just.
You can use either one.
Thank you. Thank you, Chairman Wayne McDonald and House Health, Human Services, and Elderly Affairs Committee. My name is Jennifer Belmont Earl. I live in Barrington, New Hampshire with my husband and our 2 school-age sons. And I'm going off script. When I was listening to the people from both DHHS and the Department of Environmental Services, they talked about providing sign language interpretation. My children are autistic. My youngest son is non-speaking. He's nonverbal. He communicates differently than everyone else. And one of the things that allows him to participate in school, in society, and eventually when he grows up to participate in our community, in our state, is sign language more than anything. And hearing them talk about how they have interpreters there to make sure people can meaningfully participate and understand what's going on is a huge, huge thing to somebody that doesn't have a verbal voice. Just as a mother, I would urge you to not pass HB 392, to recommend it doesn't pass, because these programs, these things, and these different agencies, they break down barriers of access. They allow more people to participate and become, contributing members of our society. So thank you very much.
Thank you. Are you taking questions or?
Oh, sure, if anybody
I don't know
has
if there
one.
are any. I don't see any. Okay. Thank you. Also signed up to speak is Andrew Lothar. I believe that's Dr. Andrew Lothar. I'm not sure I'm pronouncing your last name correctly, so I apologize if I'm not.
Thank you, Mr. Chairman, for the introduction. My name is Andrew Lair. I'm a Lyme resident. I'm a surgical oncologist. I'm the vice president of Grafton County Medical Society. I'm also the public policy liaison for the Dartmouth Cancer Center. The capacity I'm here today, I'm speaking largely on behalf of my patients and our research community that has done so much in this space over the last few decades. New Hampshire is home to some of the best doctors in the United States, but yet we also know that our clinical care is limited oftentimes by the communities from which our patients come. 60 to 80% of health outcomes are due to factors well outside of the role in the hospital or in the clinics. These social and environmental drivers of health are why thousands of Granite Staters, 50% of Granite Staters who can't afford health care, 50% of Granite Staters who live in rural communities, disabled residents, small business owners, service workers have adverse and worse health outcomes than others. Health equity impacted my 74-year-old patient from the North Country who waited until a softball-sized mass was bleeding through all of his clothes to show up to see me because he didn't have a local provider or any transportation. Health equity is my 47-year-old patient who worked 6 to 7 days a week for her entire life and only came to me when she could no longer walk because of the 30-pound tumor that was obstructing her venous outflow. Her only question to me prior to our surgery was, when can I go back to work? Health outcomes also have an immediate impact on the communities in which we all live. I vividly remember walking into a patient who just underwent a life-saving surgery. He and his wife were crying because they just had to sell the farm that had been in their family for 4 generations. Another patient of mine had to sell his business that he had had for 40 years because of cost complications and inability to pay for his workers. Strikes me every time I talk to my patients, oftentimes the first thing they talk about is the burden of their care on their patients, on their community, their family, their businesses, their employees. So health equity is not some straw man that affects everybody else. Health equity impacts all of us. It's ensuring that all in our community have access to high quality care. In fact, health equity research has shown that policy that the state has implemented has eliminated disparities in rural patients presenting with advanced stage cancer. That's being published in the coming months. It also is the work that's being done on the ground to address the 20 to 40% of Granite Staters who have food insecurity and can't heal from the surgeries that folks like myself try to provide in life-saving fashions. Health equity is also things like the Medicaid expansion that we know stabilized the rural health hospital marketplace, decreasing closures of rural health, ensuring access to everybody. And data out of other states has shown that Medicaid expansion improved the overall economy of states. Finally, I want to talk a little bit because health equity and diversity are very often conflated.
If you could start wrapping up though.
Yeah, I will. To be clear, both of them are critically important. I have to tell all of my patients, regardless of background, that we have delays in scheduling their operation. That's because our workforce is so incredibly short up at Dartmouth and elsewhere around the state. Up to 100% of population growth in this state is net in migration. We need to know how to work with folks from outside of this state and elsewhere in order to increase the workforce. So in closing, I would just strongly urge you to oppose HB 392. I will be submitting my testimony as well as any other supporting documentation, statements, research that you all have requests of me.
Thank you. Any questions? Representative Lucas.
Thank you, Mr. Chair, and thanks for taking that question. I would like to know if you are aware of any incidences in your practice among your patients or your colleagues in which any of the practices by the DES, or I'm sorry, the DHS, have resulted in discrimination in healthcare, in your opinion?
No, sir. No, ma'am.
Thank you. Thank you.
Thank you. Other questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Gwendolyn Tyree from the Greater Nashua Mental Health.
So who understood that?
Oh, okay.
I am the only hearing person on my team, and today it was supposed to be a deaf person that would be speaking with you. However, I'm assuming you guys know that especially a meeting like this, a hearing, takes a lot longer than an hour that is typically expected. An interpreter was only scheduled for an hour. The service is used for CART, the captions that are now being provided to my coworkers and to we have somebody else who is here from Northeast Deaf and Hard of Hearing, who is also deaf, are not high quality. There are full sentences being missed. And so there is not equal access today at this hearing where you are determining if deaf people should be able to access their health care. Now imagine, and this is common, this happened before surgery. I have known people who have gotten surgery on the wrong side of their body because they could not communicate with their doctors and tell them that it was wrong because they didn't know what the doctor was trying to communicate with them either. That is gross malpractice, and that is not equal access to our healthcare. I urge you to think about this as well. 90% of deaf children are born to hearing parents. 90% of those parents will never learn any sign language at all. I grew up in the deaf community, and I had a friend who I asked one day, how do you communicate with your mom? He said, I don't. The only things I know is when she walks in my room and goes like this, it means clean your room. If she does this, it means come here. Besides that, she'll text me. His English language was not strong. So he could not truly understand what his mother or father was trying to communicate with him. I'm going to do my best to keep this under 4 minutes and respect your time. And I appreciate you all so much for listening to me and hearing what I have to say. I have spent $200,000 on an education to be a counselor, a clinical mental health counselor, the only one who is a clinical mental health counselor in the state for deaf people. My coworkers make up the only service for mental health counseling that is provided in sign language in the state. I drive 2.5 hours to see one of my clients up in Gorham because there's no other service for them. They already have a huge barrier to finding the services that they need. Why would we add another one? We are making a decision for people who are unable to be here today and for people with disabilities who are unable to stand up for themselves. How much was this advertised, this meeting, for those people to come and speak for themselves? And how much was it advertised in not just English, because English as a second language is hard. How many people here read things and you have to reread it in English because you didn't understand what it said? Now do that in your second language. It does not help anybody in the community to pass this bill. It hinders them. Our Pledge of Allegiance ends with, "In liberty and justice for all." Where is the justice in this bill? What are we doing to help the people that we have promised to help and support in our country? This is supposed to be a place of freedom. This is supposed to be a place of democracy. And I do not see that being represented in this bill. If you have any questions about deaf culture, which I am not the person who should answer, even though that is my undergrad degree, it is the deaf people that are currently here that should be speaking right now. It is the deaf people here that should be answering any questions that you have about how drastically this bill will affect the community. I was a special education teacher for a year in the state of Maryland. I moved here for this job from Kentucky. I displaced my husband unwillingly on his part to be here. I will wrap up. I was also 6 years ago started interpreting. So I have seen from the interpreter side, and I'm a case manager as well. So I schedule appointments for deaf clients. And a lot of times they ask me to schedule the doctor's appointments because they have too hard of a time trying to get an interpreter. A lot of times offices will hang up when they hear that a sign language interpreter is being used over the phone because they think it's a scam or whatever it is. I do not know why this happens. It is that I could talk about all this for a very long time. But I was calling to make an eye doctor appointment, and I promise I am wrapping up, for an 11-year-old client because mom, who is hearing, has had such a difficult time to get an office to accept using an interpreter and paying for one, which is a legal responsibility of the office to pay for that interpreter. I had to call 3 offices. One of them flat out refused. Another one said that they don't have the resources set up, and I tried to educate them. Finally, the third one was willing to work with me, and I had to have a phone conversation with their office in order to teach them how to find an interpreter and that they are indeed legally required to provide that to somebody. Thank you so much for your time. If you have any questions, reach out to me. I can help you, direct you to somebody who is deaf and can better answer them and share their life experience, but today that was unavailable.
Thank you. Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my call. You obviously have an important role to play in this state. Thank you for being here.
Of course.
What happens to your job if this bill passes?
Well, my job, I would actually get more clients because it would cause so much stress. I have one of the only professions that if I do my job right, I will be out of a job. I would love to be out of a job. But this would cause so much stress. The current political climate, the current way that everything is happening is already putting so much undue stress on people. We have had clients cancel services with us because they're scared of what's going on with the political climate and that their services would be taken away anyway, so why would they continue?
Other questions? Seeing none. Okay, thank you.
Thank you very much. I hope you all have a wonderful day.
No one else has signed up to testify on HB 392 FN. Before I close the public hearing, does anyone else wish to testify? Seeing no one, I am going to close the public hearing on HB 392 FN and open the public hearing on HB 751 FN and recognize the prime sponsor, who is actually a member of this committee, Representative Mark McLean. People came to testify on this one, or to observe. Representative McLean, anytime you're ready.
Thank you, Mr. Chair.
Yes.
I filled out the pink card. It is coming down.
Oh, yeah, that was going to be my next question.
It's weaving its way up to your desk. Good morning, everyone. Thank you, Mr. Chair, and honorable members of the Health, Human Services, and Elderly Affairs Committee. For the record, my name is Mark McLean, representing Hillsborough District 14, which is Manchester Ward 8. I'm here to introduce HB 751, which would create a licensure process for outpatient substance abuse treatment programs by the Department of Health and Human Services. So just a little story. Early last year, the newly elected mayor of my city of Manchester met with several legislators from Manchester, including myself. And when we asked him what he needed from us in Concord, he said he needed three things, really: help with housing, a cleanup of the bail reform law, and pertinent to the legislation we're talking about today, some kind of regulatory structure for substance abuse treatment. And this bill is a step towards addressing that final concern. So why is it needed? Well, both the mayor and myself, neither one of us are big fans of excessive regulation, but the situation in the city and in the state as a whole in relation to substance abuse treatment has become unmanageable. So the mayor of Manchester, as many of you may know, is a recovered addict himself. So he knows the recovery landscape, and he, as much as anyone else, wants to see people get treatment. But his comment to me when we were talking about this is, he says, look, when we release somebody from Valley Street Jail and they are clean, we have a rare opportunity to keep them that way. Instead, they go into some black hole of treatment where the person who's providing the treatment isn't even through their own recovery journey completely. And so what happens is they fall back into addiction, and this very precious opportunity is lost. Okay? And that's really what's at the heart of the problem. And those comments don't even touch upon the predatory behavior highlighted in 2023's The 13-Step podcast. The state doesn't even know of the existence of more than half the facilities that are out there. They're operating completely in the dark. And so we're really in a situation where I think we need some guardrails. The bill originally came before our committee last year, but at that time, the committee rightly said there were too many holes in it to allow it to go forward. The major concern expressed at the time was that licensure might be so onerous that it might discourage folks from actually coming in and offering services. Services availability may go down rather than up. But, because I was aware of the need that the bill addressed, I asked, instead of us killing it outright, if we could hold it over for interim study. So in the subcommittee, we looked at it. We eliminated the residential components of last year's bill to focus on the outpatient only. We exempted non-clinical services, individual practitioners, and 12-step programs from the need for licensure. Okay. Also, we retained the ombudsman position subject to available funding contained in the original bill. We talked in our orientation session early about the value of an ombudsman. So, whether it's, for the elderly, we have a right to know ombudsman, and even the Housing Appeals Board, which was newly created, serves as kind of an ombudsman effect. And so basically, I think that those have been very effective, and persons who are using the services of these facilities are often at the most vulnerable point in their lives. And so having easy access to someone like an ombudsman who can help them access and resolve their complaints, I think would be of enormous value. Since filing the bill in the fall, based on the work of the subcommittee, we modified the bill somewhat. And since then, the HHS department has come back and said that they think that they can execute the licensure requirement more effectively by rolling it into the existing healthcare facility framework than the separate certification that we've been talking about in the bill last year. And that is what you have in the amendment before you, which I handed out before the public hearing. Everybody should have amendment 220H, okay? And so that is what I would like to you consider going forward with. I mean, basically what that does is that substitutes the bill wholeheartedly with the amendment. And what does the amendment do? The amendment basically, well, as I said, it keeps the ombudsman position subject to the availability of funding. It establishes the licensing requirements with the specific exemptions that I mentioned, the individual practitioners and 12-step programs. But instead of creating the separate certification, it rolls the licensure into the existing framework laid out in RSA 151:2 and appropriates the money for a compliance officer who will provide oversight. And the thinking was, you know, since we already have this existing infrastructure set up, it's going to be much easier to do, it's going to be easier to comply with, and it's going to be easier for the department to run. And so they have come around to say, yeah, we think this is a better way to go. So I'll just end by saying, I know a lot of you folks, I know that many of you folks are skeptical about new regulation. So am I. But the population that is struggling with substance abuse, I think they're often so low that they're not, this is not like going and looking at Yelp for a good roofer and letting the market kind of drive it. These people basically, they're so low, they're going to go where they're appointed. And they're just not going to be doing all that heavy research. So I think we can help with this. I think this bill is needed, and I hope you'll support it. There are others who are lined up to speak as well. I'll do my best to answer any questions that you may have, but bear in mind that I do have some folks behind me. Thank you, Mr. Chair.
Thank you. Any questions for Representative McLean? Yes, Representative McKay.
Thank you, Mr. Chairman. As a former director of alcoholism for the state of New Hampshire and a licensed clinical social worker, would you believe that I strongly support this legislation?
Representative McClay, I would believe you support it. I would also believe that you were invaluable to the subcommittee in the fall. Thank you.
Other questions? Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. Like in previous session, I still don't understand why we need it, because you spoke about predatory behavior in some of treatment centers, and that was the reason this bill came to us in a previous session. But for me, the logic doesn't match, because predatory behavior outlined in that podcast happened exactly in certified treatment program. So now we are pushing uncertified programs into certified programs where this predatory behavior was happening, and with state facing all the lawsuits from Sununu Center that was certified, I just don't see how more certification will help with predatory behavior.
Well, I don't think that the intention at this point is to insulate the state, against lawsuits from predatory behavior. The intention is to minimize the predatory behavior. So, number one, the majority of the facilities, we heard testimony from the department in the subcommittee, the majority of the facilities, we don't even know that they exist. And so while individual providers within those facilities may be licensed by the OPLC, there is no oversight of the facility itself. And I think also this was where the ombudsman position becomes very important. You know, when we look at, for example, the right to know ombudsman, people would look to get transparency. They would run up against barriers in their towns, and it was very hard to push through. And I think, you know, having someone that I can go to and I know what their role is, even if their role is they don't have any legal weight, they can certainly shine light on things and they can influence what ultimate decisions come. So if you have someone who is a clearly defined position that people can go to, that understands the framework, hopefully the intention would be that would be helping to guide better outcomes. I look at it from that perspective. I hope I answered your question.
Other questions? Representative McGrath.
Can you help me understand how it works now? Somebody's getting out of jail. Do they go right into one of these treatment centers, and who pays for that?
If they get out, I don't. I'll defer it to somebody after me. I do believe that if it's mandated by the court, that it would be covered by the state. But don't quote me because I'm not an expert. I do believe it is, and maybe you can ask somebody after me from the department that might know better than that. I don't know if we have somebody here from the drug court or not, but I'm not certain.
Other questions?
I do.
Representative Mazer.
Thank you. Thank you for taking my question. The Office of the Ombudsman, so that's something that does not exist presently, correct?
That is correct.
Okay, follow up.
Follow up.
So I've had experience with the right to know ombudsman, and so that was not a great process. So I'm wondering if there's something that you can send us that really lays out what that ombudsman, this new creation of, would be responsible for, and his responsibilities, how he communicates with people, because we couldn't email, phone, nothing. So if there's something that we could see that would make this a process that would make things efficient.
I mean, I don't have the particulars on that. The position hasn't been created. There was discussion during our orientation hearing that they have an ombudsman who works with, you know, people who are in elder care. My assumption, and it's just an assumption, would be that it's based upon something along that model. But, you know, I could certainly, when the folks from DHHS come up, we could ask the question, but I'm assuming that it would be built upon that same structure.
Other questions? Representative Nagel.
Thanks, Mr. Chairman. Thanks for taking my question. I really appreciate all the work you did on this. You really deserve a pat in the back. You really gutted this bill a lot. And I was wondering about the whole section 2 where it talks about how the commissioner is going to establish rules and so on and so forth. Why was all that eliminated?
The reason is because you're going to be, instead of creating a brand new certification, you're moving it right into the existing statute for healthcare facility licensure. So I do think there would still be some rulemaking that would have to be done. I don't think it just is a cookie cutter insert creating a new subsection G. But the amount of rulemaking that would be required would be substantially less.
Thanks.
Other questions? Representative Kofal.
Thank you, Mr. Chairman. Thank you for taking my question. So you have sponsored legislation that would open healthcare to free market forces in New Hampshire by allowing licensed healthcare facilities to accept cash-only payments. Right now, licensed healthcare facilities are required to accept all forms of payment, essentially. Would this, if it's moved under licensed healthcare facilities, would it then be the case that we would have treatment that would have to accept all forms of payment, including Medicare, Medicaid, private insurance, et cetera? Or would cash payment, or would cash only payment or free market options be available?
Yeah, thank you for the question. Obviously, I'm a huge fan of free markets, and I do want to liberalize the healthcare marketplace. And so when this amendment did come back to me, since they are rolling it into 151:2, that was a huge concern of mine. Looking at 151:2, the all payer requirement applies to A and D, and it explicitly says A and D, where this is creating a new section G. That would not be the case. So, for example, if you wanted to open up a facility and you wanted it to be cash only, because this new section G is not covered by that, it would not be covered by the all payer requirement. So that would be, I hear what you're saying, and I've already asked some folks about that very thing.
Thank you.
Other questions? Okay, I'm seeing none. Thank you. We are behind schedule. We've had some important bills today, and we are behind schedule, so we aren't going to break formally for lunch, but members are encouraged to go at their leisure. I'm going to continue the hearings right through until we get done. So you want to go now, you want to go later, we call it a rolling lunch. And we will continue to have the hearings, and hopefully we'll get caught up at some point. So I'll leave that up to members' discretion as to if you want to go. Also signed up to speak on this bill is Jenny O'Higgins and Doreen Shockley from the Department of Health and Human Services.
It is still morning. Good morning, Chairman McDonald, committee members. My name is Doreen Shockley. I am the manager of the Bureau of Licensing and Certification at the Department of Health and Human Services.
Good morning. I'm Jenny O'Higgins. I'm the legislative liaison for behavioral health at DHHS. So the department would like to provide some information relative to House Bill 751. We continue to expand substance use treatment options and also to monitor the effectiveness of care for all New Hampshire residents. In the existing state licensing or regulations are for substance use exist under the Office of Professional Licensure. They exist under the Bureaus of Licensing and Certification, as well as the Bureau of Drug and Alcohol Services, and our Medicaid provider enrollment. So those are some of the existing quality and oversight protections to make sure that people who seek treatment, that treatment is effective and of high quality. This oversight bill here is, as already described by the prime sponsor. The underlying bill had focused on certification, and in working with stakeholders and sponsors, the department was able to identify existing programming under our licensing department. So you will see in the fiscal note of this worksheet that you may have with you today is on the underlying bill. And you'll see that because the creation of a certification program for these substance use outpatient facilities would be new, the department was requesting 4 positions, an IT infrastructure build in order to do the certification, and some training within our existing ombudsman's office. And in working together on the new amendment, that amendment would allow us to reduce that fiscal impact significantly, where the department would need 1 position within our existing Bureaus of Licensing and Certification unit. So that is a big change, and some of the reasons that we moved from certification to licensure to be more effective in that existing oversight that's oversees today already substance use disorder residential treatment, and this would expand to outpatient. As also previously noted, the department doesn't have a great sense of where treatment is happening in the outpatient space because we don't have this oversight. So today we know that there are 53 outpatient practices registered with Medicaid at over 90 locations, but that's would be just those that accept Medicaid. And so the landscape of substance use treatment is much larger than that. So the intent of the bill is both to help us understand the landscape of treatment and have families be able to know where they they can access care, and then also to monitor the effectiveness and quality of that, and to receive complaints and be able to take action.
And as Jenny has already stated, substance use disorder residential treatment facilities are already licensed in the state of New Hampshire, and the Bureau of Licensing and Certification oversees those facilities. And Jenny's already mentioned the fiscal note. Again, the department is committed to continue working closely with the sponsors and with advocates and stakeholders to ensure that it will be an effective way to understand the landscape of treatment in New Hampshire and ensure the quality of services and the ability to respond to concerns. We're happy to answer any questions if you have them.
Thank you. Any questions? No questions. Thank you.
Thank you.
Thank you.
Also signed up to speak is Kate Peters. Good morning. Please put your microphone on. And you asked for 5 minutes. Please keep it closer to 3.
You bet. My name's Kate, and I'm a family doctor in Manchester. I work at Amoskeag Health, which is our safety net health center in Manchester, and I also moonlight at a couple of our county jails. So I'm very familiar with substance use treatment, and I do a lot of it. And I'm passionate about getting high quality treatment in place for folks. And I've seen the damages that can happen with poor quality treatment, because a lot of folks end up, unfortunately, in situations that are not ideal for their treatment setting. I guess the piece that I'd like to add to what's already been said is that in my estimation, 100% of the people who seek treatment for substance use have suffered significant trauma. And people who have suffered significant trauma are particularly vulnerable, unfortunately, to abuse and to be taken advantage of. I hope you all have listened to the 13th Step podcast. I think it's really pertinent to this conversation. And you know, it's my job as a healthcare provider. It's your job as lawmakers. It's all of our job as responsible citizens, I think, to advocate for the most vulnerable among us, right? This is why we put in laws to keep kids safe and keep elderly people safe. And I think people who have suffered significant trauma, like those people who are seeking substance use treatment, deserve that added protection too. So over the years, the legislature has given lots of money for substance use treatment programs. And I want to say it's working. I see a lot of people turn their lives around and become wonderful contributing members of society who take good care of their families and contribute to the economy. And we now need to continue to make this investment effective by putting in guardrails, you know, so to speak, for the treatment places that are available. When we provide good quality evidence-based treatment for folks with substance use, they get better. And that's good for all of us. So I hope that you vote ought to pass on this and help me in stemming the tide of the opiate epidemic.
Great, thank you. Any questions? Seeing no questions, thank you. Oh, Representative Nagel.
Sorry, I was just dealing with my son's trauma. Just for clarification, can you specify what you mean when you use the word trauma?
Sure. Well, trauma can be lots of different things, right? It can be certainly physical trauma, like having suffered an overdose and getting, you know, medical treatment in ER, or it can be emotional trauma. I think that there's really good data that most people who end up struggling with substance abuse either have had trauma in their history that has led them down that road, or in getting involved with substance abuse, then they have suffered trauma emotionally and physically as a result of that.
Other questions? Okay, I think it's safe this time. Thank you. Also signed up to speak is Annette Escalante from the Elliott Health System. Good. Please put your microphone on. And again, you've asked for 5 minutes. Please keep it closer to 3. There you go. Oh,
It's on there? Okay,
Red
here
light
it
has
is.
to be on you.
Okay. My name is Annette Escalante, and I am the Director for SUD Services for the Elliott Health System. And I am here today because this was one of the things that I'm very passionate about. Just to clarify, I'm a person living in long-term recovery, 33 years from heroin. And I got to be very honest with you that when I came, I'm from Massachusetts. Yeah. But when I came here 29 years ago, I was a little shocked about the current SUD system. And I can honestly say that we've come a very long way, but we still have a long way to go. About 4 years ago, I was a director of the Bureau for Drug and Alcohol Services and really got to experience the state piece and what we do with the treatment. And now as a provider out in the community and serving for many years before that, I really am able to see what we're actually currently working with. And the reason that I am so passionate about making sure that this does happen is because of my experiences at the state, knowing that I really couldn't do anything. I would get complaints and we had no oversight. So what I decided to do was really push this, and I left the state because I was receiving phone calls from family members asking where they should send a loved one. And I got to be honest with you, if you were looking right now today to try and find a place for your child or your sister or brother, you're going to want to have someone having oversight from where you're sending that person. And this is really what this is about, is making sure that we're providing the best care for any person coming into treatment here. We've received several complaints. There have been several complaints, and the people who know the best are the clients who are actually the folks who are receiving these services. We've had programs that kind of put 30 people in a group. There's no oversight for this. If someone has a complaint, they don't have anywhere really to go unless the program itself is receiving services from the state of New Hampshire. So we really need to be able to have a place for anyone who has a complaint to be able to look into it and really process it so that we're taking care of the most vulnerable population in our state. And that's really why I'm here today.
Okay, thank you. Any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Jamie Powers from, I believe it's Gatehouse Treatment. You just shut it off. There you go.
My name is Jamie Powers. I'm the CEO of Gatehouse, New Hampshire Respite, and MAT Care Clinics, all located in Nashua, but serving all areas of the state. I was also the director of the Bureau of Drug and Alcohol Services immediately after Annette was, so it's nice that we're following each other again. I am here to testify in support of this legislation. It's a crucial step towards ensuring the safety and effectiveness of our treatment services here in New Hampshire. As others have mentioned, we're dealing with very, very vulnerable populations who don't necessarily have the means or even willingness to do a lot of research into care. They just want care. They're scared, they're sick, they're done, they want help. They're not going to Yelp. It's not like choosing where you're going to go to dinner. And right now, with no certification or licensure for outpatient facilities like we have for individual providers through OPLC or residential treatment centers through health facilities, there really is no measure, nor is there a comprehensive list of what services are available. We have made huge investments in our system of care over the last 10 years since the implementation of the Affordable Care Act as well as parity. And that system has grown incredibly, but we don't have the means to monitor it to make sure that we are giving people the services that they need. I know I've heard concerns about this bill and stifling creativity and innovation. I want to be very clear that what this bill does is it provides a framework of safety that individual programs can then build on in their own ways. And just as we have with Medicaid and payer regulations now, we have very different programs that have those same standards of safety. I think most of everything else I was going to touch on was already discussed. I will echo Annette's frustrations with families members calling, concerned about the treatment that their son, daughter is receiving and really not being able to do anything to help them. That's a really horrible feeling. So I will leave my written testimony, and I thank you all for your time and consideration.
Thank you. Any questions? Seeing none, thank you. Are those to be distributed? Ms. Powers, are those to be distributed or? Okay, yeah, Representative McGrath, could you pass that down, please? Also signed up to speak is Jake Berry from New Futures.
Mr. Chairman, honorable members of the committee, thanks so much for having us here today. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for more than 25 years to help address issues around substance misuse and addiction in our state. I don't want to repeat too much of what's been said here this morning, but I do want to stress our strong support for this bill. Simply put, we believe this bill represents a natural and logical next step in the growth and maturation of our treatment system, and it will provide important quality assurances and patient protections for individuals in need. As others have alluded to, our substance use treatment system has grown significantly in the past decade thanks to the work of many, including many of you and your fellow legislators. There are now dozens and dozens of treatment providers in our state, meeting the needs of individuals and families. Certainly, we want to believe that each of them prioritizes patient care and patient needs and provides high quality evidence-based services. And most of them, and we believe most of them do, but the truth is we don't know that that's the case for all of them. As you've heard, under our current system, the state has no oversight or record of many of the provider organizations operating within our borders. You heard the numbers. There are 53 outpatient provider organizations currently registered with Medicaid. Of those 53, the department currently contracts with only 8 of them. For the rest, the remaining 45, the state has no oversight authority or mechanism to step in if cases of wrongdoing or misconduct or substandard services arise. And this doesn't even touch on the dozens and dozens of providers that are not registered with Medicaid. These organizations are not registered with the state in any way. We don't know who they are, where they operate, or what quality of treatment they provide. At best, this leaves individuals seeking treatment to navigate an uneven system that varies significantly in the quality of services offered. This weakens our treatment network as a whole and contributes to a revolving door of patients who transition in and out of treatment while they fight to address their addiction. At worst, it leaves patients at risk of abuse and misconduct that threatens to force them to relive the trauma they have experienced and make it that much harder for them to obtain long-term recovery. The amendment, as Representative McLean mentioned, would address this by requiring outpatient treatment providers to be licensed by the state. Further, it would add the behavioral health specialist position to the Ombudsman's office, which, as you heard, is just a critical component to ensure that individuals who are experiencing, misconduct or wrongdoing within treatment have a place to go to report their concerns, and it's just another avenue for them, for the state to investigate and make sure that there are corrections where there need to be. In closing, I would say that the state, over the years, we have invested millions and millions of state and federal dollars to establish a treatment system that is capable of meeting the needs of our state. It is, weaknesses or holes in the map, folks who are not registered, that makes it harder, for us to be good stewards of those taxpayer dollars to make sure the money is being reasonably used. Because it means people are receiving substandard treatment, which makes it harder for our high quality treatment providers to ultimately help get them on the right path and get them the support that they need. So we think that this bill is just critical in ensuring high quality services across the state for everybody who needs it. And I'm happy to take questions.
Thank you. Any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Amanda Vachon from Riverbend Community Mental Health.
Good morning, Chairman and committee members. My name is Amanda Vachon. I am the coordinator for the Merrimack County Recovery Court. It was formerly known as the Drug Court. We just rebranded, so those terms are interchangeable. I have testified on all the versions of this bill since its inception, and that felt like a responsibility to me. I've worked in this field of mental health and substance use disorder treatment for over 15 years. The majority of that, I worked as a corrections officer working with people from community corrections, so people who are out in the community on bail or who were serving a sentence. It also included folks who were part of the specialty court treatment, so programs, so mental health court and drug court. The reason this is so important to me and to the specialty court programs in the state is that we end up working with the highest risk, highest need folks in our communities. So what that means is that without intervention, they would likely recommit, commit a new crime, and their substance use disorder would likely get worse. They also are the highest need because they have a severe substance use disorder. Previous testimony has included information about trauma and how impactful that is to developing a substance use disorder. It is pervasive. Substance use disorder does not discriminate. It's across all genders, across all socioeconomic status, across all races. And so it's important to the society as a whole that we do something to safeguard the treatment that we're expecting people to participate in. Now, this bill applies to all treatment and not just the participants that I work with currently as the coordinator of the program. But by the time they get to us, it's more than likely because their substance use disorder has gone untreated or has gone, they've sought services from providers who did not provide adequate treatment. The goal ultimately is to not need specialty courts because hopefully we would provide a network of treatment that would get people well before they commit crimes to the point where they would be facing a prison sentence or participating in my program. But we're not there yet. And so we have an obligation to provide oversight to ensure that we have a continuum of care that would reduce the likelihood that someone's going to wind up on my, in front of me. For those of you who may not know what specialty court programs are, they are a combination of mental health and substance use disorder treatment that's aimed at providing accountability for those who have committed crimes and who also have one of those diagnoses. In New Hampshire, we should be very proud. All but one of the counties in the state has an adult drug court program. We also have mental health courts across the state, and the recent data has shown that we are reducing overdose deaths by about 40% in 2024. We also will see the 1,000th participant graduate from our court system in the state. The reason I'm here is really just because the 13-Step podcast illuminated something to me that I didn't know about, which was the likelihood that the people I had sent to treatment over the course of my career were statistically, it was possible that they were victimized when they went to treatment. And to me, that was unacceptable. I lost sleep over that. And I feel like I have to be here to be a voice for those people who we are mandating, in some cases, to go to these treatment centers.
Okay, thank you. Any questions? Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. And I apologize if you said this and I didn't quite understand it. But does the court contract with particular treatment centers now, or how do you make the referral? Where do you currently get your information about what programs to refer people to?
You mean before they come to our program or after they've already accepted a sentence?
I guess anywhere in the process. I don't really.
Okay, I'll try to quickly summarize. So someone who commits a crime, most often they're drug-related or drug-related adjacent. they would be referred oftentimes by their defense attorney to apply for the program. So these programs are voluntary up until the point that they're sentenced. Then they become mandated. So they have to do what the court is asking them to after that point. But the process to get into these programs is twofold. They have to be assessed by a licensed clinician to determine they have a substance use disorder. And they also have to be assessed by a trained professional to determine their risk level. And they have to be high risk to participate. Once they come into the program, the clinical assessment that they obtained when they were deemed appropriate is then used to determine the level of care that they would need to be in. Sometimes that means they come out of the jail or system to right into an inpatient bed. Sometimes it means they come right out to outpatient services through, for example, Riverbend, which is where I work, as part of a program. But over the course of time, level of care can change because addiction is a relapsing condition. It's chronic. And so over time, they may struggle. We reassess their level of care. They go to a different treatment center and come back to us. So the continuum of care is very important to the success of our participants over time.
Other questions? Seeing none. Okay, thank you.
I don't know if I have enough copies here.
Also signed up to speak is Cheryl Pacapelli, I believe it is. Did I pronounce that correctly?
You know what? You did a great job.
Thank
So, yeah, my name is Cheryl Pacapelli, and I am also a person in long-term recovery for 35 plus years. And I am speaking in support of this bill. I concur with everything everybody said already, but now I want to tell you a story about what is currently happening right now, today, as we sit here with zero oversight for these programs. On Monday, as a person in long-term recovery for a long time, I get calls from all kinds of people, family members, where can I send my son, daughter to treatment? And I also get calls about this happened where I work. Who can I tell? What's the process to make a complaint? And this woman who called me is in her early 20s. She works at a outpatient treatment center, and her boss, who was the director, solicited inappropriate sex from her, and she doesn't know who to tell that to. There's no oversight for this. She went to her boss. The person ultimately got fired. And when that happened, she took over all of his clients. 5 other women have said the exact same thing happened to them. Again, nobody to tell. No oversight, nobody to make sure where he's going to work next, which he is already working somewhere in Concord, it's not going to happen to another woman. So again, I would urge you to support this bill for those reasons. And it has been mentioned before, if you have not listened to the 13th Step podcast, I would download it to your phone on the way home. This is real. Women in treatment are being abused over and over and over, and we are not doing anything about it. I have been trying to work on getting this done for 11 years. This is the closest like I have come, and it is in your hands now to help to move this legislation forward. And I have written like professional testimony.
Sure.
But I just wanted you to know, like, this is actively happening today. And I am trying to help this woman know what to do. So, and I'd be happy to answer any questions.
Thank you. Representative Palazov.
Thank you, Mr. Chair, and thank you for sharing with us and taking my question. So I'm trying to understand, obviously, very concerning situation, but I'm trying to understand if this bill will help or makes it worse because you are speaking about individual who was abusive and now he is in different facility, but I think Bill, if I'm not mistaken, speaks about facility itself, and facility is now in good hands. So going after facility may be not the right approach in the situation that you described.
So in my way of thinking, and I could be way off, but if in fact I was a woman in that treatment center and this was happening to me, that I would call the office of the ombudsman and report it. And then what they do with it, I would hope they would investigate, look into it, and find out what's going on. Make sure the director of that facility knows, like we had 5 women say that this person is, taking advantage of us. And right now, there's no place for that to happen.
Thank you.
Other questions? Seeing none. Okay, thank you.
Thank you. Oh, and one other thing. I was never the director of the Bureau of Drug and Alcohol Services.
Also signed up to speak is Marie Keeley.
Hi, my name's Marie Kiley, and I live in Portsmouth, New Hampshire. Thank you for allowing me the time to testify. I'm here today in support of House Bill 751, and I'm supporting this bill because my son, my only child, Ben, and this is his picture, died suddenly and unexpectedly from alcohol on October 24th, 2023, just 15 months ago. And he was only 44 years old. And I never saw him drink, and neither did my whole family. He worked full time, and he had lots of friends, and he was very close to his family. And his friends knew he had a problem with alcohol, and they just didn't know how to help him. And I appreciated hearing that this bill, people talk about this bill is going to allow people to be able to more easily navigate the system and find treatment because, and someone mentioned, I think the sponsor mentioned that, and others, that the people and their families are really vulnerable when this is going on, and it's not an easy process to find quality treatment. So my son, I didn't know that he had relapsed. This picture was taken on Mother's Day 2023, and that was 5 months before he died. And we were out hiking. He loved nature. He loved to go hiking. And he was sober then. I didn't know he had relapsed, so it was a shock in October when I received the call from the hospital that he'd had a cardiac arrest. And it was 3 a.m, and he never regained consciousness, and he died a few hours later. And my sister-in-law was there with me at the hospital, and she said, "This is just shocking." She's like, "He's the picture of health." And I kept looking at him and saying to the doctors, "Look at him. He doesn't have a line on his face. His beard is so trimmed, his fingernails, he's so healthy. How could this happen?" And a doctor told me that, I'm like, "But he's so young and he's so healthy." And he just said, "For your son, alcohol was poison." And he said, we don't know why some people are in their 70s and they're in and out of detox and they're back here. But he said, not for your son. So Ben had voluntarily attended substance use treatment centers 4 times in the 6 years before his death. That's when we found out that he had alcohol use disorder. Like I said, we never saw him drink, but 6 years before his death, he was diagnosed with alcohol use disorder. And he was very open about it with us, and he badly wanted to stop drinking. And unfortunately, the treatment centers that he attended did not provide evidence-based treatment, something that I didn't realize at the time, and he didn't realize. And he did tell them, after the first treatment center, and when they sent him he was referred. We talked to the hospitals and they referred him to these facilities. I don't think they knew that they weren't evidence-based, and he had told them after the first one, I need more medical care. Sorry, I'll keep this short. But he didn't receive it. So he did not receive evidence-based treatment, and I think that this bill will help to ensure that that happens, that the facilities need to meet standards, have qualified staff, and provide evidence-based treatment. And also, the other thing is that we and the other families that were had their family members there received outdated and harmful advice from the center staff who lacked the qualifications to advise families. We attended the family meetings, and the advice that we got on how to help our families was very outdated and very harmful. And so I think that this bill will help to ensure that there are qualified staff there that are meeting standards. And Ben was very intelligent, kind, caring. He always worked full time. He had so many interests. He loved history and literature. He loved to read and write screenplays. He was funny and creative. He was just a wonderful son. He was a gift. I used to tell him he was the joy of my life, and I miss him every single day. And I'm just so sad that he lost his beautiful life needlessly. And I've since learned that alcohol use disorder is highly treatable, and I believe Ben would be alive today if he had received the evidence-based treatment that he wanted and needed. And he was so full of life that I saw him losing hope that he could recover. So I ask you to support this bill for the many people like Ben who are struggling to recover from addiction, and for their families and friends who are also desperate to help them. So thank you for your time. and
Thank you, ma'am, and we're
consideration.
sorry for your loss.
Thank you. Thank you very
Any
much.
questions? Seeing no questions. Thank you. I have a second card for Jamie Powers, but I know Jamie Powers just testified, so is this a duplication or? Okay. All right, great.
Do I need to retain this?
No, we've already got one. So. Okay, I have no one else signed up to testify on 751 FN. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 751 FN and open the public hearing on HB 645 FN. And I believe Representative, yep, there he is. Representative Edwards is the prime sponsor. He's coming in now.
2 minutes just to go to the restroom.
Sure. We're going to have just a very brief recess of a couple of minutes, but give Representative Edwards a chance to get situated and a couple of other members to take care of a couple of things. And
Do you want me to hold off?
Yeah, if you could hold off for just a couple of minutes. Appreciate your patience.
No problem. We've had some interesting bills today.
Yes. Okay, I'd like to reconvene and again, open the public hearing and proceed with the public hearing on HB 645 FN and recognize the prime sponsor, Representative Jess Edwards from Rockingham County District 31. Representative Edwards.
Thank you, Mr. Chairman. I'm Representative Jess Edwards, representing Rockingham District 31. That's Auburn, Candia, Chester, and Deerfield. I'm here today to introduce House Bill 645 FN. One of my co-sponsors shares with me the honor of serving on the Prescription Drug Affordability Board. That's Senator Rosenwald. And we also today have the chairman of the Prescription Drug Affordability Board with us, the Honorable Gary Merchant. Representative Merchant helped me draft this bill with Senator Rosenwald. So what you're looking at is the evolution in understanding how the Prescription Drug Affordability Board ought to operate. It first got put into legislation about 4 years ago, maybe 5 years ago. It had some concepts at the time that it was going to be pretty autonomous in terms of its data collection and data storage and its ability to do data calls to ask industry to provide direct answers to them that they would provide privacy and security around. So what has happened is having had an opportunity to operate the board a while and figure out what the real ways of working should be, it's been determined that we think the board ought to rely on the data that's already being accumulated by other departments and to rely on them to do all the data warehousing and managing, and that the PDAB will become essentially an entity, a customer, to request access to particular data to run a particular report, and only run the reports that have been developed in concert with the entities of the state that purchase our prescription drugs. So we're supposed to be in touch with those entities that buy drugs on our taxpayers' behalf, figure out what kind of information they need in order for them to make better informed decisions, to use the transparency of information for them to drive better drug prices. That's the general principle of the board. And what this bill does is, in several places, it puts this in the statute, like on the first page, section 21 on down. It talks about identifying the report before they start to seek the data. Then on line 28, it starts to talk about collaboration between departments using MOUs. It talks about cost sharing with those departments so that if extra work is required, money is made available. It talks about on page 2, line 5, the methodology for making a data call. Line 11 is due process, so that if data request is made that's onerous, that industry has an opportunity to contest the request before providing the data. And on page 3, I'm going through it a little quickly. There's a section in here that talks about how the board is supposed to provide value and what kinds of information it can look to. We added to that line 25 and 26, basically saying that the board ought to have situational awareness of what other PDABs around the country are doing, what the feds are doing, so we can just leverage other good ideas instead of thinking we have to make them up ourselves. Next page, again, we're on situational awareness. Then we get to how we can levy fees if companies do not comply with a valid data request. We limit our own access to the data to only those who are qualified and with a need to know within the board. Sometimes we may ask for business sensitive data, and that's what lines 34 on that page do, is to just say that we should be aware of business sensitive data. Next page 5 is a quality statement, so that if we collect data, we're collecting good quality data, and that way any data that we do collect can then be useful to others and not just to our own purposes. So that's what the bill does. There's a fiscal note on it, I think this is this bill is an effort to do some good government. The board operation ought to mature, and this legislation directs a good way in which it can be done in a sort of a nonpartisan or a bipartisan way. And with that, I'll take any questions.
I have one to start off with. Is there an amendment pending on this? I heard a rumor. Or...
I do not. I understand the ED&A committee, after they heard the other half of this bill, that their committee is talking about another amendment, but I don't have anything official on that.
Okay, thank you. Any questions? Representative Kofal.
Yes, so can you offer any insights into how much, what is the budget? I was looking at some slides online, and it looks like the budget request for the next 2 years is around 1.2 million for the board. Is that accurate, or am I off base there?
I am aware of the agency budget request and I remember it in the first year. The first year it's $257,000. And that's in the budget. And then this fiscal note thinks that there would be some potential for revenue a little bit, and some additional expenses related to the data calls. So another appropriation would probably need to be made to support the data call part of this. And so it could go from $250,000 to about $350,000 a year. Does that answer your question?
It does. Follow up?
Follow up.
Are you aware of, so in addition to the sort of the hard dollars, are there soft costs associated with the board? Are there, for example, agency personnel or personnel from other agencies that are contributing significant amounts of time that ought to be considered as a factor in the overall cost here?
The amount of time that I'm aware of is in the Department of Health and Human Services, because this is attached to DHHS, and I think it's accurate to say that in the last year, or about 120 man hours, 100 to 120 man hours. It's a rough estimate. It's not been documented, but it feels like an additional 120 man hours have been donated to the board by other departments. And that other departments could include the departments that come in to provide some an advisory council, and the Department of Administrative Services and DOIT as we talk about data warehousing. So there are additional indirect costs that are not associated with the hard dollars.
Thank you.
Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. In medicine, we like to think we proceed on and call it evidence-based medicine. I think this looks pretty good in the sense of evidence-based buying.
Yeah.
With that said, I'm a little bit confused. Maybe I'm just not reading this carefully enough, but there's some authority to get the data that you want to make sure that money's being spent properly, and the muscle behind it. And we've seen this in other committees about state money being hidden behind proprietary discretion and not being accessible. What would prevent, like, say, a PBM would be one that you would interact with, I would presume. They wouldn't want to give up their data. What authority do you have
The initial legislation from 4 or 5 years ago had very strict authority. And we scaled that out until we could build the PDAB and figure out what we really need so we could make the authority commensurate with the requirement for the data instead of just a sort of a plenary authority. And we've scaled it back, Representative Woods. I'm looking for the particular paragraph, but I think it's about $500 or so for a data call that is refused. So if we've justified the need for data by having a report format that would serve the needs of a buying entity, if we do the data analysis on it to find out that the data just doesn't exist anywhere in our government system already and that it's a new request for data, and then we form the data request and send it out, the entity receiving the data call has an opportunity to protest, say, I'm not giving you that. It's too business sensitive. You don't really need it. You could get it from other ways. There's a due process loop that's in this bill that hasn't existed yet. And at the conclusion of that, if the PDAB determines that we still need the data, then we can issue the data call, and there's a legal obligation of the entity receiving the data call to respond. And if they don't, then they begin to be fined. So it's very narrow, whereas the initial setup, it was very broad.
Well, I wanted to clarify that in fact, there is an avenue to get that data, and there's no way for an entity to just plain stonewall and say, no, that's proprietary information. Thank you very much.
They have an opportunity, as they should, to protest if we've asked for too much data, and we give them a due process opportunity.
Yeah, I get that, yeah.
And but still, at the end of the day, the PDAB is in a judgment position to determine whether or not their protest was adequate or not.
Other questions? Representative Kofal.
Thank you, Mr. Chairman. Thank you for taking my question. So so reading through the annual report, there's quite a lot in there about rebates, and one of the powers in statute is to collect information about rebates. So I have really two questions about that. Number one is, does the purview of the Prescription Drug Availability Board extend to vaccines? And does the information collected about rebates apply to rebates or incentive payments that are made to providers for certain meeting certain thresholds for either pharmaceuticals and or vaccines?
Okay, I'm going to try to answer your question. It may not be directly correlated, but in general, the Department of Insurance already collects a tremendous amount of data. They get data on actual orders and utilization. I think some of that information comes through the prescription drug boards. What's the term I'm looking for? PBMs. Comes through the PBMs. But the rebate information so far has been extremely difficult to get and to apply to the drug data. And therefore, entities all over the place trying to figure this stuff out, IT, DAS, the federal government, other states, everyone, I think, is struggling with the idea that these rebate mechanisms are so obscure and Byzantine that it's very difficult to take that information, even if you can get it, and then apply it to the actual drugs so you can know what the true costs of the drugs are. So that's a problem. And I think that's one that the PDAB is working with the DOIT for the coming annual report. And like I said, the Honorable Gary Merchant is here. He's the chair. He's been working this problem for 4 years. He could elaborate.
Follow
So if that is the case, because rebates play a significant role in pricing or in obscuring transparency in pricing, And if the Prescription Drug Availability Board doesn't have access to that information, is it obscuring the ability of the board to do its work? And, you know, can the board be effective under those circumstances?
I won't get to the effectiveness question, I think, right away, but I'll say that the entire predicate of the board is the belief that if we have price transparency, we can provide recommendations to the purchasers of our drugs where they can use that in their contract negotiations. And so to the extent that we have really well-qualified drug transparency, you would assume that that would lead to better negotiating positions, which is maybe why it's so hard to get the data. I don't know. That's where this kind of gets gray. And then the question on whether or not the PDAB is effective without being able to do that, I think the ultimate indicator of effectiveness is the extent to which the PDAB is able to provide value-added recommendations to our purchasers that they can implement and start saving real money. So far, there haven't been any recommendations that have turned into the saving of real money.
Other questions? Seeing none?
All right.
Thank you.
Thank you.
Also signed up to speak is former State Representative Gary Merchant and former member of this committee. Welcome, Representative Merchant. Representative Merchant, I have to admonish you, we try to stick to 3 minutes here. You asked for 5.
I'll try to wrap it up as quick as I can, Mr. Chair.
Thank you.
It's a pleasure to be back before this committee. It was a pleasure to serve with this committee for a few years. I learned a lot, and hope you guys will bear with me as well. So what I would say is what we're trying to do in the Prescription Drug Affordability Board is bring a greater transparency into the state of New Hampshire to make people more aware of what the market works. I'm a strong believer in a free market, but I also believe a free market only works when transparency is available and data is flowing freely. If the buyer is not aware of the market and what's going on, it's really, in a lot of ways, puts them at a disincentive. So when you look at the state of New Hampshire, to give you some idea about the magnitude of what we spent, in 2022, we spent $1.7 billion. That's with a B. The state of New Hampshire by itself spends multiple millions of dollars on prescription drugs. If we don't find a way to begin to bend the cost curve and try to understand what's going on in the marketplace, we cannot, as a state nor as a citizen, try to bend that cost curve. So what this is, and I worked with Representative Edwards, also with Senator Rosenwald, is trying to find a way to collect the data that the board needs in order to begin to bring greater transparency to the marketplace and try to educate ourselves as well as other folks that rely upon the market. So that's the whole intent here, is to say, we don't need to be in the collecting of the data process. The board should not have to build its own infrastructure to collect the data. There are other entities in the state that collect data. The Department of Health and Human Services, the Department of IoT, the Insurance Department. We don't need to recreate that infrastructure. What we need to do is have the ability to identify what data we need for the reports, let that entity collect the data on our behalf, and then have that entity, once they collect the data, share it with the board. That's an efficient way for government to work. I was upstairs with eDNA talking about a data warehouse. We have various silos in our state that collect data, but they don't talk to each other. So it's a separate bill, but this is back to the same thing, is we're trying to find a way to use state resources efficiently and economically to ultimately allow the board to accomplish its mission that was stated in the statute.
Okay, thank you. Any questions? Not seeing it. Oh, there he is, Representative McLean.
Thank you.
Thank you, Mr. Chair, and thank you very much for taking my question. Just for because I'm still trying to piece this together. Could you give me just an example of who would be the consumers of the reports that would be generated, and what kind of information would you be talking about going into the reports? I'm just trying to understand, how does this work? Who's using the report? What data are they using?
That's a really good question, Representative McLean. I think the intent of the report is to provide information to the buyers in our state. And when I say about the buyers, it's the people who buy the prescription drug benefit. Is helping them understand what's a reasonable contract, what's a reasonable price. So when they're negotiating, they have some benchmark to benchmark against. Today, they don't have anything. There's no recommendation saying this is a fair price, this is not a fair price. It doesn't, I want to be clear about this, it does not in any way disallow someone from charging whatever they want. What we're talking about for recommendations, which is back to the same thing in the free market, is saying this is a reasonable price, this is not. If you go out, if you think about the Kelley Blue Book, it tells you what a reasonable price is to buy a car. Does it not? It doesn't mean that the dealer can charge whatever they want. They can charge $100,000 for the car. But the Kelley Blue Book says it's only worth $30,000. It's still your choice to pay the $100,000. But at least you have something to go back to look at the market and saying, what's reasonable? We don't have anything like that. This market is so opaque. It's like walking into the dealer and saying, I like that car. What do you think it's worth? And you're relying upon them telling you what it's worth versus going to a third party like the Kelley Book and saying, based upon the Kelley Book, I think this is reasonable. What you charge me and what you want to charge me is unreasonable. But there's no reference, if you will, Representative McLean, there's no third party database to help.
Follow up?
So I'm going after this information. You mentioned that we have a whole bunch of DHHS. Are they going to be the primary information reserves that you're going to, or you're going to be going to the manufacturers themselves? And the compliance mechanisms that you have in here, is it just the departments or is it for everybody?
If you would, when you say compliance with the
So
data
basically
call,
you're
or
saying, so I have a data call and you don't give me the data. So after 14 days, and I said, this is fair, this is a reasonable request, you're not meeting this request. So you owe me $500 or whatever it is, $500 a day up until I hit 25,000 and then it caps off. Is that being paid by the non-compliant department or the manufacturer? Can you go to the manufacturers themselves? Who are you seeing as the people that are going to be paying that fine?
the entity that's required to submit the data is the one that's going to be on the hook for the $500, not the department that receives it. So be clear, if you're asking from the manufacturer, they're the ones on the hook to comply. If it's coming from the PBM, it's coming from the PBM. Whatever the entity is that's being asked for the data, they're the ones that are on the hook to pay you the fine if they don't release the data.
So I noticed that the fine caps out at $25,000. So given we're talking about hundreds of millions and billions of dollars, and information is very valuable, how is that amount arrived at, and do you think that that's an effective stick or not? It could just stonewall you.
They could call it a cost of doing business. I don't disagree with you. I think it's a place to start. If we find that with people stonewalling us at that point in time, and $25,000 on a $1.7 billion worth of book of business is just the cost of doing business, then I think we need to come back to the legislative body and saying it's not working. They're stonewalling. We need to have a way to break through it, whether it's with fiscal penalties or some other way to get there. I don't know, but I thought it was reasonable at $25,000 to cap it, to begin the process and not get into something so onerous that it would be so difficult to even get it to the legislative body.
Thank you.
Representative Woods, and then, did I see someone else? Yeah, okay. Then, yes, I know. Yeah, go ahead, Representative Woods.
Thank you, Mr. Chair. Thank you, Representative, for taking my question. Good to see you. I'm concerned about this nebulous reasonable price. Reasonable in the eyes of myself as an end user will be vastly different than the reasonable price if I'm PBM, and it's vastly different that if I'm a pharmaceutical manufacturer putting out a drug that's may save millions of dollars and thousands of lives. How do you arrive at the ground level of this is a, and what factors do you include when you say it's a reasonable price?
Well, that's a very good question, Representative Woods. It's one I wrestle with. But there are third-party entities that spend a lot of time and a lot of resources trying to come up with something that's reasonable. You have ICER, which is available. It's out there in the marketplace. When new drugs come to the market, they do actually develop what they think is a reasonable price for it based upon the market, based upon the resources used to create it. It does not preclude somebody from paying more than that because the board is basically making a recommendation. So you have the issue of what's reasonable and how you define it. I think it's also a critical question for the advisory council, which is comprised of many stakeholders, and asking for their input as well. So it's not like the board's making this decision in a vacuum. It's really looking for broad stakeholder opinion before they try to come up with some recommendation.
Follow up?
Thank you. In that consideration, I guess I'm trying to say if you consider the social value of drugs as well. We think about the immediate value of, solving someone's problem, either getting rid of Representative Jess's cold versus someone curing cancer, and those have value. And some have other social values as well. Is that taken into account in discussion with one of the, this is a true story, one of the drug reps that has the Hep C. And as you know, a dosage of Hep C is horrific. And my query was, why? Well, we're saving society millions of dollars. We feel we should get some of that in return.
That I totally agree with. I think when it comes to trying to understand what the fairness of a price comes into multiple factors, including offsetting medical costs. I can remember when H2 or Peptid, if you will, hit the market, and it was supposed to be very expensive, but it was saving surgery. There was ways to prevent it. So you have to look at, to your point, the whole cost spectrum. So it's not like you're looking at strictly one piece of it, but you got to look at the whole overall impact of healthcare. So we're not trying to just isolate the drug cost by itself, but looking at the overall impact.
Representative McGrath and then Representative Kofod.
Thank you, Mr. Chair. Thank you for taking my question. Can you explain how, being a pharmacist, a prescription PBM negotiates with the insurance on behalf of tens of thousands of patients for the best price, and yet that price is hundreds of dollars more of every generic discount card that's negotiated with a pharmacy?
No, I cannot. And that's part of the reason I'm trying to, with the Prescription Drug Affordability Board, begin to understand it. I just came across something the other day, not to just divert myself, but a lot of the prescription discount cards we have, do you realize that they sell your data? Yeah. We in our Constitution have data protection, seriously, that we put in the Constitution. Here we are taking these opportunities and letting people sell our data. There are, which came to our attention at the board, ways to use a card like that from other states that created something that prohibits them from sharing that data. That's an example. But back to your question, which you asked, there's no way right now. I mean, if you look at Mark Cuban, this market is so opaque. It's like the Wizard of Oz behind the black curtain, trying to figure out what's going on. And until you pull it back, you don't really understand it.
Representative Kofod.
Thank you, Mr. Chair. Thanks for taking my question. So I have a couple of questions actually, but the first one is a follow-up to Representative Wood's question regarding what's reasonable. So would potentially substitutable pharmaceuticals be an example? Like, would that be a basis for determining what is reasonable if there's a generic or other substitute that could be offered in replacement?
Representative Caulfield, I think we're talking about another bill that's being brought forth, and that's in the biologics. And when you look at the biologic market right now, it's unreasonable because you have a situation where the pharmacist cannot allow an interchange with a patient to save them money. So the reasonableness it comes back to is what is reasonable based upon what's available. So if you have competing entities on the product or on something comparable to it, and you can save money for the patient, should we not allow the marketplace to do exactly what it's supposed to do and allow people in the play, if you will, to be able to take advantage of that on behalf of the patient or a payer? So reasonableness is really not defined in one particular way. It's defined upon many different ways to define it. So I'm with you 100%.
Follow up.
Can you offer specific examples
Yeah.
of pricing
Sure.
in that category?
The last time I was last year talking about drug, you have a Humira, and you have Humira $80,000 a year list price, and you have something else that's drug B, which is probably $40,000. Sounds like a great savings. And you have another one, drug C, which is $20,000. But if you don't have a situation for the pharmacist to allow them, the market, if you will, work with the patient saying you should have a choice between Humira, B, or C, 80, 40, or 20. That's a question of bringing that type of transparency, that kind of information to the buyer to allow them to understand what's available to them. And right now, that is not really readily available. It's like goes back to my Blue Kelly book. It's having something that somebody can look at and saying, this is where the market prices are. These are comparable products, and this is something you can work with. If you think you need to go back to your physician, go back to your physician, but you need to educate the buyer about what's there, including physicians. For the most part, they're trained, nothing against Dr. Woods here or Dr. Palmer, or Dr. Delsey. They're focused on your care and trying to get you the best thing for your care they possibly can. But there should be a way for all the parties to have access to data about what the prescription drugs cost and help them understand what the choices are economically.
Other questions? Final one.
Sorry. So would this bill provide the board with the information that it needs to increase the transparency around rebates specifically?
I can say that it will provide the board with more information that it needs to begin the process of transparency. I cannot guarantee that having the data is going to do that, but I can say what we're doing today without the data is not working.
Anyone else? Seeing no one else, thank you.
Thank you.
Also signed up to speak is Dr. Jason Aziz, I believe it is, from NHID PDAB. And could you identify the person with you?
Good afternoon. Thank you for your time to hear us. I have with me here Morgan Harris. She's our Director of Healthcare Analytics at the Insurance Department. My name is Jason Aziz, Director of Health Economics at New Hampshire Insurance Department. Ms. Harris works with the prescription drug rebate data submitted to the department by PBMs. We wrote a redundancy elimination report at the direction of the New Hampshire legislature, published it late last summer. To my recollection, it's posted to the PDAB's website, the New Hampshire PDAB's website. And we did see some reference to redundancies and streamlining the efficiencies for data collection, sharing, and reporting. So the department has a neutral position on this bill, but we're here to answer any questions that might arise.
Right, thank you. Any questions? Wow, okay. I guess I'll question out at the moment.
Okay, thank you for your time.
Thank you.
Yeah.
Also signed up to speak is Linda Hodgson who's a volunteer with AARP of New Hampshire.
I've changed my good morning to good afternoon. Thanks for hanging in there. Good morning or good afternoon, honorable members of the House Health and Human Services Committee. My name is Linda Hodgson and I live in Epsom. I'm here to testify on behalf of AARP New Hampshire to express our strong support for House Bill 645. In my prior 30 years working for the state, I was Medicaid Finance Director at one point, and in my last position, I was Commissioner of Administrative Services. We were in charge of administering the active and retirees health program for over 40,000 lives. In both jobs, escalating drug costs were a challenge to understand and to try and manage. Data made all the difference, and data saved the state money. I am concerned about the rising cost of prescription drugs and its impact on older adults in our community. An article I read over the weekend stated the two largest age groups in New Hampshire are 55 to 59 and 60 to 64. In the same article, the New Hampshire's Office of Planning and Development projections for the population in the 65 plus community is an expected growth of 66% from 2020 to 2040. As many of you know, the 55 plus community is the group that AARP represents. I fully support the New Hampshire Prescription Drug Affordability Board and its goal to make prescription drugs more affordable for Granite State families. It's a valuable resource for New Hampshire, and we need to support it. I support House Bill 645 because the PDAP needs access to data to do their job. Fortunately, much of the data they need is already being collected by other state agencies. House Bill 645 will create an efficient way for the PDAP to access this data, helping them to fulfill their mission on behalf of New Hampshire citizens. With access to the data, the PDAP can better address high prescription drug costs, benefiting consumers facing expensive drug prices. In conclusion, I urge the committee to support House Bill 645 to ensure the PDAP can work effectively for New Hampshire residents. The PDAP is a great resource, and we need to use it to support its mission to improve access and affordability of prescription drugs for all of the Granite State families. Thank you for your time, consideration, and attention.
Thank you. Any questions? I'm seeing none. Okay, thank you.
And I have written testimony. It'll be submitted through the portal.
Okay.
Thank
good.
you.
Thank you. That was the last person who had signed, she was the last person who had signed up to testify on 645 FN. Does anyone else wish to testify? If not, I am going to close the public hearing on HB 645 FN and open the public hearing on HB 724 FN and recognize the prime sponsor, Representative Hecken Phillips. Before we get too deeply, we needed your pink card, by the way. Oh, you've got it, okay. Sure. I'm going to turn the gavel over to the Vice Chairman, Representative Mazur. I'm going to step out for a short time. I'll turn the hearing over to her. And then with that, Representative Hacken Phillips, you may proceed.
Thank you, Mr. Chair. Just a matter of process. I'm wondering if the committee's already been provided copies of Amendment 0222H in regards to HB 724. If you've not received it, I'm happy to bring that out.
Ms. Grant, I thought Karen Davis was going to give that to us, but I don't think I've seen it yet.
We have.
Oh, here it comes. There it comes.
Fantastic timing. Thank you. Thank you, Mr. Chair and members of the committee. Good afternoon. I'm Representative Mary Hacken Phillips of Grafton 12, serving Hanover and Lyme, and I'm very pleased to be with you today to introduce HB 724 relative to lead paint poisoning prevention and remediation. At this time, I'd like to offer amendment number 2025-0222H, which is being passed around the room at the moment. This amendment will replace the bill in its entirety. If it permitted, Mr. Chair, the only difference from, or Madam Interim Chair, the only difference from the bill and the amendment offered is that Section 2 of the original bill, which lowers the threshold for blood level investigations, has been removed, given it has a significant fiscal impact. The original intent for the bill was to offer a no-cost, high-impact solution to prevent or remediate lead poisonings. And so I'll be focusing my testimony today on that amendment during today's hearing. But of course, there will be folks here, and I'm happy to speak about that section at a later time if the committee so chooses. So to begin with, the prevailing belief is that lead poisoning in kids is a problem that New Hampshire solved decades ago when Congress banned lead paint essentially in 1978. We understand the cause and we know what the solution is. Scientific experts inform us that lead exposure through paint, dust, consumer products, and water causes elevated blood levels in children who are more susceptible to poisoning than adults. Children with elevated blood levels in turn experience reduced learning capability, ability to pay attention, and academic achievement. But high levels of lead poisoning can cause irreversible health damage, and this is a permanent trauma to the child and their family. The solution once a child is poisoned is very expensive. Medical interventions and treatments for the child, remediation of lead in the property, or a complete disposal of the product, and ongoing financial support for education, emotional, and behavioral development at school and in our communities. So you see the effects ripple wide, and they're just devastating. So the sponsors argue that we have a duty and a moral imperative to act, so that we're not waiting for New Hampshire's babies to be poisoned before we do something about it. Thankfully, Congress has passed many laws in the past aimed at preventing lead poisoning. For instance, Congress in 1992 passed an act that requires lead paint disclosures for most real estate built before 1978, which has really increased the public's awareness of what lead paint is doing in aging housing. And in particular, in 2008, the EPA established the Renovation, Repair, and Painting Regulatory Program, which requires contractors and landlords to be trained and certified in lead-safe practices to lawfully work on projects that disturb lead-based paints in homes, childcare facilities, and schools built before 1978. Here in New Hampshire, the legislature has most recently passed RSA 130-A:5-D, which requires property owners to have a lead-safe certificate prior to occupancy, and newly constructed rental properties and newly licensed childcare facilities located in buildings that were constructed before 1978. So these laws, together, and others, make up part of the solution to reducing lead poisoning. But the New Hampshire Department of Health and Human Services December report, based on its own testing data, indicates that these solutions are not enough. Members have received copies of this recent DHHS report in their legislative mailboxes, and I really encourage everyone to check this out. Perhaps you've learned or heard about this in the news reports that have been across our state in the past week. DHHS's report says the number of children here in New Hampshire identified with elevated blood levels has increased since 2021, and it's at its highest level since child blood lead level testing was enacted in 2018. That's right. And an estimated 1,142 children here in New Hampshire have elevated blood lead levels high enough to impair their ability to think, learn, and concentrate in 2023. So concentrations of child's lead poisoning is most pressing in Manchester and Nashua, but no community, no region, and no county in our state has been unscathed. Moreover, poisoning numbers are probably worse than reported, given that not every child in New Hampshire is tested. So here's the takeaway. The lead poisoning problem in New Hampshire has gotten worse, and we have to do something about it to keep our kids safe. So this legislature can affirmatively act by advancing HB 724 as amended, and to take another step towards the prevention and remediation of lead poisoning today. The amended bill has 3 no-cost solutions for your consideration, and I'll just briefly explain those now. So if you're looking at Amendment 0222H, it changes our RSA 130-A, the lead paint poisoning and prevention control chapter law, with the following additional paragraphs. So section 1 of your amendment requires that building permit applications include the EPA RRP license number for any person engaged in renovation, repair, or painting of buildings erected prior to January 1st, 1978. Under the existing EPA's renovation, repair, and painting rule, homeowners are already required to use a licensed service provider for these projects, so the change to an application form helps remind contractors and homeowners of their legal responsibility. The New Hampshire Municipal Association's Town and Cities magazine noted that municipalities have a role to play in preventing childhood lead exposure. And many municipalities here in New Hampshire are already doing this. It's a simple, no-cost change to an application. And you may know that towns such as Sugar Hill are already doing this. Their permit application has been printed, and it will be here for you to take a look at what this looks like in practical implementation a little later today. Section 2 of this amendment bill restores the Department of Health and Human Services authority to inspect subsidiary units if another unit in the same multi-unit building is found to have a lead paint hazard. In the past, DHHS had this authority, but at some point it was removed from statute in approximately 2018. In consultation with the department, stakeholders and sponsors of this bill have learned that the department would welcome the restoration of that authority to protect all the people in the same building that is known to have a potential lead hazard. So the department here today can verify, or the department is here today and can verify that it believes the subsidiary unit inspection work can be absorbed without a fiscal impact to the state. Finally, Section 3 of the amended bill establishes a rebuttable presumption of lead in pre-1978 housing, unless a lead inspector has determined the dwelling or unit does not contain lead-based substances. This change will create a low barrier evidentiary tool in court that any pre-1978 housing is likely to contain lead-based hazards. So this is another no-cost strategy for preventing blood lead level poisonings that have been effective in other states in our region, including Vermont. So I'm just calling on my colleagues on both sides of the political aisle, as well as in both chambers, to join the sponsors in preventing childhood lead poisonings by supporting HB 724 as amended. We hope you will agree it's a no-cost, multifaceted approach proven to reduce lead exposure in New Hampshire, worthy of your support. This will be another step in reducing the lead risk to children in our state. And please know the sponsors will continue to push for no cost, low cost, and ideas with return on investments to reduce the lead risk to children here in New Hampshire. So I know there are many advocates here planning to speak today in more detail. And if the chair should agree and the committee does not object, I'm hoping the next speaker could be Attorney Heidi Tremarco of the Conservation Law Foundation, who has several handouts that will be helpful for the committee to in framing the discussion today. So I'd personally like to thank the co-sponsors and the Conservation Law Foundation for their partnership in working on this bill. And thank you for your time. And if there are any questions, I'm happy to answer them at this time.
Thank you, Representative. Does the committee have any questions? Representative McGrath.
Thank you, Ms. Chair, and thank you for taking my question. So this graph is really interesting. We've had mandatory testing and it was going down. Do we know why? And now it's going up. Do we know why?
Yeah, so the amount of testing went down during the COVID pandemic because not as many families were coming in for their children's annual inspections when this blood test requirement usually takes place. But I'm sure the experts here can speak to the nuances as well of those results.
Thank you. Any other questions? Thank you. Can you please repeat who you said you'd like to speak next?
Yes, it's Attorney Heidi Tremarco from the Conservation Law Foundation.
Heidi, okay.
CLF. Yeah, thanks.
Thank you. The chair does recognize Haiti Tremarco. You have 3 minutes. Thank you.
Thank you. Nice to see you again. My name is Heidi Tremarco. I'm an attorney with the Conservation Law Foundation. And 3 minutes is quick, so I will run through my material. I've submitted written material in support of the bill. And you're getting a hard copy of that now, and that has some documents attached to it. So that might be helpful when you are looking. It has the DHS 2023 data brief. It has a building permit from the town of Sugar Hill, so you can see what this looks like on a building permit. And it has one of the economic studies cited in my testimony. I'd also like to note some testimony that the committee should have received electronically from people who wanted to testify in support of the bill but can't be here today. The first is Dr. Christine Arsenault from the New Hampshire Pediatric Society, or the New Hampshire AAP, the chapter of the Pediatric Society. The Pediatric Society strongly supports the bill and urges the committee ought to pass, and you should have her testimony. Also testimony from Charlene Lovett, the former mayor of the city of Claremont, who also supports the bill and brings a real municipal perspective and discusses how Claremont has done similar things that this bill provides to remediate lead problems in Claremont and how that worked in Claremont, and urges the committee to ought to pass this bill. As you've heard, and as I hope you've seen in the data brief and in the news, the recent DHHS report shows the highest lead poisoning levels in children since we began recording those numbers in 2019. And the jump up to 1,142 children, which is a 42% increase from 2022, cannot be attributed to an increase in testing alone. For example, the testing in 2023, the numbers of children tested is very similar to the numbers tested in 2019 before the pandemic. So we're testing about the same number of children and having elevated, more kids poisoned by lead. And as the sponsor told you, not all of the kids are being tested. So about 70% of our children are being tested. So we know there are a lot more children out there who are likely poisoned by lead. And we can also understand that a lot of these children who aren't getting tested are probably our most vulnerable children and more likely to be exposed to lead hazards. And the data bears this out. It is our poorest children in New Hampshire who are the most susceptible to lead poisoning. They are twice as likely to be poisoned by lead. And for New Hampshire children on Medicaid, 1 in 10 is poisoned by lead. It's really tragic. There are some experts here today who will talk about what happens when a child is poisoned by lead, why this is so terrible, and the lifelong impacts that child will carry. I have references in my testimony as well to support that. And I know the committee has a lot of medical experience, and you can all draw on your personal knowledge of what the dangers of lead poisoning. But I'd like to point out to the committee really quickly, and you'll see this in my testimony, that the state has also studied that investing in lead poisoning prevention saves the state a lot of money. DHHS in 2014 estimated that medical treatment and special education costs for lead poisoned kids cost the state roughly $300,000 a year, which in today's dollars is about $500,000 a year. And taking into all of the other expenses that occur in families and communities and the state, the cost of lead poisoning is in the millions of dollars. And there's references to DHHS's report. I didn't bring it because it's like 25 pages, but the link is in my testimony, so you can go read that data for yourself.
Thank you. If you could start wrapping up.
Okay. I'd be happy to answer questions about these 3 provisions, which are geared at preventing poisoning in the first place. So requiring towns to have the RRP number on their building permit. You'll see in the Sugar Hill building permit, this is a 1-line addition to a building permit. It just says contractor name, license number. So they're already required to be licensed. This is just a simple prompt on a building permit. And you'll see in Mayor Lovett's testimony that this simple prompt encouraged more contractors in the city of Claremont to become RRP certified and to engage in lead safe practices. It also lets homeowners know that there's lead hazards in their home I think that people are often under the assumption that this is a problem we have solved. This is a simple way of letting people know this problem is still there.
Thank
The
you.
other-
I really do need you
Okay.
to wrap up. Thank you. Does the committee have any questions? Representative Woods.
Thank you, thank you for taking my question. This license, especially in some of the more rural areas, does that impact the ability, or does everybody, all of the contractors have this as a matter of fact? Or is this going to impact people being able to do repairs on their home?
Thank you for the question. So the contractors are already required to be RRP certified. This bill does not put any new requirements onto them. So that's a federal law. It also applies in certain situations under EPA's RRP law. And so this just prompts when they're doing renovations on a home, when submitting a building permit, to provide that number. And I think Mayor Claremont's testimony, I'm sorry, Mayor Levitt's testimony about the Claremont experience does speak to how a community benefited from this provision.
Yes, follow up.
I'm not sure I asked the right question. If you're in a rural area, and someone wants a renovation done, they go to get a permit. Well, the fellow contractor doesn't have a license. Now, is that a significant imposition in any way to get remediation?
Thank you for the question. I'm not aware of how many unlicensed contractors are out there working. I mean, that would be in violation of existing law, so I can't speak to that. But I can say that the communities that have put this into place are kind of varied across the street. So we have Sugar Hill, Waterville Valley, Easton, Merrimack, Madbury, Claremont. These are a variety of communities who are recognizing it's important to get this on their form, and I don't think it's been an impediment. I'll also add that Municipal Association has told me and authorized me to say on their behalf that they don't think this provision will add any cost to municipalities.
Thank you. Representative DeLemus.
Thank you, Madam Chair. Thank you for taking my question. So when you say contractor, are you talking construction contractor or painting contractor?
Thank you for the question. So it is anybody engaged in work under EPA's RRP law. And so that's renovation, repair, and painting of pre-1978 housing. So there's a very specific set of work that triggers this provision. Okay. And it is anybody engaged in that work. So if you have a home that was built in 2019, this wouldn't never apply to that, or a new build house, this wouldn't apply. It's a specific rule for people who are engaged in work that has to deal with lead hazards under this federal rule.
Any other? Yes, Representative Lucas.
Thank you, Madam Chair, and thanks for taking my question. Wondering about the situation, at least in my community, it comes up quite often, and people do their own renovation. They don't hire a contractor. How is this going to address the situation, if at all?
Thank you. So often the RRP rule does not apply to home renovations in people's own homes. And it is really tragic. And I don't have the data, but I've talked to a lot of lead experts about where is this increase in poison kids coming from? And some people do speculate that there is a bump in DIY home projects, particularly since the pandemic. We were all home, we were all doing work in our homes. Perhaps, and again, I don't have data to back this up, perhaps that's one of the reasons why we are seeing these increased numbers. So this provision wouldn't impact, the DIY, I'm going to go paint my hallway. But as a whole, I'm trying to get the word out about this. I think the provision on a building permit prompts a conversation in communities, and people go to fill out their form. They see it there. You look at these building forms now, it says, what are the wetland impacts? What are this, that? Lead paint is not on there. It should be. People should be thinking of this. Where do I live? Where do my neighbors live? So it's to raise awareness, and the same with the rebuttable presumption is to raise awareness to this problem. And I'm telling everybody I can, we have not solved this problem of lead poisoning. It is here. We know what the solutions are. We know what the problem is. So it's part of that effort. But I don't have a perfect solution for in-home projects.
Thank you. Anyone else? Any further questions? Thank you.
Thank you.
For testifying. Next, we have Kate Fry.
Good afternoon. My name is Kate Fry. I'm the Vice President of Advocacy at New Futures. I'll be very brief. I do have written testimony. New Futures, we appreciate the testimony speak in support of House Bill 724. We're a nonpartisan, nonprofit organization that works through problems, through policy change. In this role, we work extensively with policymakers and healthcare providers regarding increase to access quality, affordable healthcare. So regarding this bill in particular, we stand in strong support of House Bill 724. I really appreciate the sponsor saying ahead of time that this is a no-cost solution to the lead poisoning prevention epidemic that's really been happening in our states for years and years and years. For context, I worked at the Department of Health and Human Services 10 years ago, and we were working on this very issue, and I feel like it's deja vu. What I really just wanted to focus on in this legislation in particular is while we made a lot of changes through SB 248 in 2018 that were really great steps regarding childhood lead prevention policies, there was a huge step back with that legislation. So prior to 2018, the department had the authority, when it had a lead hazard in one housing unit, the agency would be able to inspect other units within that building to check for lead. This was just common sense primary prevention. You don't want a kid to be the canary in the coal mine. If you know that there was a kid in another unit who was poisoned, you should be able to check the other units. That was changed in SB 248, and I think that was a big step back in terms of primary prevention. This bill fixes that, and my understanding is the department is on board with that. So it does also identify other solutions to which Heidi spoke about, of which we are in favor. But I would just really ask this committee to consider this bill closely as further steps we can take to prevent our kids and keep them safe. And I ask you to vote to pass.
Thank you. Does the committee have any questions? Seeing none? Thank you very much. Next, we have Nick Norman. Oh, I'm okay. I'm sorry.
Yes.
Don't know your name.
Thank you very much for the opportunity to speak. My name is Nick Norman. I'm an advocate for housing providers. My association is a network of property owners throughout the state in various different associations that work together on legislation. We look at all legislation that affects real estate, and particularly landlord-tenant law. We have a membership of about 3,500. We give out a legislative update to those members each week during this legislative season. I'm a landlord for over 30 years, probably about 35 years. I've got a number of properties myself that are older. I've been very involved in the lead world, so to speak. I've served on 2 year-long lead commissions. I've served on a committee that rewrote the rules for lead in the state of New Hampshire. I teach the RRP course that people have been talking about, and I have a very large knowledge and background on the subject of lead. So I would like to invite everyone to be asking me questions to get in perspective from a property owner's position. There are tremendous amount of problems with this bill and the cost that it will create. It is absolutely not a no-cost solution. I'm sorry to hear that that's been represented to you. I've got a lot of things to say. I have talking points that I will pass out a copy. I have emailed you last night, and I probably won't have enough time to go through it, but I invite you to ask questions. So I'll just get started, and I guess you'll have to pull the hook at some point. landlords did not create the lead hazards. The use of lead-based paint was dramatically popular. It was the best functional paint ever invented. Unfortunately, it was extremely poisonous at the same time. It was very commonly used, very much recommended to be used, and it's just a plague on our society. It's a societal problem. It should not be placed to one set of stakeholders, namely housing providers, to brunt the full cost of this. And every time there's a piece of legislation, it's always aimed at forcing housing providers to pay for this solution, which is not something they created. It was part of our society. The cost of abatement ranges all over the place. If you have a little bit of work to do, it's going to be a little bit of a cost. If you got a lot of work to do because nothing's been done over the years, it's going to be a larger cost. But there is an average. In the last set of grants that were in Sullivan County, the average cost was $30,000 per unit. In Nashua, it was $28,000 per unit, and in statewide, it was $26,000 per unit. So if you have an 8-unit building and you find out that there was one child that had an elevation, and the present law says any other units with children will be inspected, and you end up with 3 units in the building that come under order. So now that's 3 times $30,000. That's $90,000 average. It's not, precisely that number. But if we switch back to inspecting all units, then that will become 8 units under abatement order. That'll be 8 times 30. That'll be $240,000. How can you say moving from 90,000 to 240,000 is no cost solution?
Sir, if you could please start wrapping up.
There's probably 3 hours more to talk about.
If
What's
you have
more
I'm
important?
sorry, if you have written testimony, we'd be glad to see that.
So testing data, let's talk about that. In
I'm-
2010,
You are going to need to start wrapping up, sir.
this will be a wrap up then.
Okay.
2010, 17% of the children tested measured between 5 and 9 micrograms per deciliter. People are talking about so much more elevations. In 2022, that was 0.49%. We've done an amazing job in reducing the amount of lead poisoning in children. And it's because the property owners have been brunting the face of this and paying for renovations and eliminating lead hazards.
Thank you.
Go ahead.
In courtesy to other speakers, I will
Yep,
have you
I
wrap
understand,
up,
but
We
please-
would be glad to have you email that us so we can really look at what you have.
I emailed this last night. There's one
Perfect.
update to it that I have another link to have referred to.
Okay,
There's a lot to say about the RRP that's been misrepresented.
Thank you. I'll open up it to committee questions. Representative DeLamus.
Thank you, Madam Chair. Thank you for taking my question.
Thank you.
Is there, if this, let's say you've got that scenario, you've got your 8 units, they come in, it needs to be remediated. Is there any recourse with insurance or anything like that?
No.
No.
There is, HUD offers grant money. And the state of New Hampshire has some grants from HUD to do lead abatements. The crazy thing about it is that you could use RRP to handle the renovation to get the property back to an abated, safe state at half the cost of an abatement.
Thank you. Any other questions? Yes. Representative Lamontagne.
Thank you. And I was going to ask the same question about grants. And have you used grants yourself to help pay for the abatements?
I have. And the process is fraught with several problems. The grant money can be a godsend. If you've been given an abatement order, you have no choice. It's like you're going to have to either pay all of this money or you turn in the keys and you lose the property because you can't afford it. And that's happened many, many, many times to property owners. You got someone that eats some applesauce that was tainted with lead in 2023, and now they have an elevation, and now the property is put under order. So yes, I've used the grant money voluntarily, and I've learned a lot about it. And some of the issues with it is that the grants are approved not based on the property owner. The grant is approved based on the income of the tenants. So if the tenant's income is above what HUD allows, you don't get the grant and you're still under order. And the grant and the abatement is the most expensive way to handle the solution. It can be handled at almost no cost.
Thank you. Representative Siebert, did you have a question?
That kind of covered it.
Okay, any other questions? Seeing none, thank you, sir. Next, we have Rick, is it? Okay, former representative, and I'm sorry, I did not know that. You should have put that on your pink card. Former Representative Rich, oh dear, Patima?
I'll help you with that. Depentima.
Depentima, thank you. You have 3 minutes.
Thank you, ma'am. Thank you. Good afternoon, representatives. I'm a former member of
One second.
Before your time starts, can you spell your last name?
Sure. D-I, capital P as in Peter, E-N-T-I-M-A. Penmanship was not my best subject in school.
Thank you for your patience.
So thank you, Representative. Glad to be here. I'm a former member of the House and a member of this committee for 4 years, and glad to be home. And some of my former colleagues, Jim McKay, who served with me. I'll read my testimony so it'll be quick and easy. And I sent it to you online as well. Again, my name is Rich Depentima from Portsmouth, New Hampshire, former state representative. I've had over 30 years of public health experience, and I won't list all of it, but most of it was I worked for the state of New Hampshire Division of Public Health Services, Assistant Director of Public Health, Chief of Communicable Disease Epidemiology. In Manchester, I was Deputy Director of Public Health in Manchester and also Chief of Environmental Health in the city of Manchester. So I had a lot of firsthand experience with lead poisoning during my career. Over my more than 30 years of public health, I've had extensive involvement in the serious problem of childhood lead poisoning. Unfortunately, despite years of effort to institute common sense primary prevention of lead poisoning, we are still waiting for children to become poisoned and even having their brains permanently harmed before we take action. The most devastating consequential event in my public health career was leading the investigation of a death of a 2-year-old child in Manchester as a result of lead poisoning in 2000. This child, having arrived as a refugee, was placed in a home in Manchester with serious lead hazards. Within 2 months, she suffered acute lead poisoning as a result of ingesting lead paint with a lead content of 35% by weight. Her blood lead level was 391 micrograms per deciliter. I'm still haunted by that investigation. Yet, even with the death of almost 25 years ago, we are still refusing to properly prevent and manage this ongoing crisis. In fact, a recent state report, as you saw, that 1,142 children have been reported with elevated blood levels, the highest number ever reported, and probably a very underreported number because of the lack of testing of all children age 1 and 2. It is long past time for New Hampshire to start treating lead poisoning like every other disease. We need to put prevention first. A number of years ago, when New Hampshire noticed loons dying of lead poisoning for ingesting lead fishing tackle, as a result, the legislature acted very swiftly to ban the use of lead in freshwater fishing tackle. This was the right thing to do. If we can do this for loons, why can't we take aggressive action to prevent lead poisoning amongst our precious children? Not only are human costs of lead enormous, so are the economic costs. The medical expenses, special education costs, criminal justice costs are huge. A 1991 CDC report concluded that the U.S. pre-1950, this was pre-1950 housing, for which 80% contained lead paint were abated, the cost savings over the cost of abatement over 20 years would be $28 billion. At any rate, the money saved by governments, individuals, and communities would be vastly more than the cost of abatement. We've been kicking this can down the road for over 50 years while children continue to become poisoned as Einstein said, continuing to do the same thing over and over again and expecting different results is the definition of insanity. Although the symptoms of lead poisoning are silent, responsible leaders and child advocates cannot continue to remain silent about what needs to be done to end this epidemic. New Hampshire could make history by putting in place a primary prevention system to finally end the scourge of childhood lead poisoning. While we cannot undo the harm caused by our past neglect, we can celebrate commitment to the future generation of children. Thank you.
Thank
Be
you.
happy to answer any questions.
Thank you. Does the committee have any questions?
Yes.
Yes, Representative Siebert?
Yeah, I was kind of a statement. I just wanted to say thank you for coming to testify. And I know what you're talking about. I actually saw that on an episode of Forensic Files.
If you could ask a question.
Yeah. So do you believe that our citizens deserve to be, for when they move into a property, let's say, whether they're renting it or buying it, they deserve to have a clear, have it on the RFP, have it made clear to them that whether the house has lead or not.
Well, thank you for the question. I think right now there is a requirement that if you sell a house, if you have lead, you have to disclose that to the prospective buyers. That includes people who buy rental properties. When they buy a rental property, whether it has 2, 5, or 10 units, they know before they buy that property whether it has lead hazards in it. So they are buying a property with the knowledge that if they don't do anything to those units that have lead, that they are going to be renting it to people. So they know it ahead of time. So once a child becomes lead poisoned, they shouldn't be surprised by the fact that a child became lead poisoned. They should have known it ahead of time when they bought the property and maybe could have negotiated a lower price for that property because of the existing lead hazard.
Thank you. Representative Lucas?
Thank you, and thanks for testifying today. How long has that been in effect? The disclosure of lead in property
Oh, I'm not
purchases?
sure exactly, but at least 20 years, at least. I'm not sure the exact date, but
Thank you.
Thank you. Any further questions? Seeing none?
thank you, ma'am.
Thank you. Next, we have Molly Ellis. We ask that you keep your testimony to 3 minutes, please.
Good afternoon. To the Honorable Chair and members of the Health, Human Services, and Elderly Affairs Committee. My name is Molly Ellis. I'm a resident of Keene, and I'm here today to ask you to vote in support of House Bill 724. And I apologize that I did not see the amendment before I wrote my testimony, so that threw me off a tiny bit. But a few years ago, I received news that my son's lead level was elevated, so I went on a mission to learn all that I could about lead poisoning, and I learned that the level considered to be safe has been lowered repeatedly over the years because doctors have learned that even very low levels can cause harm, and in fact, there's no safe level of lead in the blood. And I realized that the amendment to this bill does scratch that requirement for lowering the maximum level permitted in the blood before public health gets involved. But I think that speaks to the importance of the second part of the bill, now the only part of the bill, the importance of contractors using proper lead safe techniques when doing renovations. Our home is a fixer-upper. And we had done lots of projects on it, and any disturbance to materials containing lead, such as sawing, scraping, sanding, creates increased exposure to lead, and that's probably what caused our son's lead poisoning. As homes are the primary reason contributing to children's lead poisoning, the most effective way to prevent lead poisoning is to be aware of the presence of lead and to use lead-safe remediation techniques when doing renovation. So please vote in favor of House Bill 724, and thank you for your time and consideration.
Thank you. Are you taking questions?
Yes.
Does the committee have any? Yes. Representative Drew.
Thanks for taking my question. Going back, I may have missed it. Are you renting? Did you buy?
We own our home.
You own your home. Well,
Yes, follow up.
were you notified that you had a lead hazard in your home when you purchased it?
We knew that because it was built in 1850, it contained lead.
Okay.
So I'm sure it was on some of those pages of that we signed, but we were aware. We were not aware. We just assumed, oh, you just paint over it. You know, we were not aware that painting over it doesn't solve it. We were not aware that there are really specific, like legally defined techniques for safely remediating lead.
Thank you. Any further questions? Seeing none? Appreciate
you.
it. Next, we have Katie Hatcher. You have 3 minutes, please.
Good afternoon. My name is Katie Hatcher. This is Kim Bernard. We work at the Nashua Division of Public Health and Community Services. I'm a public health nurse. I'm also the lead coordinator for the program, and Kim is the chief public health nurse.
Good afternoon. We wholeheartedly support and recommend the changes to Section 3 that states when a child living in a rental unit is identified as being poisoned, that all other units in the dwelling should be inspected, regardless if there are pregnant women or children under the age of 6 living in these units. In my 6 years working in lead poisoning prevention, I can tell you that if there is lead paint in one unit, there is likely lead paint in other units. With this change in lead inspection laws, we have the opportunity for primary prevention, which is preventing lead poisoning before it happens. New Hampshire does not focus on primary prevention for lead poisoning, and that narrative has to change.
Nashua just received a $7.7 million grant for lead remediation that distributes $30,000 per unit for lead hazard reduction. Listening to the other testimony here as a parent and a nurse, it hurts my soul to hear that our children's futures are not worth the cost. I'd also like to point out that we are really disappointed and discouraged to hear about the amendment to drop the language of lowering the action level from 5 micrograms per deciliter to 3.5, which is in line with the CDC. If we don't do it now, then we need to do it soon. Research shows that even very low level exposures cause irreversible, lifelong cognitive and behavioral deficits. I've been working in the lead poisoning prevention program in New Hampshire for many years when the action level was 10 micrograms per deciliter. I was there for the transition from 10 to 7.5 and then 7.5 to 5. We can transition from 5 to 3.5. DHHS estimates that 280 children fall between the parameters of 3.5 and 5 micrograms per deciliter. That is 280 children in New Hampshire that we have the opportunity to improve the outlook of their futures and help them reach their full potential.
We're happy to take questions.
Does the committee have any questions? Yes, Representative LaMontagne.
Thank you. Thank you for taking my question. We received some emails suggesting that we're focusing too much on exposures in the home and not enough on nutrition and other causes. But isn't it true that better nutrition might mitigate some of the damage from lead exposure, but the primary cause is the exposure itself?
That's an excellent question, and thank you for asking it and giving us the opportunity to answer. So primarily in New Hampshire, lead paint is the primary source of exposure. We do see other exposure sources through imported products, food sources, and other things. As far as nutrition, yes, children that have lead exposures typically if they have a nutritional deficit, they will hold on to lead in their body a lot longer than children that don't. So we do use nutrition as a counseling tool to help families with that. That being said, it is not the only tool that we have. And a lot of children that have lead poisoning do subsequently become anemic. So certainly we monitor the nutrition, but it is not a fail-safe.
Thank you. Any further questions? Seeing none? Thank you very much.
Thank you very much.
Next, we have Christine Bayardo. You have 3 minutes, please. Thank you.
Thank you. I'll also just read to make it quicker. Good afternoon, committee members. My name is Christine Fajardo, and I'm here in my capacity as a member of Manchester's Board of Mayor and Aldermen, proudly representing Ward 4. Thank you for your time today and for your service to our state. Thank you to Representative Hacken-Phillips and the other sponsors for bringing this important bill forward. I'm here today to speak in urgent support of the proposed legislation. Over the last couple of years, I've been closely involved with the formation of the city's Lead Exposure Prevention Commission. I worked for over a year with retired State Rep Mary Heath and former Alderman Mary Heath, Senator and Alderman Pat Long, as well as our city's health department, our Deputy Director, Phil Alexikos, alongside several other concerned members of the public and advocacy groups to see that this commission was formed. The commission has 12 members and consists of landlords, property managers, lead risk inspectors, members of our city's planning and community development department, aldermen like myself, and importantly, we also have members with lived experience. This is a broad coalition of highly concerned and motivated stakeholders, and it enjoys widespread support across our city. Prior to my work on the commission, I knew that lead exposure was, of course, a problem. I had very little idea of the extent of the problem, and more so the prevalence of the problem, especially in Manchester. This particular detail has always stood out in my mind, as I think it is the most essential thing. It's already been stated, but I think it bears repeating. This is a direct quote from Deputy Director Alexikos when making a presentation to the Board of Aldermen in 2023. Lead is a toxic substance. There is no safe level of lead, and I cannot say that enough. The body has absolutely no use for lead, and it interferes with both calcium and iron absorption, which are directly involved in the development of tissues and the nervous system and the skeletal system. It can have not only acute effects, but it can result in death, as we have heard about. As it's been pointed out, we are seeing a rise in exposure and poisonings that cannot be exclusively attributed to increased testing. So I won't go into the details of that. But something that stands out to me as a potential cause, and we know there's no single or straightforward answer as to why we're seeing this increase, but what I wanted to speak today about is the increased focus on alleviating the housing shortages across our state. As more and more buildings are renovated, rehabbed, and repurposed for housing, so too will rise the risk of lead exposure and poisoning. We should fully expect that the number of children poisoned will go up. To put a much finer point on it, more housing equals more lead poisoning, and I'll wrap up. I'll leave you with this final data point, and I think it's also been spoken about the idea of the cost in dollars and cents. We know that everyone pays the price, including landlords and how other housing providers, but it's estimated that for every dollar spent to reduce lead poisoning, there is a social return on investment between $17 and $21. This should not be seen as an expense, but rather as a smart investment. It should not be seen as a punishment to housing providers, but rather a public health requirement that our state supports. Primary prevention is good math. It's good for everyone, and it's essential for our children. Thank you.
Thank you. Any questions? Seeing none. Thank you. Also signed up to speak is Michelle Woberge, I believe from the Department of Health and Human Services.
If the committee wouldn't mind, I would like to bring Beverly Druin up with me as well. She works with the department. Okay.
Okay, thank you.
Thank you, members of the committee. For the record, my name is Michelle Roberge. I'm the Bureau Chief for Public Health Protection within the Division of Public Health Services. at the Department of Health and Human Services. And with me today is Beverly Druin, and she's the administrator of the Healthy Homes and Environment section within the New Hampshire Department of Health and Human Services. Before I start my testimony, if the committee agrees, the department will focus its testimony on the amendment as opposed to the original bill. Is that okay with the committee?
Sure.
Okay. So although the department is not taking a position on the bill as amended, we would like to thank the bill sponsor for supporting efforts to reduce childhood lead poisoning. And we are happy to be a resource to the committee and are available to answer questions that you may have. And with that, I'll turn it over to Beverly to continue.
Thank you. So the department recently published our 2023 lead poisoning in New Hampshire data brief, which I believe you all have. In the data brief, the 2023 data shows that 1,142 New Hampshire children had elevated blood leads high enough to impair their ability to think, learn, and concentrate. The data in the brief also indicates that Lead Safe Housing Initiative support primary prevention efforts. Since the bill's been amended to remove the provisions to lower the blood lead action level from 5 micrograms of deciliter of whole blood to 3.5 micrograms per deciliter, the fiscal impacts to the department, should this amended bill be enacted, have significantly changed from the original estimate in the department's fiscal note worksheet. The department originally estimated the need for additional funding to support activities associated with increase in lead poisoning cases that would need environmental and nurse case management as a result of lowering the blood lead action level to the CDC's blood lead reference value of 3.5. Since this provision's been removed from the bill, the department does not anticipate significant fiscal impacts associated with the remaining provisions. Specifically, the department is not anticipating significant increases in expenditures as a result of the proposed amendment to RSA 130A:6 to require the department to conduct inspections for the purposes of identifying the presence of lead-based substances in all the other dwelling units within a multi-unit building that have been identified as having a child with an elevated blood lead level residing in that building. Since the department will already be on site to conduct an inspection in a dwelling unit of the impacted child, the inspector could also conduct inspections of the additional dwelling units within the building at the same time. Any additional work related to this provision can be addressed with existing program resources. This provision supports lead prevention efforts by addressing lead hazards in the building before a child is poisoned. The department is also not anticipating an increase in expenditures as a result of the proposed addition of the rebuttable presumption that all dwelling and dwelling units, including residential rental units erected prior to January 1st, 1978, are presumed to contain lead-based substances unless a licensed lead inspector has determined that the dwelling or the dwelling units do not contain lead-based substances. In addition, the bill proposes a new section, RSA 130A:4A, that requires all building permit applications submitted in the state of New Hampshire to include the US EPA renovation and repair, the RRP license number. The department would like to point out to the committee that we don't have the authority over the issuance of building permits. Thank you for the opportunity to provide this information. Michelle and I are both happy to answer any questions that you might have.
Thank you. Any questions? Yes, Representative Drew.
Thank you for taking my question. If a DHHS inspector has cleared a particular unit or a particular building, if a lead hazard is then found in that building, does that transfer the liability to the state?
So in the state of New Hampshire, if I understand you correctly, a licensed risk assessor is the only person who can clear a unit. They're the people who go into the unit to determine there's no more lead hazards. So if a unit has been cleared and another child has a blood lead elevation, then that unit, we would go back and we would conduct an investigation to find out what failed in that abatement, or if there's new hazards that have
sprung up or arrived since the building was cleared. Does that answer your question? Okay.
Not entirely, no.
Okay.
The issue I'm specifically concerned about is legal liability. In other words, what it seems like, and I realize this is a much broader question. When the state is doing this inspection, the state is saying that this building does not have lead hazards. And if it's then later found that that building does have lead hazards, does that liability simply fall on the landlord again? Or does it transfer to the state because the state was the one who said that the building was clear? Does that make sense? Can you speak to that?
Yeah, I think I can. So lead hazards are a moment in time. So I'll give you an example. So if I paint my staircase and it's all painted and it's pristine and there's no lead hazards, there's no chipping or painting, but then my husband moves a couch or a bureau up the staircase and bangs it and there's chips, 10 minutes later there's hazards. So when the department goes on site to do an investigation and inspection to determine if a child that had an elevation there, if there's lead hazards in the building, and we find that there are no lead hazards, no chipping, no friction, no impact, no chewable, it's that moment in time. And then maybe a day later, 10 days later, a month later, there's a child with a blood lead elevation. There could be new hazards there that we didn't see, and that liability is on the landlord. Is there anything you want to add?
So potentially a landlord could be put in the lead abatement process more than once.
Absolutely.
Thank you.
Representative Kofal.
Thank you, Mr. Chairman. Thank you for taking my question. So just as a point of clarification, so if I'm a housing provider and I want to get a lead safe certificate, am I calling upon a state inspector or am I calling upon a licensed risk assessor who is an independent party?
You're correct. You are calling on an independent New Hampshire licensed risk assessor to give you that lead safe certificate.
Other questions? Representative McGrath.
So this is, thank you, Mr. Chair. Thank you for taking my question. So this is important work, but I've heard people mention things like applesauce and other sources of lead. How do we assess that maybe the child has been exposed to some other source? Like how does those cases get discovered?
So our data tells us that of the children who have blood lead elevations, 70% of those children have been exposed to hazards from the built environment, the house. 15% are from consumer products and 15% of those are from drinking water. So when we go and do an investigation, Katie Hatcher is one of the people who spoke earlier who does investigations on behalf of the state. She's a nurse, a contracted nurse to the state. She'll go out and interview the family to find out that child's play habits, eating habits, where they go and where they act, so we can identify where the source of the hazard might be.
Other questions? Seeing none? Okay, thank you.
Thank you.
Thank you.
Also signed up to speak is Sarah Holland from the New Hampshire Realtors.
Good afternoon. Thank you, Mr. Chair. Thank you, committee. My name is Sarah Holland. I am a real estate broker in central New Hampshire, and I am the current chair of public policy for the New Hampshire Association of Realtors. The realtors have concerns about this legislation regarding the timing and adding to the already escalated housing crisis that we have. And this is a very narrow objection on this legislation. So with this legislation, if there's a concern with one unit, then there's going to be a concern to mitigate all units in a particular building. And as Mr. Norman had noted, there's an added cost for that. And that's going to be coming through either a grant program or it's going to be coming out of the pocket of that particular landlord. And that creates additional financial strain. And that financial strain creates a lot of uncertainty for those tenants. Number one, in the mitigation process, those tenants are going to need to vacate that property, and currently there's nowhere to go. So if there's one unit that needs to be vacated in a building, that's difficult enough in this current environment. But if there are 10 or more units that need to be vacated, that's exponential. That's really difficult to manage. Additionally, when landlords struggle with this, they're going to need to come, if they choose to put their property back online for rent and allow those tenants to move back in, there might be an additional cost to rent for those tenants or for future tenants so they can make up these costs. So these are all concerns. The money has to come from somewhere. And I know that there is a mitigation fund, and we're happy to have conversations kind of outside of this committee hearing regarding how much money is still in that fund, how much we anticipate coming into that fund going forward so we can come up with some sort of solution. Last year, we passed legislation that any new residential conversions to rental, so existing homes that are now turning into residential rentals, needed to be certified lead safe prior to that occupancy. And that process is incredibly slow. And it is incredibly cumbersome and costly to folks that are looking to do that. And I know in my practice, folks who were looking to purchase those properties and turn them into rentals, with this new legislation, they've kind of shied away from that. So those properties are not coming online as we were hoping that they would in a safe manner to help with this crisis. And most recently, I spoke with a colleague who had a client that owns their own home and their child tested high lead levels, and they are working through the process to get grant funding to be able to mitigate that in their own primary home. However, there's no place for them to go in the meantime, and now they have this knowledge that this house is poisoning their child. So these are concerns that need to be thought through when weighing this particular legislation. We do not have enough homes out there for folks to be able to move to during this mitigation process. We don't have enough homes, period. So we need new safe homes out there for folks. Happy to take any question. Actually, hold on. Something was mentioned earlier, lead disclosures. Those lead disclosures need to go out prior to the, in the sale process. Everyone is going to be, provided a lead disclosure for any property that is pre-1978, and also in the rental process, any prospective tenant also needs to be provided a lead disclosure for properties that are older than 1978 as well. Happy to take any questions.
Thank you. Any questions? Yes, Representative Siebert.
Yeah, I just have a question. I feel it to be pretty reasonable in regards to, like, you know, we do know that there are a lot of, some people call them renovation evictions, but whatever they are, when they do, you know, displace folks and they're going to do a renovation on that property, whether it's slapping on a coat of paint, a coat of paint or whatever it is, upgrading a few things. Why would we not, do we require that to be abated within that process? I mean, I understand it's cumbersome and that type of a thing, but it also still is the law. You know, what would be a solution for that for you versus let's just keep leaving the situation the way it is?
If I could ask for clarification on your question, are you asking about folks that are having tenants vacate so then they can do renovations on their property that are not relative to lead paint?
Yeah. Why would you not address that at the same time?
That's it. That's up to the landlord. I can't answer that. It does seem reasonable unless there is a cost aspect of that is just cost prohibitive for them to do so. Yeah.
All right.
Other questions? Seeing none. Okay, thank you.
Thank you.
Okay, no one else has signed up to testify on HB 724 FN. Does anyone else wish to? Ma'am? Okay, what's your name, ma'am? Oh, oh, okay, you put down 756, that's the next bill? Oh, I'm sorry. Did you want to testify on this one also? Okay, could you fill out another pink card for us, please? Well, you also want to testify on this one too, right? No, I don't. Oh, you don't? Okay. Okay, I'll just change this one then.
Thank you, Chair, members of the committee. So my name is Joan O'Brien, and I'm the president of the New Hampshire Animal Rights League. And we were formed in 1977, so we've been around for almost 50 years. And our mission is to protect animals from human-induced forms of harm. So I wanted to speak to this bill today because I wanted to discuss a largely undiscussed potential exposure to lead, which is lead in hunted meat. And I attend the monthly New Hampshire Fish and Game Commission meetings. And a few years ago, the then director, Scott Mason, was discussing a ballistics demonstration that he had attended, where they showed that a lead bullet is shedding lead all the way through its path, if you shoot an animal. And he said, and then you've got lead in your meat. So I thought, interesting. And then later I learned about we have something called the Hunt for the Hungry program. And that is a program where you can donate venison to the food bank. And I thought, gosh, I wonder if, those people are at risk. That's a vulnerable population of people getting food from the food bank. Maybe they're getting meat with lead. And so I did some research into it. And in fact, if you shoot a lead bullet into an animal, the lead fragments into a lot of little pieces, they can be 18 inches from the site where the bullet hit. And hunters are accustomed to field dressing their animal, and they would cut around, the place where the bullet hit, but they might not get all of the rest of the fragments. And so I did call the food bank, and the director there this had never come up. And she said, we have the meat processed by approved butchers. But the butcher didn't call me back, but I read a study where they took 30 deer in another state, took 30 deer to 30 different butchers and tested the ground meat, and they found lead in 24 of the samples, so 24 out of 30 butchers. So I think it's just a largely undiscussed exposure, and I know that Medicaid recipients are all over the state, including in rural areas where hunting is popular, and poaching is also something that happens all over the state. And recently, the Fish and Game donated 350 pounds of poached meat to, I'm not sure where actually, but you can imagine somebody poaching an animal might have shot it with a lead bullet, probably not caring too much. So I did write an article about this, which was published in the New Hampshire Bulletin, and and we to raise awareness, we tabled about this in 2022 at the New Hampshire Fish and Game Discover Wild New Hampshire Day, and we had a petition. I'm almost done. We had a petition. We got 250 signatures asking the department to take some action, like a buyback program, an ammo buyback program, or something like that. So nothing's happened yet, but I just couldn't resist this opportunity to raise this. And on your website, it doesn't mention hunted meat as an exposure. Shooting ranges are mentioned, but not hunted animals. So thank you.
Thank you. Representative Palazzo.
Thank you, Mr. Chair, and thank you for sharing this concern with us. So obviously exposure is possible, but do you know of any case somebody was poisoned by New Hampshire and needed medical help because he or she were eating venison or some other hunted meat?
I don't know of any, data about that because I think it's largely undetected and people don't think about it. Should be, where it came from.
Other questions? I'm seeing none.
Thank you.
Thank you. Okay, I have no one else signed up to testify. Does anybody else wish to testify on HB 724 FN? Seeing none, I am going to close the public hearing on HB 724 FN. The next bill is scheduled to be heard at 2:30, which is 756 FN. So we will be in recess for the next 10 minutes. Thank you. I'd like to reconvene, and we have one bill left to be heard today, and it's HB 756 FN. The prime sponsor is Representative Heath Howard, and he is at the witness table and ready to go. Welcome back, Representative Howard.
Thank you, Honorable Mr. Chair and committee members. My name is Representative Heath Howard. I represent the towns of Stratford and Barrington in Stratford District 4. Today I'm introducing HB 756, which is lead blood testing levels. So lead poisoning among children is rising dramatically across our state. The proposed legislation mandates blood lead level testing for children aged 6 or upon entry into a public school or child care agency, which is critical, timely, and is actually a response to the alarming data revealing a 43% surge in lead poisoning cases in 2023. With 1,142 children suffering harmful blood lead levels and low-income Medicaid insured children twice as likely to be poisoned, this legislation is a moral and practical imperative to protect the vulnerable youth. Lead poisoning causes irreversible cognitive damage, impairing learning, concentration, and lifelong potential. The recent spike saw 342 more children poisoned in 2023 than the previous year. Signals a systemic failure. While increased testing post-pandemic explains some of the rise, experts have warned the true toll is likely higher. This legislation closes that gap by requiring universal testing, ensuring no child slips through these cracks. As you have heard in the previous bill, low-income families bear the brunt of this crisis as older rental housing, often disrepair, is laden with lead paint. Disproportionately houses Medicaid-insured children. Mandatory testing ensures early detection for all, regardless of income, and empowers parents with state-provided educational resources to mitigate risks. Lead poisoning costs taxpayers millions in healthcare, special education, and lost productivity. Earlier detection is far cheaper than treating lifelong disabilities, and this legislation's testing mandate, paired with exemptions for religious exemptions, balances public health needs with individual rights while reducing long-term economic burdens. New Hampshire cannot ignore a crisis poisoning its future generations with lead levels at historic highs and vulnerable children at the most risk. This legislation is necessary, evidence-based intervention. It prioritizes prevention and accountability, safeguarding children's health while addressing the root causes of exposure. Passing this bill is not just policy, but it is a moral duty to protect New Hampshire's children and build a healthier, fair future for all. Thank you so much, and I'm open to any questions.
Thank you. Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Was there a particular reason that you limited it to public schools?
I believe, so this is a resubmission of legislation that was proposed last year. And I mean, I do think that the public schools is the best and easiest way to implement this without necessarily trying to get involved with private entities.
Follow up.
But just in view of fairness, wouldn't it be applicable to all schools?
I think that it could be.
Well, again, a follow-up comment perhaps to clarify. Say a child does go to a private school and finds out he has difficulty because of lead poisoning. Currently, they don't have the ability to take a child with IEPs. And as a consequence, that falls back to the public schools. So in that sense, the private schools then would reap the benefit of that service without any responsibility. And so therefore, I would say, I would encourage you to consider having it all schools.
Yeah, I may be also incorrect about this, but I believe it also would allow any children aged 6 to potentially be able to be eligible for that. Again, I'm sorry, I don't have the full text in front of me. Here it is. Yeah, I believe on line 10.
Yes.
Yeah, yes, I understand what you're saying. That would be for someone who had been domiciled from birth.
Mhm.
If someone is, say, coming from some other venue into the state and wants to enter directly into the school system at that time, they would not have been included.
Yeah, I understand what you're trying to say. That would be a good amendment to add in to make sure that all students would be eligible for testing.
Other questions? Seeing none. Okay, thank you.
Thank you so much.
Also signed up to speak is Representative Alice Wade from Dover.
Good afternoon, members of the committee. I'm Representative Alice Wade, representing Dover Ward 2 and Stratford District 15, and I'm one of the co-sponsors on this bill. So the core part of this bill it gets at is having data on lead poisoning. The importance of that in terms of abatement cannot be understated. Knowing whether or not a child has had exposure is just the very start of the process. And it can help not only improve that child's health, it can prevent them from being exposed in the future if you catch it early. But it can also indicate trends in the area and can prevent additional exposure to many more people. Let's say if one child tests positive, you can test their home and maybe you find contaminants on the windowsill or on the door frames from when it rubs. You can treat that. If you don't find contaminants, the investigators can go through further processes to identify exposure through food products like was mentioned during the last hearing, and that can help identify those issues and then prevent thousands more children from being exposed to that contamination. You know, it can help that child, it can help any child that moves into that house in the future. If another child, if their friend visits their house, it can prevent them from exposure. Maybe it's in the soil and it can help their neighbors too. You know, the same goes for things like daycares. And those trends can only be identified when you have sufficient data. You know, lead back in the 1900s was everywhere in our paint and our gasoline, and we did a lot of great work to prevent that. But a lot of those older buildings, as is the case here in New Hampshire, still have a lot of lead paint in them, flakes, and all of that. And this problem doesn't go away on its own. Lead doesn't degrade on its own without actively working to address it. You know, just this week, it's been mentioned, NHPR released the headline of the report about how lead poisoning is the highest they've ever been since we started testing. And that's likely a significant undercount because testing is not currently universal. That exposure has drastic effects on the health of children. It impedes their brain development and causes a number of additional health issues. You know, there have been a lot of studies that correlate lead exposure to higher rates of crime, lower IQ, other health effects like damage to their brain, their nervous system, you know, challenges with hearing and speaking processing and many learning disorders. You know, and treating this lead exposure has a high return on investment, yielding at least $17 for every $1 you spend on it. And that's why this bill is in everyone's best interest, since you can only treat lead if you know it's a problem in the first place, and I strongly urge you to vote ought to pass on this bill. Thank you, and I'm happy to answer any questions.
Thank you. Any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Representative Nancy Murphy from Hillsborough 12, I believe it is.
Good afternoon, Mr. Chair and honorable members of the committee. I'm Nancy Murphy, representing Hillsborough 12, the town of Merrimack. I'm here as a co-sponsor and to express my support for HB 756. HB 756 is both a public health and child protection bill. It's important to remember that there is no safe level for lead in a child's body. Lead is a neurotoxin which causes neurodevelopmental disabilities in children, resulting in learning and behavioral challenges that can be lifelong. Increased costs for special education services result in higher property taxes for New Hampshire citizens. Though the analysis notes that this bill establishes a blood testing requirement for children entering daycare in public schools, we should be clear that the requirement is not actually for the testing itself, as that is already in current RSA, following a study commission on lead poisoning that led to SB 147 being passed into law in 2018. HB 756 does not add any new requirements for physical examination nor lab testing for lead. Rather, the requirement referenced in the bill analysis pertains to a notation on the school daycare health form of a single lead testing result, which would not be necessary if the child is exempted. Should the child's health form be missing that single blood level testing result that New Hampshire statute already requires, the school or daycare will A, remind the parent guardian of the lead testing requirement, and B, provide them New Hampshire DHHS supplied educational materials relative to lead poisoning and the importance of lead testing. It's hoped that HB 756 will lead to increased compliance with lead level testing, so that parents of children found to have elevated lead levels can have a better understanding of risks relative to lead toxicity and the options for treatment. This will afford parents the opportunity to intervene quickly and protect the health and well-being of their children. Thank you for your time and attention. I ask that you recommend OTP on HB 756. Thank you.
Thank you. Any questions? Seeing no questions, thank you.
Thank you.
Also signed up to speak is Katie Hatcher from, I believe it's National Department of Public Health Services. And is someone with you also?
She is speaking separately.
Okay.
Good afternoon again. My name is Katie Hatcher. I'm at the Nashua Division of Public Health. I have been a registered nurse for 15 years, and I have been working as a public health nurse doing lead poisoning prevention directly with families for 6 years. Thank you for allowing me to speak. All New Hampshire children deserve the freedom to reach their full potential, and lead poisoning robs our children of that freedom. Lead is a neurotoxin, and children under the age of 6 years old do not have a fully formed blood-brain barrier to protect themselves from that poison. There is no safe level of lead in a child's body. The human body does not know what to do with lead when it enters the body, so your body actually thinks it's calcium. Lead follows the path that calcium takes throughout the body, so it goes directly to the brain, your blood, soft tissues, and your bones. The research shows that even very low levels of lead causes irreversible cognitive deficits, developmental delays, lower IQ, speech delays, the need for special education services in school, and there is even correlation that childhood lead poisoning can cause incarceration as adults because lead can affect the impulse decision-making part of your brain. We have to stop the cycle of generational lead poisoning, which perpetuates the cycle of poverty. When a child is poisoned, 95% of the lead burden goes directly to their bones, and it stays there for decades upon decades. Even if that child is removed from all environmental lead hazards, their own bones become the exposure source. I'm going to repeat that because I think it's really important. When a child is poisoned, 95% of the lead burden goes directly to their bones, and it stays there for decades upon decades. Even if the child is removed from all environmental lead hazards, their bones will become the exposure source. For example, a female child who is lead poisoned reaches childbearing age. She becomes pregnant. During the second trimester of her pregnancy, Her fetus tries to pull calcium from her mother's bones to make bones for the fetus. When there is lead in the bones, lead gets pulled instead of calcium, so that fetus becomes lead poisoned. Another example is when a child is lead poisoned, the lead stays in their bones, they become elderly. If they develop osteoporosis, that lead is leached back into their blood and they are lead poisoned again when they are of advanced age. Childhood lead poisoning is 100% preventable. It is irreversible. It causes lifelong deficits for the child, the family, the community, and our economy. We have the power today, right now, to make a difference for the children of New Hampshire, and I ask you to please support this bill.
Thank you. Perfect time. Any questions? Seeing no questions.
Thank you for your time.
Thank you. Also signed up to speak is Molly Ellis from Keene, New Hampshire.
Good afternoon to the chair and the committee again, and thank you. That was wonderful and said a lot of what I was going to say, so I'll be very, very brief. My name is Molly Ellis. I'm a resident of Keene, New Hampshire. I'm here again to ask you to support House Bill 756. When I discovered that my son's blood lead level was elevated a few years ago, I really panicked. Because doctors have discovered that there is no safe lead level in the blood. It is especially crucial to test very young children because, as we just heard, they have no blood-brain barrier, and the lead is absorbed into their brains, which causes so many terrible problems. It's associated with behavioral problems, cognitive impairment, stunted growth, hearing problems, even incarceration. Because we learned about my son's elevated lead level, his outlook is very good, and this bill can help keep other children's futures safe as well. So please vote in favor of House Bill 756. Thank you for your time and consideration, and I will take any questions if anybody has any.
Okay. Thank you. Any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak is Jackie Cowell from Early Learning New Hampshire. Is it Jackie or is it Jackley or?
Jackie, well, it's Jacqueline.
Oh, okay.
When I was in trouble with my parents, but I'm Jackie.
Okay.
How do you do? Chairman McDonald and members of the committee, my name is Jackie Cowell. I am the Executive Director of Early Learning New Hampshire. We are a statewide nonprofit, and our mission is to ensure that all New Hampshire children have the opportunity to reach their full potential. We do that through supporting childcare programs as well as the families they serve. And so we are actually coming in opposition to this bill, not because of its intent, but simply because of its solution. We feel there is a more logical and efficient solution than what is proposed in this bill. Knowing again that there is a requirement to have blood lead level testing, we do not oppose at all having an extra line on the health form that goes to the public schools or for childcare agencies. But having the burden and the duty of it not being completed, going back to the child care provider and then alerting the parent and trying to give the parent documents, why it seems so much more efficient that the healthcare provider fill it out. Or if they don't have the information, they have the capacity to do that testing there. It does not make sense to us adding this extra paperwork and documentation for something that could, we believe, be much better fulfilled if it was the healthcare provider who is required to fill that out. Thank you.
Thank you. Any questions? Seeing no questions. Oh, Representative Lamontagne.
Hi, thank you. though I think the point of the bill is to be able to identify children that enroll in a daycare that perhaps never were tested. It's just a fail safe.
Right. I do understand that, but the first order of what's going to happen is a healthcare provider will fill out the form. That has to happen before they enter, that they have that health form filled out. So if there's a new line there that the child care provider would be reading, so would the healthcare provider. And if it's blank and there's no testing, it seems more logical to us that the healthcare provider then take action. Does that make sense? Yeah.
Representative Kofalt and then Representative Nagel.
Thank you, Mr. Chairman. Thank you for taking my question. So current statute does require lead testing for children between 1 and 2, I believe, if I understand correctly. And so it seems to me that this bill would cover 2 scenarios. One is children who were exposed at some point after they were initially tested by a physician. And the other would be children who moved to New Hampshire, whose families moved to New Hampshire from out of state. It seems to me that sort of gives us a much smaller subset. Obviously, every child is important. We want those children to be safe and healthy. But can you comment on sort of what do you think the impact is in terms of sort of the procedural concerns that you brought up and the fact that we are already requiring lead testing for children before the age of 2?
Yeah, and again, I applaud the intent of the sponsors of this bill, and I feel that it's a good idea to have that new part on the form that's not there now, saying what the blood lead level is. And again, because the first contact with that form is not the child care provider, it's the healthcare provider, that if that is not there, that's where it's best caught and resolved when they're filling that form out, whether they're going to a child care program or a public school.
Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. I think I have 2 questions. The first is, what happens to that form?
Yeah, so it is filed and data is kept on immunizations. There is an annual report that is required by child care programs. This, again, part of what I'm thinking about is if this form comes incomplete, then this bill then asks the child care provider, rather than asking the form to be complete, asks the child care provider to notice that, document, go back to the parent, tell them, give them forms, tell them that they have to have it completed, etc. That seems a lot less efficient and may not result in a quick solution.
This is really more of a second question than a follow-up, and I apologize if you're not the right person to answer this, but all the form requires is that at some point between the age of 1 and 6, you've had a blood test, which by law has to be between 1 and 2, which means there's a big gap between 2 and 6.
Right. And I'm not the best person to answer that. All I know is that this bill talks about it being that if it's blank, that the child care provider or the public school then connects to the parent and does some documentation of disseminating information, etc. Yeah.
Representative Woods.
Thank you, Mr. Chair. And you, again, may or may not be able to answer the question. We talked about all kids by law have to be tested from up to age 2. But what is the actual compliance with that? Sitting on a commission a couple of years ago, we found the compliance was really poor. So when we read this, do we know what the current compliance is?
I don't know. Yeah, that's not my expertise. Again, it's that whether they fill it in, whether they have, if the healthcare provider has the blood lead level, right?
Yep.
Other questions? I'm seeing none. Okay, thank you.
Sure, thank you.
Also signed up to speak is Kim Bernard from Nashua Department of Public Health Services.
Hello again. Okay. So my name is Kim Bernard. I've been a registered nurse for 30 plus years. I currently am the Chief Public Health Nurse at the Nashua Division of Public Health and Community Services. Children that have lead poisoning typically look happy and healthy, as the cognitive and behavioral deficits oftentimes do not show themselves until school age. The only way to know if a child is lead poisoned is to test them. Universal testing has been a great start to increasing testing rates in New Hampshire. However, according to recently published 2023 data brief, 24% of 1-year-olds are not being tested, and 31% of 2-year-olds are not being tested. That's a lot of children in New Hampshire that are slipping through the cracks. We know that lead poisoning disproportionately affects low-income populations. New Hampshire children on Medicaid, as was discussed during the last bill, are twice as likely to have lead poisoning. Research shows that many children who have lead poisoning required special education services to access their educations. There are new studies that have just been published correlating childhood lead poisoning with mental health, with mental illness as adults. Part of the job that we do in public health is provide nurse case management to children who are lead poisoned, as well as their families. We go into their homes, we work with these families over months, sometimes years, because it takes a very long time to get lead out of a child's body, even when the lead hazards are removed. We connect with these families. We connect these families with community resources such as early supports, which includes early intervention for 1 to 3-year-olds with things such as OT, occupational therapy, speech therapy, physical therapy, because we know these children are at high risk for developmental and behavioral deficits. We also connect these families to WIC because healthy nutrition, as my colleague had mentioned, is one of the tools that we use to help with lead poisoning because oftentimes it can cause anemia. These families feel like their lives have been turned upside down, that their home is not safe, that their child may not be able to have the future they envisioned for them. We have seen children as young as 9 months test positive for lead from home renovations. We are seeing an increase of 5 and 6-year-olds having lead poisoning due to lead in food, such as Wanabana applesauces that were recalled, cinnamon, and other imported spices from India and Southeast Asia. Childhood lead poisoning is 100% preventable. It causes lifelong deficits for the child, the family, the community, and our economy. We have the power today, right now, to make a difference for children of New Hampshire. I ask you to please support this bill. Thank you.
Thank you. Any questions? Seeing none, thank you.
Thank you.
Also signed up to speak are Michelle Roberge and Beverly Druin from the Department of Health and Human Services.
Thank you, members of the committee. For the record, my name is Michelle Roberge. I'm the Bureau Chief for Public Health Protection within the Division of Public Health Services at the Department of Health and Human Services. And with me today is Beverly Druin, and she's the Healthy Homes and Environment Section Administrator with the Department of Health and Human Services. We wanted to come up and be a resource to the committee and try to provide some information that we heard from some questions. I think it was specifically Representative Wood's question related to testing rates for 1 and 2-year-olds. There is a requirement in RSA 130A:A-5A, which New Hampshire is a universal testing state, and there's a requirement for all 1 and 2-year-olds to be tested for lead. And we have that data available. There is an exception in the law as well. We do have that data, and you all should have received a copy of the 2023 lead data brief. And so on the first page, you'll see at the bottom of the first page, there's a graph, and maybe Beverly, you can speak to it a little bit more, but there's a graph that shows the testing rates for all 1 and 2 year olds in New Hampshire.
So in New Hampshire right now, sorry.
In New Hampshire right now, if you look at the bottom graph here, it shows that 2023 that 76% of our 1-year-olds were tested for blood lead levels and 69% of our 2-year-olds. The universal testing law in the state of New Hampshire that was implemented in 2018 requires our 1-year-olds to be tested and again our 2-year-olds. So it's 2 tests, a 1-year-old and a 2-year-old. And if a child, for whatever reason, misses their well-checked visit and misses that 1 or 2-year-old test, and they go back to the doctor at their 3, 4, 5-year-old, if they're under 6 years old, we recommend that they have their blood lead levels tested. So test at 1, test at 2, and if you miss one of those tests, they call it catch-up testing. You get tested at 3, 4, or 5. So I just wanted to make sure the committee understood New Hampshire's universal testing law.
Okay. Any questions? Representative Nagel.
Thanks, Mr. Chairman. Thanks for taking my question. I'm just always curious when we have laws like that, what are the ramifications for parents if they don't do it?
So there is an exception in law in our
Assuming no exception.
What is the ramification if a parent chooses not to test their child?
Just doesn't do it, is non-compliant, doesn't do it.
I would think the ramifications might be that you would get your child into school and the school district might not have a flag that this child had a blood lead elevation, which is a brain injury, and they might not be looking for, they might not get him enrolled in an IEP. They might not be able to start those services soon enough.
Yeah,
So
the reason I'm asking the question is laws are only as good as they are enforceable, and if there's no enforceability behind this, that's going to affect our ability to do this.
I think it's the relationship between the medical provider and the parent, and that the recommendations that come through for that, and this law just provides that guidance back to clinicians to do that early on testing. It's the recommended guidance.
Representative Woods, did you have your hand up a moment ago? Are you all set?
One more question. I mean, I was looking up the CDC's guidelines, and they actually recommend testing at 6 years too. Are we ever looking at doing that as well?
So right now our testing law is 72 months and younger, which is the month that a child turns 6. So we educate our providers, and the New Hampshire Academy of Pediatrics in their Bright Futures guidelines recommends testing up to 6 years old.
Representative Woods.
Yeah, thank you. I just need to help me through your data.
Yep.
On the 1-year-olds, we'll just say for 23, 69%. And then on the same year that, so those are, okay, I think I understand that. In other words, when the 1-year-olds were tested, when they're 2-year-olds, they wouldn't be tested because they were tested when they were 1-year-old.
No, let me help clarify a little bit.
Yeah.
So on the graph on the bottom of the first page, the blue line is the testing rates for our 1-year-olds. So if you look at 2022, you can see that 77% of our 1-year-olds were tested, and it went down slightly in 23. Only 76% of our 1-year-olds were tested. But we had some huge gains with our 2-year-olds. So if you look at 2022, the orange line, you can see in 2022, 57% of our 2-year-olds were tested, and it improved to 69% in 2023. So the law requires a 1-year-old get tested, and then, because that's when they start, they're mobile, right? We want to test them early. And then we test them again at their 2nd birthday. 2 tests.
Okay, so I wanted to clarify, it's 2 tests.
2 tests.
It's not just age.
Correct.
No, it's 2 tests.
And that citation is in RSA 130-A:5A. So that's the universal testing law requirement.
Thank you. Representative DeLamus.
Thank you, Mr. Chairman. And thank you for taking my question. I hear required, suggested. Is it required? Is it a by law required of parents? And if they do miss having their children tested, are they legally liable to be fined or taken to court, or is there any teeth to that?
So I'm looking at RSA 130A semicolon 5A, which is our universal section of the state lead law. And it says all healthcare providers who provide primary medical care shall conduct blood lead testing of all 1 and 2-year-old patients to determine their blood lead level. A healthcare provider shall not be liable for not performing a test for blood lead level when a parent or a guardian has been informed of the blood lead testing requirement, has refused to consent, or failed to follow through in response to a referral for a test. Nothing in this section shall prevent a healthcare provider from recommending blood lead testing for children younger than 1 or older than 2 should circumstance, including potential lead exposure hazards, warrant such testing. Yeah. Sorry, I had to read that.
Representative McGrath.
Is the percentage of untested, do you believe the barrier is those are uninsured?
I don't know that I can speak to that. I don't have that data. I think we know that some families don't have a medical home. I think we have a little bit of ways to go with educating our healthcare providers that it's 2 tests, right? So I think it's a combination of factors.
Other questions? Not seeing any.
Thank you.
Thank you. Also signed up to speak is Melissa Clement from the Department of Health and Human Services Child Care Licensing Unit.
Thank you, members of the committee. For the record, my name is Melissa Clement, and I'm the chief of the Child Care Licensing Unit in the Department of Health and Human Services. I'm just here to answer any questions you may have regarding the section that speaks to the health forms in child care programs, because we would be the one enforcing that action. So if you have any questions, I'm happy to answer them.
Are there any questions? Representative Nagel.
Thanks, Mr. Chair. Thanks for taking my question. If I remember last year, there was a lot of opposition on the basis of time elements and things like that. It seemed to me this is just a simple check mark that then gets transferred to somebody else to review. Is that accurate?
Sure. Let me thank you for the question. The process that would happen is a child care program would receive the form. They would be reviewing to see if the lead level was there. If the lead level isn't there, according to the bill, the program would then be required to go back to the parent and provide resources or determine if they have refused the test. So what we would be doing when we go into the program, we take a sample of children's records where we already have a health form, and it does have a spot for a blood level test, but we would now specifically be looking to see that that section was completed. And then if it wasn't, we would have follow-up questions for the provider for them to show us what documentation they had regarding what they provided to the parent. So that would be the process. And then if they didn't have that information, they would be cited for noncompliance because it was not there and they did not provide the information to the parents as required.
Other questions? Seeing none. Okay, thank you.
Okay, thank you.
No one else has signed up to testify on this bill. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 756 FN. That is the last bill we had scheduled for hearings today. So, the hearing portion of our day's work is completed. We are going to be going into executive session shortly to consider some other bills, but we'll be in, I don't know, does the committee wish a recess, or shall we go directly to the executive session?
5 minutes.
Okay. How about we'll make it 10. We'll be in recess for 10 minutes. Okay, I'd like to call the executive session to order. We have, hoping to get through 4 bills this afternoon. The first one will be HB 51. Representative Plazoff, I believe you have a motion.
Thank you, Mr. Chair. I move ought to pass on House Bill 51 relative to hemp-derived cannabinoids and the definition of cannabis and therapeutic cannabis. This bill will help.
Let's get a second first. Representative McLean, I believe.
I'll second.
Okay, go ahead, Representative Plazoff.
Thank you. I think this bill will help patients and provide greater variety of therapeutic products, and it improves the definitions in the law. And there are some concerns around intoxicating effects of medical marijuana, but this bill actually may help patients to transition from high delta 9 THC products to blends that are less intoxicating. So I see this bill as win-win, so please support it.
Okay, thank you. Anyone else wish to speak to this motion or to this bill? Seeing no one, I'll ask the clerk to call the roll. Motion is ought to pass on HB 51.
Representative Mazer,
Yes.
Representative McLean,
Yes.
Representative DeLamus, Representative Kofalt,
Yes.
Representative Nagel, Representative Polizov,
Yes.
clerk votes yes. Representative Markell,
Yes.
Representative McGrath,
Yes.
Representative Siebert,
Yes. Sorry.
emphatic yes. Representative McKay,
Yes.
Representative Woods, Representative Palmer,
Yes.
Representative Tellez,
Yes.
Representative LaMontagne,
Yes.
Representative Hartnett, Representative Lucas,
Tim Hartnett, Representative Hartnett was terrible to say. I just realized he wasn't here today. Okay.
vote is 16-0, motion passes.
Do I get to vote? Or?
Oh, sorry.
That's all right.
Representative McDonald,
That happen, every clerk does it. Yes.
it should put you at the bottom of the page.
17-0. That was, we were trying to figure out who sat next to you. Representative McGrath, that's Representative Hartnett that sits there, right? It's been empty all day, though. Well, after that first bill this morning, I missed a lot of things. So anyway, okay, so the motion passes 17-0, and Representative Palazzo, if you'll get me a report within the next couple of days. Okay, great, thank you.
Consent for that?
Yeah, if there's no objection, we'll put that on consent. Any objection from anyone? Representative LaMontagne, any objection? Okay. Next up is HB 53, Representative Kofalt, perhaps?
This is the amendment.
Oh, I'm sorry, I apologize. Representative McLean.
Yes, thank you, Mr. Chair. I handed out, pardon me. I move amendment 0272H to HB 53.
Okay, and I will second that motion. And would you like to speak to your motion, Representative?
Thank you, Mr. Chair. Yes, I was not here for the public hearing, but it was noted that there was a drafting error in the legislation where the implementation date on page 4, line 27 is no later than December 1st, 2024, which has since come and gone. So the amendment makes that December 1st, 2025.
Okay, is there,
That was the only revision, yes.
any other questions or comments about this amendment?
Well, I'm intending to lean a little ITL on this one, so I was hoping.
This is just on the amendment, Representative, not the bill itself.
Just the date change.
Yeah, I'm OTP on that.
Okay.
Okay, so the motion is ought to pass on, again, the amendment number is 0272H. Any other discussion? If not, I'll ask the clerk to call the roll.
Rep Mazer,
Yes.
Rep McLean,
Yes.
Rep Delamus,
Yes.
Rep Kofalt,
Yes.
Rep Nagel, Rep Polizov,
Yes.
clerk votes yes. Rep Markel,
Yes.
Rep McGrath,
Yes.
Rep Siebert,
Yes. Sorry.
I don't think they heard you across the street.
Rep McKay,
Yes.
Rep Woods,
Yeah.
Rep Palmer, Rep Tejas,
Yes.
Rep Lamontagne,
Yes.
Rep Hartnett is not here. Rep Lucas,
Yes.
Rep McDonald.
Yes.
Vote is 17-0. Motion passes.
Okay, now the motion before us is ought to pass as amended on HB 53. Representative Kofalt, are you up for this one, or?
Yes, I move ought to pass with amendment on House Bill 53.
Okay, and Representative McLean, well, Representative Lamontagne. Okay, Representative Lamontagne seconds. Representative Kofalt, do you wish to speak to your motion?
Yes, I think this bill addresses three issues. One is access. There are people who live pretty far away from an ATC or dispensary, and it's a burden for them to drive long distances to get medical cannabis. I also see a potential cost issue. A lot of these folks are operating on a very thin budget. Prices are high at ATCs in New Hampshire, and allowing them to cultivate their own cannabis is going to save them money. And there's also a safety issue, which is that I have heard that there are medical cannabis patients who for cost and access reasons may buy black market cannabis off the street, which could bring with it some potential safety issues. So for all of those reasons, I support House Bill 53.
Thank you, Representative Delamus.
So,
Can you put your speaker on your mic?
thanks for taking the question. So the question is, who is checking on all of this growth stuff? That was the question I had asked before, and I don't know if there are enough checks and balances to this system as far as being homegrown.
So the same person who checks all of our homes for illegal cannabis, which is no one unless there's some reason for them to be in the home. So I guess I see this as saying there is permission is granted and you will not be outside the bounds of the law if you cultivate a certain amount of cannabis for your own use or if a caregiver does so. That does not call for or require inspections in my mind. It's simply saying this certain behavior will not be deemed illegal under these circumstances. So I don't think it calls for inspections of any kind.
Representative Woods and then Representative Nagel.
Thank you. In a general concept, I'm in favor of the bill. However, for some of the reasons that were just stated, I have some concerns. The ATCs have extraordinarily tight, strict, regular oversight about exactly not just growing it, but how much, what kind, et cetera. Extraordinarily tight oversight. Putting this in an individual's home, I think with no oversights that I can see, other than someone's, quote, suspicion, raises some concerns. And I say that from some background. My neighbor a few years ago was a federal AG and dealt with this issue. And at that time, one of the major problems was growing in individual homes in rural areas. And people were coming to New Hampshire for that purpose because rural areas have very poor police coverage. And therefore they thought that we'll buy a house and we'll just grow as much as we can here. And the basement and everything else is just full of drugs of all kinds. So with virtually no oversight, I think it does beg to say, well, now I can go dark, or someone's coming into knocking on that individual's door and say, oh, you're growing your own. Look, I can make this very profitable for you. I'll help you do this if we can use your basement. I have some concerns.
Other questions, other comments? Representative Nagel.
Thanks, Mr. Chairman. In the interest of consistency, this is the fourth time I've been able to vote on this bill. Twice at the therapeutic cannabis medical oversight bill, and this will be the second time in this committee, and I voted against it every time. I really appreciate everything that Representative Colfault said because I agree with everything he said. I think there's probably better ways to address that. One of the things we did was this morning, the greenhouse cultivation, which will be a big one for increasing access to other strains that we don't have access to now, and another bill that we're proposing to increase the number of ATC dispensary sites, which can solve those problems, I think, relatively safely. Having toured cultivation site and seeing the amount of science that goes into developing a reproducible product, it's become quite apparent to me that it's virtually impossible for a typical lay person to do that on their own and get a product that is actually a reproducible thing. I mean, I could go on that in detail if you want, as to all the factors that are involved in getting something like that, but I just don't think your typical person can do that. And then when I asked, the folks, at the dispensaries and people knowledgeable about this, they said, well, we don't think many people are gonna do this anyways. So I said, I go, well, you can't create a reproducible product. It's really not a pharmaceutical product. This is really not a therapeutic thing. I don't think we're going to support people growing opium in their own homes to do the same thing for opioid-related products, which probably have much more medical value than cannabis does. I just think based on all that, I just don't think I can support this bill ever. With that said, I've been very happy to be a 19-1 vote on this 3 times, and I won't be opposed to being it again on a 4th, but that's...
Won't be 19-1. There's only 17 of us here. So. Representative McKay.
Thank you, Mr. Chairman. I was chairman of the committee to legalize marijuana for 5 years. I've never had an experience like that before in the legislature. It's the intensity of feelings on both sides, for and against legalization, is still powerful. I support this legislation because it heads in the direction of distinguishing between the use of marijuana for personal reasons versus the professional reasons. And that we heard from Jerry, and I can't remember, he has a tricky last name. Right. That committee recommends this legislation. That's what influenced me. Those are the doctors who are looking at this medication, marijuana, are finding very specific uses for serious illness, including mental illness. And because of that, I see this as not a major solution, but a step in the right direction. Therefore, I will support this.
Anyone else? Any other comments, discussion? Representative Markell.
Thank you, Mr. Chairman. A couple of things come up in my mind is when I heard the original testimony on this bill, it was represented that this was going to appeal to a very small market. The indications were initially that approximately 15,000 people have medical marijuana cards in this state. However, they made no representations whatsoever as to what the size, then they indicated there was a necessity or transport issue. Dealing with the necessity, they never made a showing as to what number of people or even a rough estimate as to what number of people would actually be growing this particular material. That's number one. Number two is that I'm concerned about the addition, I think, as Representative Nagel points out, and as was also pointed out, what's to prevent people in this situation if they have that kind of financial need or they're that remote from growing it and then turning around and selling it. And I realize that distribution of marijuana in the state is illegal, but that doesn't stop people, and I'm wondering if this aids and abets it. Number three, the people who are the proponents of this bill were asked about the statute the statutes that exist as to growing in surrounding jurisdictions, and they weren't able to discuss it in any way, shape, or form other than it exists. So I had to take it upon myself and look up the statutes myself. They're somewhat different. They're also distinguishable on the grounds that our surrounding jurisdictions here also allow personal possession for non-medicinal use. On that basis, I distinguish it. So I've looked at this, and I'm not sure that this is really good public policy. Beyond that, I'd like to go a little bit further and say as follows. Number one was I asked about transport, and I did make a reference to whether if you can deliver it almost like a pizza. I think it developed a little humorous response, or maybe even less than that. And then we're looking at a companion bill which allows alternate grow sites, which is going to permit alternate grow sites for these distribution centers, and yet that they were talking about being able to transport it from their grow centers to their distribution centers under tight controls. Now, if the case is one of two things, and the additional thing is that they want to convert from nonprofit to be able to incorporate to some degree. I'm assuming that's either going to be either an S, if they're going to file their taxes as an X Corp or a C Corp on this. I don't know that you could, that's for somebody else to decide if you're growing marijuana. But the point being that if they're going to regulate and tightly control transport, why can't we have legislation that tightly controls delivery to people, to individual users? And the other representation that was made was that cost was a factor, and so somehow you can grow your own and mitigate the cost. Well, if they're that concerned about their people, number one, and they want to convert to a corporation, which they said would give them a little more financial flexibility, why not be able to use that incorporation authority to be able to have a financial need-based program to give the people a break on their current product? That way we would be addressing those needs, and at the same time, I think, engaging in prudent public policy by keeping, quite frankly, keeping marijuana out of the hands of people who shouldn't be getting it while it's still federally illegal. And beyond being an attorney who deals in federal and criminal defense as well as state criminal defense, that's a whole different matter. But for those reasons, I don't really think I can support this bill.
Representative Lamontagne and then Representative Nagel.
Yeah, I don't think that this bill has that much to do with the nonprofit or for-profit status of some of these companies. I see this as a person who has a medical marijuana card for their condition, wanting to grow their own marijuana at home for their needs. And anyone can do this without a card. but these are individuals who want to use this product for their pain or whatever reason. And they're not, I would think they're probably less likely to grow the marijuana to sell or to give to anyone else. They're trying to meet their own needs and stay within the law. And I don't really have a problem with it any more than, someone that is manufacturing their own beer. It's for their own personal use.
Representative Nagel.
I feel obligated to throw this in since this is a public hearing, but I think I was one of the first doctors to ever certify a patient for cannabis in this state. I've certified a lot of patients for cannabis in this state. I believe that it has value more as an adjunct than as a primary medication, but at the same point, I don't have a single patient that smokes it. I don't have a single patient that inhales it. I don't have a single patient that vapes it. Even the dispensaries, we try really hard to not use that mode of delivery as a method of taking this stuff. And it's same with opioids too. Injection is really a bad way to do it. Pills are a lot better. And so when you're doing it at home, doing it this way, the odds are you probably are going to be smoking it, which we just don't think medicinally is a good way to do it. But I just feel obligated to say that. Thank you.
Other discussion? Representative McKay.
Thank you, Mr. Chairman. If I didn't mention this before, Jerry Knurr, who is the chairman of that committee, was of professional doctors, said that they voted to support this legislation.
I was there.
Other discussion? Representative McLean.
Yeah, I mean, I'll just be brief. I think, I respect Representative Nagel's point about, the complexity with respect to the ATCs and what they do and the likely inability to replicate that at home. That being said, one of the things you will be able to do at home is not know that you're making a product that's laced with fentanyl, right? And so I think so while you're not getting that same caliber of product, there is still the safety concern for me. And I really think this just allows people to live within the law. If you're looking to go and make a huge amount of marijuana, for sale to third parties, you're probably going to be doing that with or without this. So I don't think it really moves the needle in that direction. So I will be supporting the bill. Thank you, Mr. Chair.
All right. I think that pretty well addresses it. So the motion is ought to pass as amended on HB 53. I'll ask the clerk to call the roll.
Rep. Mazer,
Yes.
Rep. McLean,
Yes.
Rep. DeLamus, Rep. Kofalt,
Yes.
Rep. Nagel, Rep. Polizov,
Yes.
clerk votes yes. Rep. Markell,
Oh,
Rep. McGrath,
No.
Rep. Siebert,
I won't yell into it. Yes.
Rep. McKay,
Yes.
Rep. Woods,
Yes.
Rep. Palmer,
Yes.
Rep. Tellez,
Yes.
Rep. Lamontagne,
Yes.
Rep. Lucas,
Yes.
Rep. McDonald,
Yes.
vote is 13-4, motion passes.
Okay, 13-4.
That prevents us from calendar, correct?
Right, yeah, we can't, I don't believe we can have more than two against. Will there be, I assume, probably not a minority report, or will there be? Huh? We don't need one, no. And it sounds like it would be Republicans writing it, probably, if it were one, and okay, that's usually found on. We don't need one.
So no, there's no minority.
No minority report, but regular calendar. Because it's,
So no, none of this,
No.
but it's on regular.
right, right.
And majority reports can be Rep. Kofalt.
Yeah, Representative Kofalt, you're writing the majority report? Okay. I had a feeling you were gonna say that. He's very quick.
So what happens when this comes to the floor? We just.
It'll go to a voice vote unless somebody wants to speak. Right. Right. No, well, the speaker will bring it up, and it'll call for a vote, and nobody signed up to speak for it, then, and there's no need to.
He'll just slam the gavel and we'll be done with it.
I mean, I will have to give names just in case somebody, it happens, but,
What?
all right, moving on, HB 126. Representative McGrath, I believe you have a motion on, oh, I'm sorry. Well, you do have a motion,
Yeah.
but it's on the amendment, right?
Yes, I'd like to move the amendment to House Bill 126.
And the amendment is 0184H. Is there a second? Representative DeLamus, I believe you're seconding, okay? Would you like to speak to your motion, Representative McGrath?
Sure, the amendment basically just moves the onus for the bill from the pharmacist filling it to the doctor who's prescribing it.
Okay. Any other discussion on this amendment? Any other comments or questions? Seeing none, I will ask the clerk if he's ready to call the roll. Motion is ought to pass on amendment 2025-0184H.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. DeLamus? Rep. Kofalt?
Yes.
Rep. Nagel?
Yes.
Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel?
Yes.
Rep. McGrath?
Yes.
Rep. Siebert?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yeah.
Rep. Palmer?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Lucas? Rep. McDonald?
Yes.
That's gonna be one. Seventeen to 0, motion passes.
Thank you. Next up, Representative McGrath, I believe you now have another motion.
Yes, a motion to move Bill 126 to pass.
Ought to pass as amended. And who seconded? Oh, okay, Representative DeLamus, you seconded? Okay. Do you wish to speak further to your motion?
Yeah, it's just a common sense bill that after a year of monthly prescriptions, a patient can get 3 months at a time.
Okay, any other discussion? Representative Nagel?
Thanks, Mr. Chairman. I just love this solution for a really complicated problem. He and I have been talking, the sponsor and I have been talking about this for quite a while. And it's the exact same solution we came up with people on long-term opioid therapies, that after a while, it's functionally not helpful to make somebody have to go in every month to get something or every week to get something when they've shown that they're a good patient. So I thought this was rewarding people for good behavior, and I thought it was a good solution.
Okay, any other discussion? Seeing none, I'll ask the clerk to call the roll. The motion is ought to pass as amended on HB 126.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. DeLamus? Rep. Kofalt?
Yes.
Rep. Nagel? Rep. Polizov?
Yes.
Clerk votes yes. Rep. Markel?
Yes.
Rep. McGrath?
Yes.
Rep. Siebert?
Yes.
Rep. McKay?
Yes.
Rep. Woods?
Yeah.
Rep. Palmer?
Yes.
Rep. Tejas?
Yes.
Rep. Lamontagne?
Yes.
Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote is 17 to 0, motion passes.
Any objection to consent? Hearing none, well, that'll go on consent. Okay, and the final bill of the day, and I know there was some concern over this, and Representative Tejas, you and I spoke about it, and not sure what her title, I think she's a director, Director Rogers and I spoke, she's from the department, about 576 FN, and they understand that it's an early bill, we want to move ahead with it, and that they didn't seem too concerned about, but, you know, I told them what the likely outcome would be, so. At this point, Representative Drew, I believe, you're going to make a motion on this? Were you making the motion?
26, but okay.
No, I had you down for 576, unless you want someone else to do it.
Sure. We were doing ITL again.
Yep.
Yeah. I move that we ITL on HB 576.
And Representative Mazur, I believe you were seconding that?
Yes.
Representative Drew, do you wish to speak to your motion? You're a busy guy.
Just real brief. This is way too expensive for what it's doing. It's a handful of people. I don't see any point to it. I can also talk a little bit about why it's so expensive. Tracking this data, because they specifically mentioned that they were using Salesforce to track this data. And so what that requires is going into Salesforce and setting up a data flow for that specific data, which is why it's so expensive. So.
Anyone else have any comments or questions, concerns, thoughts? Representative Tejas.
I had understood that we asked a lot of questions and wanted more information about potential alternative databases, because the way it was written, they costed it out in a certain way, and we had a lot of conversation about exploring alternatives, so that's why I had hoped we could not exec it today.
You know, Representative Tejas and I were speaking earlier about this, and you know, in the 4 years or going on 5 years I've been here, especially as the 3 that I've been doing this as chairman, I've always admired the fact that when we ask for information, anybody we ask is very prompt about getting back to us, because they recognize we're on timetables and they never know when the bill might get exec. And plus, this is an early bill, and we, at this point, we're looking at having hearings even during school vacation week for this committee, because we do have so many bills. So I think it's important that we move ahead with this, but obviously the committee is, I mean, I want to listen. So Representative Nagel.
With that said, I think it brings up important issues that they did not address in a cost-effective manner. I know there's better ways to do this. Is this a bill that we could retain and think about later? I'm sorry for not bringing that up earlier, but I never thought about it till right now.
Well, right now, the motion on the floor is ITL, so that would have to be withdrawn, but I'm not sure if there's, I guess that, again, during the discussion on ITL, we can discuss if that's the direction the committee wants to go in, or if we want to, you know, obviously it's got to pass this committee as to what the ultimate action is. If ITL fails, then we could certainly discuss retain, but right now we have another motion on the floor.
Was there any, sorry.
That's kind of what I figured, but I just thought I needed to ask it. There's nothing wrong with letting this bill go home, letting people sit down, think about it, work it out a lot better in a multi-stakeholder manner, come back and with a solution that's much more cost effective than this. And there's other people in the country that are doing this. There's no reason we have to be the ones, and there's no reason we have to do it by tomorrow. So.
Representative Lamontagne.
Yeah, I would like to vote against the ITL. I believe that the fiscal note was not realistic at all compared to what other states have been able to implement registry, states that have much larger population than we do. And I think it is there aren't that many cases, but it's a very serious disease, and we don't know what causes it, and we have no cure. And by having a registry, it's the first step to allow, you know, both the individuals' medical care, they can gather a lot of information, but for epidemiologists to start tracking where the cases are. And it's really important.
Representative McLean.
Yeah, thank you, Mr. Chairman. Last year we held over 15 to 20 bills, And I know that we only had subcommittees really to look at 2 of them. So we retained all this stuff to look at. And because this is not going into an interim study, if this is retained, we're just going to be dealing with this again in January of next year. And I think your comment that, you know, we had asked the department for additional information, and there just didn't really seem to be a lot of fire there. I just don't know that we're really going to be doing a lot with retention, and we're going to be back here again next year. So I would favor just going forward and ITLing the bill.
Representative Palmer.
So I apologize because I missed the hearing, and my recollection from the last time around was that most of the cases are followed by Dartmouth. And I guess what I'm thinking, and that one of the thoughts was that they would provide the data, and I guess they decided not to do that. And so I'm just wondering what the value would be if there are relatively few cases and Dartmouth's already following the cases that there are we getting it, not into our hands maybe, but into the hands of people who are looking into the causes of ALS? Are we already getting about as much as we'll ever get in the state of New Hampshire, since it's such a small state with so few cases? I don't know.
Representative Nagel.
My understanding is actually the cases that are followed within the state, that they're the ones that follow the most, but there's a substantial number, when you're talking 26 cases, I don't know what substantial number means, that are actually followed in Massachusetts, not here. And that was what they wanted to do, was capture that data too. That was the whole benefit for it. But with that said, this is a 2-committee bill, correct? So
It is, yes.
So it's going to finance, and with that number, it's never making it out of there. So no matter what we do, it's not going anywhere. So we might want to just save them the pain and suffering, I guess.
Representative Kofalt, and then Representative Tejas.
So I want to sort of echo some comments that have been made. I also want to acknowledge that, you know, one of our colleagues, the Honorable Mark Allegro, passed away from this 2 years ago now. And it was devastating to watch that. So I think many of us would very much like to do something to help people who are afflicted with this. At the same time, though, I don't see that this accomplishes that. I think that given the very small number of cases and the likelihood that the right medical professionals already have high visibility to those cases, I just don't see it, even if the fiscal note were substantially smaller than it is. You know, retaining this bill, I also agree, is just we're gonna circle back and probably come to the exact same result. So I just think it is probably best for us to just make the decision to ITL it at this point.
Representative Tejas.
Thank you. I have learned in the functioning of this committee that we make the policy decisions and we let the fiscal committee do their part. So I would urge us to consider, like everyone has said, it's a very devastating disease. There is no registry or place where the data is being collected. And I didn't know about the Cyanobacterium Association, and I think it should get studied. And the fact that rates in New Hampshire seem to be higher than other places. So I would urge us to, and I think what happened is it wasn't explicitly clear that we were expecting them to come back with more information. Like that was clear in my head, but I've talked to other people. I don't think everyone thought that was clear. And so they would, you know, with a little more time, I think they would like to explore. But again, we don't know what that price would come down to. I think we all agree it should be a lot less. So I would urge us to do the right thing from a health perspective.
Thank you. Representative Mazur.
While I appreciate the intent of this bill, I did make a note from the hearing that could this be handled by the oversight committee? There was a mention of that in the hearing. So taking this outside of where they recommended it go now. So that was, you know, that this stats tracking could be handled elsewhere and without the fiscal note that they brought to us. So I'm going to go ITL just because I think there's other ways of doing this, and this is not the way.
I will say that I sit on the Oversight Committee along with Representative Weber and Representative Woods. You're going to be on that too, aren't you? And I know Representative Murphy has been on there in the past. If I'm a member of this committee, I'm the vice chairman of the committee. Chairman Mark Pearson, who's also on Children and Family Law, he's the chairman of that committee. We do hear updates every month. We meet the last Friday of every month. We hear about updates on new system design. We hear updates on Medicaid Medicaid dental program and numerous other things. So this is something that could possibly be addressed in that manner. I don't set the agenda for that committee. The chairman does, obviously, but we do certainly handle other regular updates. Representative Nagel.
Yeah, and if you do it that way, you don't need a statute to do it. It's a departmental thing, and that it solves the problem with.
I mean, if we were to ask the commissioner or any or Henry Lippman or whoever, Henry Lippman is state Medicaid director, whoever, they've been very accommodating, and again, that's the purpose of the Oversight Committee. Representative Woods.
Yeah, I'm just going to, I think, Bill, on what you just said in terms of having the Oversight Committee. I've forgotten 4 years ago or something like that, there was a big push. I think Representative Edwards was heading that movement to completely redo just this issue, the data systems and their interaction, because they were so disparate and they couldn't talk to one another. And I've forgotten the details, but there was a committee established just to look at databases, and not just the databases, but security and making sure they wouldn't be hacked, like some of the other things we hear about. And so I think to ask that question at the Oversight Committee would be the way I would think we should go with this. The study itself is not providing a treatment. And at the moment, we really can't provide any prevention because we don't have the data. So the data, but this, I made a note to myself, fiscal note is totally out of whack. I just didn't quite admittedly, the data has to be fairly robust because the data, we don't know where people came from. People come to New Hampshire to retire. Did they get their exposure in Texas? So it does have to be fairly robust in the sense of very detailed. So I can see where it's not just a matter of, oh, you have ALS, fine, check the box, thank you very much. No, we're all done. It is more robust than that, but still, this was way out of whack. But it would also seem that interfacing with Dr. Stummel, when I actually had a bill 5 years ago, which I pulled just because of secondary issues, and to coordinate with Dr. Stummel and almost be a repository for his data rather than generating any new data. And I think that's something else that the Oversight Committee would have the flexibility to look at. So I'm going to vote ITL with the hope that our Vice Chair of the Oversight Committee can get it on the agenda.
I will definitely talk to the chairman about that. Representative Nagel.
I'm sorry for throwing one more thing in, but the other big problem that I had with this bill was that it's being referred to as a critical health problem, and I don't think we ever fully really defined what a critical health problem means, and something that affects 66 people in the state. I think it's a big step to refer to it in that particular statute. And one more thing, Dr. Stummel and I we're on the Rare Disease Commission together, and there's not definitely a clear association with cyanobacteria. It's a theory of his. He believes that environmental exposure is may play a significant role. He's very interested in veterans. There's a lot of veterans data on exposure to the things that they get exposed to. So he's trying to prove a theory. It's not that the theory is tied in stone yet. So that's why they want the data so that they can prove association.
Representative Lamontagne.
Well, to Representative Nagel's point, though, I think the only by having a registry where you can first make sure it's not the same patient being counted in Vermont and Massachusetts. It's not just about collecting the numbers, and it's being able to go back, because yes, maybe you would disprove that it's cyanobacteria, but you might find something else only by having the registry. I can't believe that anyone who is diagnosed with ALS would object to participating in the research to look at perhaps where they were exposed and what the cause might be. And I don't really understand how the oversight committee could possibly replace a registry.
Yeah, it's not a replacement.
But how is it solving the problem?
Start a different process. Yeah.
Anyway, Representative McKay.
Thank you, Mr. Chairman. I was the one the other day that made the fuss about the fact that it should have gone before the Oversight Committee. So I'm trying to figure out how to vote. And so I take it that if we vote ITL, that somebody on the Oversight Committee will ask for that to come before them.
And I will do that. And again, I don't know, I mean, there's a very specific statute that
Yeah.
addresses the mission.
You're allowed to do that.
I am.
Yes.
I can't promise anything, but I will explore that, and I will see if it's within our jurisdiction,
Yes.
and I can bring it up to the Medicaid director, because I see him monthly at those meetings, and
So therefore,
or whatever appropriate personnel there might be.
I'll vote ITL.
Anyone else? Representative Woods.
I think going with and it may be a dead end, but I think it's definitely the next avenue is to go through the Oversight Committee, because they have much more flexibility in terms of what we can or can't do, and I think would circumvent this big, financial thing, which I've had out of whack. And anyway, enough said.
Other questions, discussion, thoughts? Representative Palmer, did you have your hand up a moment ago? Or?
No, I was thinking of it, but now I'm convinced by Representative McKay and Representative Woods, so.
Okay, all right. If there's no one else, I'll ask the clerk to call the roll. The motion is ITL on HB 576 FN.
Rep. Mazer?
Yes.
Rep. McLean?
Yes.
Rep. Delamus? Yes. Rep. Kofalt?
Yes.
Rep. Nagel? Rep. Polizov?
Yes.
Burke votes yes. Rep. Markell?
Yes.
Rep. McGrath?
Yes.
Rep. Siebert?
Yes.
Rep. McKay?
Yes.
Rep. Woods? Rep. Palmer?
Yes.
Rep. Tellez?
No.
Rep. Lamontagne?
No.
Rep. Lucas?
Yes.
Rep. McDonald?
Yes.
Vote is 15-2. Motion passes.
Is consent appropriate, Representative Lamontagne? Okay.
Is it? I didn't
Was that
hear.
a yes or?
Yes. Consent, no objection to consent. All right, those are the only bills that we had planned to exec today. So that concludes our business. Anything else? Any other questions before we adjourn until next Wednesday? Hearing none, we stand adjourned.
Am I the majority?